come on stage. Dr. Divya.
Actually, sir, ওদের কে কি আগে বলা হয়েছিল 6+2
এই ইয়ে যে কি বলছে হয়ে গেল হ্যাঁ জিজ্ঞেস করে রাখুন
সুদীপ স্যার
আচ্ছা 6+2 করে দে হ্যাঁ
The timing is 6+2, okay?
Hello. What? May I start, ma'am? Very good morning to all judges. My topic for today is pediatric sleep disorders. It is a cross-sectional observational study. Now sleep, we all know how important sleep is in our lives. However, the lack of thereof is often escapes our eye. These are the common signs and symptoms of sleep disorders which we see in our daily practice. It can be difficulty in falling asleep, mental disorders, irregular breathing, so on and so forth. There can be decreased in quality or quantity of sleep. Now, sleep disorders in children is a very complex topic. However, ICSD-3 classifies the issues in this manner, in the following way. And sleep problems in children, what do we deal with? We can see children who have sleep apnea, parasomnias, and limb movements. These are the various ways in which insomnia can come to us, along with the neurotransmitters, and the history is thereof. It's not coming. So, in a way, we can say that in insomnia, there is difficulty in sleep problems, which if lasts for more than 3 times a week and for more than 3 months, then we can call it as insomnia. Coming to pediatric OSAs, this is the criteria for OSA, and few risk factors include obesity, adenotonsillar hypertrophy, craniofacial anomalies, and as such. Insufficient sleep, increased sleep drive during daytime, and disturbed sleep lead to hypersomnolence or excessive daytime sleepiness. Few parasomnias which we see in children are head banging, sleep starts, head rolling, and sleep terrors. We had checked the net for the previous studies. Most of the studies have been done on Western kids and not on healthy Indian children. However, the studies which have been done give us a prevalence of about 20 to 30%. So we knew that there was a gap in the prevalence pattern of sleep disorders and the common issues with it. So this gave rise to a research question: is sleep disorder common among apparently healthy Indian children? Our objective was to estimate the prevalence of sleep disorder in children aged 3 to 14 years using Bear screening tool, and to see the profile of sleep disorders using the PSQ and Epworth scale, and then to compare the sleep hygiene practices among children screened positive and negative by the Bear screening tool. These were the methods. Children who were eligible were taken consent from, and the Bears was applied to them. And in both Bears positive and negative, there is a tool which is the children report of sleep hygiene which was applied, and then who had tested positive with Bears, we had further tried to pinpoint the type of sleep disorder with the help of PSQ and ESS. Now I'll quickly run through the tools. Bears is an easy tool which is well known widely, and it gives age-wise questions for various age group. Coming to CRSP, here the insight of children is obtained, which may go unnoticed. Here, the higher the score, the worse is the sleep hygiene outcome. PSQ and ESS combined gave us a way to describe the various sleep disorders. Coming to the data was analyzed using SPSS 22. Coming to the results, we have found that most of our children were male, with the mean age group was about around 7 years. Most of our children were in the preschool age group, and the prevalence was found at 29.2%, which is in line with the previous studies done on the Western population as well. Further results, those who had answered positive were found. The most common complaint was actually snoring, and the activity before bedtime was found to be laxing the most. Parasomnia was the most common complaint for those who had tested Bears positive, and when we had applied the PSQ and the ESS, most common was the restless sleep. However, when we had compared the following hygiene practices with the Bears positive negative, statistically significant p-value was not there. So about 1 in 3 children have an underlying sleep disorder, and we had seen about 2/3 with a better sleep hygiene were found to have no sleep disorder, which is those who had a score less than 20 on sleep hygiene were screened negative by Bears. The key sleep hygiene practices were screen time, and the environment in which the child was sleeping, and the activity before bedtime. In conclusion, I would like to say that sleep disorders are fairly common in our practice, and there are various types and the way they are seen as based on BMI and lifestyle factors. Improving the sleep hygiene is a multifaceted approach, and there is a lot of scope for the future research. Thank you. Ma'am. Sir, it was done by me only, sir, by myself.
Okay, thank you. Nice presentation.
Can you explain what sleep hygiene is?
Yes, ma'am. It's basically the sleep, various practices which we do in our day-to-day life, which are a part of sleep hygiene. For example, daily physical activity, taking a bath before bedtime, trying to limit the screen time, the amount we spend using mobile phones, video games. For children, those are common. If they are reading books or not, if they're listening to music while they're sleeping, if there is any other member who is causing a ruckus, maybe the TV is going on, those are things of poor hygiene.
So how did you assess those parts?
Actually, ma'am, as I have shown, there is a questionnaire. However, that questionnaire is not really suited for our Indian scenario. In those, there were questions which were part of good hygiene practices and bad hygiene practices. So those who were bad, so the entire concept was the higher the score, the worse is the hygiene outcome. The entire score was about 40. There were around 10 questions. So each was scored from 0 to 4. In the way of scoring, it was mentioned that you have to say how many times you do it in a week. If it was most frequent, then it was scored 4 if it's a bad hygiene practice. Similarly, if it's a good hygiene practice and the child hardly does it, then again it was given a higher score because he's not doing the right things. And it was found that those who have done in a better way, those who are maybe going physically active, are reading books before bedtime, hardly use phone, their parents don't allow that much screen time, they have actually not had any sleep problems in the Bear screening tool. They were tested negative.
Wide range of age, right?
Yes, ma'am.
What was the age range?
The age group was total 3 to 14. However, since the CRSP is a self-report and the child that lower age cannot really speak for themselves, for the CRSP we have taken the age group from 8 to 14 years.
So you have administered two side of scales, one for hygiene, another for the. Have you any correlation between the identification of the sleep disorder and the hygiene?
Yes, sir. And the table which I had shown.
You have identified two scales.
Yes,
so
sir.
Is there any correlation between them? You identify the sleep disorders.
Yes, sir.
And you want to specify the hygiene practice.
Yes, sir.
Is there any correlation or not?
The data which we have obtained as of now, the p-value is not less than 0.05. The reason could be that in the CRSP they are saying that how frequently it is done, but we are not saying that how much time how much time the child is using in that time. For example, a child may use only 5 minutes of phone and then sleep off, but someone who's using about 1 hour or so or more, that person may actually have a sleep disorder, which can't be assessed with this scale. We will need further scales to actually classify that how much time is being used to for all those sleep hygiene practices.
Your scale is okay, the efforts and okay,
Yes.
but sleep hygiene is
Yes.
not suited totally for our population.
Yes, sir, that is correct,
Because
sir.
these items are not done over
Yes,
here.
sir. Yes, sir.
So these has to be very much validated.
Yes. It is a valid scale in Western population, but yes, those questions are not really for our Indian population. We'll have to find new scales. Thank you, ma'am.
Next participant, Dr. Debashish Maiti.
So good morning, my respected faculties and the delegates. Today I will be presenting 3 cases on focal cerebral arteriopathy. The first case is a 13-year-old girl who presented with pneumonia and reticulated rashes all over the trunk and extremities with arthralgia involving the small joints symmetrically. The case worsened on day 5 with right-sided hemiparesis and ipsilateral facial palsy with Babinski sign being positive on the same side. The power grading was 3/5 on the right-sided limbs and there were no eye symptoms. The respiratory status deteriorated on day 6 and there was type 2 respiratory failure. The patient was mechanically ventilated. Blood parameters came out to be having normocytic normochromic anemia and leukopenia, along with there is slight elevation in the transaminase level. The MR angio shows there is narrowing at the M1 segment of the left MCA and there is diffusion restriction of the left internal capsule region. CSA biofire shows there is positive IgM B, parvovirus B19 biofire titer. The case was treated with aspirin, gastroprotection, and intravenous pulse methylprednisolone and tapering dose of oral prednisolone was given. The patient gradually improved and weaned off from mechanical ventilation, and the motor deficit subsequently improved within 3 months of the follow-up. The second case is a 9-year-old girl without any comorbidities, presented with febrile illness and blistering rashes. The neurological symptoms started to appear by second week in form of right-sided hemiparesis with focal motor seizures and dysarthria followed by unconsciousness. She had cellular pleocytosis in her CSF, and the MR findings were the left MCA territory showing narrowing at the M1 segment with poor distal flow, resulting in the diffusion restriction in the left frontoparietal and the left gangliocapsular region. This patient also came positive to be suffering from varicella, and the treatment was same like before, but here in this case, acyclovir for 14 days were added. Gradual improvement in the clinical symptoms was noticed, and radiological normalcy was achieved 3 months after the initial presentation. The case 3 is a 12-year-old boy who had fever, intense headache, and diplopia on either side with external ophthalmoplegia with ataxia and features of raised intracranial pressure, had an acute brainstem infarction with narrowing of the P1 segment of the posterior cerebral artery. The CSF study was normal in this case, but his serum and CSF HSV DNA PCR was positive. This patient was treated with dual antiplatelet with osmotherapy and other treatments like IV methylprednisolone followed by oral steroids and acyclovir was given. The outcome was not that good as like the previous cases. The residual third nerve palsy persisted on the left side, but there was disappearance of the symptom, radiological abnormalities at the 3rd month of the follow-up. Now, focal cerebral arteriopathy is an acute and monophasic clinical entity of the arterial ischemic stroke primarily affecting the children and adolescents, which has been coined from the term that is transient cerebral arteriopathy. It was earlier known as transient cerebral arteriopathy, and in 2009 it was named FCA, which typically involves affects the school-going children, and there is equal gender predilection, the most important risk factor being an upper respiratory tract infection primarily. The complete or near complete recovery is noticed in up to 40% of the cases, with mortality rates ranging from 0 to 28%. 1 in 4 cases recur, and 1 in 4 patients of the atrial ischemic strokes are due to focal cerebral arteriopathy. FCA basically targets the distal parts of the ICA and the proximal segment of the MCA and the anterocerebral artery. Mostly the anterior circulations are affected, but in 25% cases, vertebrobasilar arteries are also seen to be affected. There are 3 types of FCA. The first one is inflammatory type, the second one is dissection type, and the third one is undetermined type. In inflammatory type, the causes are mostly viral causes, that is varicella, herpes, COVID, and parvovirus B19. And arterial dissection is usually seen after trauma, but in case of children, it can be non-traumatic also. It involves mainly the cervical segments of the arteries. The radiological markers of FCA, in inflammatory type, the most common MR angio finding is a small lenticular striate infarct, which is seen in 75% of the cases. But the most pathognomonic marker is banded appearance from the M1 segment of the MCA, which is seen in less than 25% of the cases. The dissection type mostly involves the cervical arteries, but intracranial dissection is more common in the children than in adults. When it involves the supraclinoid ICA territories, along with the formation of the collaterals, then we have to always think for an unilateral Moore disease. There is a question whether MR angio and DSA, whichever is applicable and whichever is more good for this patient. DSA is definitely gold standard, but the procedural risk always outweighs its benefit. And the MRI and MR angio is non-invasive and uses no radiation. And by time of flight sequence of the MR angio, the post-contrast enhancement can point towards FCA dissection when it is of eccentric type, and in inflammatory type, it is mostly concentric type. The disease severity correlates well with the high sensitive CRP and amyloid A. And the management before 2017 was only with antithrombotics like aspirin and the supportive care. But after the initiation of the PASTA trial, the results when came out, this Swiss Australian study, it showed that the steroid and the antithrombotic group had better performance in terms of the cognitive and the behavioral domain of the pediatric stroke outcome measure scales. And almost there is a reversal of the stenosis in this CA2, that is corticosteroid and the antithrombotic groups. Thus, it was postulated that maybe steroids are modulating the inflammatory cascade, which is limiting the FCA progression. Now, which steroids are to be used? That was a question that has been answered in the FOCUS trial. It involves incorporating methylprednisolone for 3 days in a pulse therapy and prednisolone for 4 weeks in a tapering dose.
Exceeded your time. You crossed your time.
Yes, ma'am.
Thank you. Nice presentation. In the first case, how will you explain the progression of a stroke despite it is an anterior circulation stroke? It progressed and resulted into the ventilator requirement.
Sorry, sir. In the first case, well, in the parvovirus B19 has some specific antigens. Basically, these are non-specific, non-structural antigens which have the potential towards the endothelial damage, which can cause the vasculopathy. And this can cause this small vessel or the lenticular striate branch, the M1 branch of the MCA may be the most commonly involved branch in the intercerebral circulation. This vascular expansion can be that the endotoxemia that is occurring in case of the parvovirus. Parvovirus, basically this antigen is an RBC antigen which targets the endothelium of a basal wall. That could cause these type of things.
So why was double antiplatelets used?
It was because it was a posterior circulation stroke, along with there is feature of raised ICP. So there was definitely more edema, which is obstructing the fourth ventricle. And in posterior circulation stroke, we always try to give double antiplatelet if there is no contraindications.
Does double antiplatelet diminish the edema? So why you're saying that because of the edema?
No, along with steroids, it was given
and also double platelet in pediatrics.
Double antiplatelet has been given considering it is a posterior circulation stroke, sir. Maybe it is a basilar artery which is mostly involved, and the P1 segment of the PC was definitely involved in this case, as shown in the MR angio. Osmotherapy took care of the raised ICP. The steroids.
How long did you give the osmotherapy?
Yes, sir.
How many days you have given?
For initial 3 days, we used mannitol, and followed by these, we used 3% NaCl.
So this is a case series, right?
Yes, sir.
So what kind of a study design is a case series?
This is a basically cross-sectional study case series.
I don't agree with you. Anyway, moving on. What was all these aspects of treatment as standard care, right? So what was unique about this case series that you thought it would, be worth presenting?
The
What were you trying
uniqueness, yes, madam. The uniqueness is in pediatric stroke. Usually, we just limit our treatment. Most of the cases, may not be in all the cases. We just limit our treatment giving antiplatelet, ischemic stroke. I'm talking about supportive cares and the aspirin or the clopidogrel. Basically, aspirin is more studied in case of pediatric strokes. But here, in this type of strokes, basically we need steroid. So these pulse methylprednisolone for 3 days and 4 weeks of oral prednisolone in tapering doses have to be given to keep it limited to FCA. Otherwise, it may progress. It is a monophasic illness, no doubt, and unilateral affection of the vessels are definitely there. But use of steroids is highlighted here, that we should be liberal to the use of steroids in case where there is suspicion of focal cerebral arteriopathy. Means whenever it is affecting the anterior circulation and the M1 segment of the MCA, which I have shown that in most of the cases, like 75% of the cases, it is just a small lenticular striate, in fact, which is getting involved in this pediatric stroke. So we just...
I think we'll stop here because we're exceeding the time. Thank you so much.
Thank you.
Next participant, Dr. Rajdeep.
So good morning, everyone. Myself, Dr. Rajdeep, and I am going to present a case series on CNS autoimmunity in childhood. So the emerging paradigm of the childhood autoimmune neurological disorder has exploded in recent times due to the reliable diagnostic methods and their ease of availability, well-defined diagnostic criteria, and the universal awareness about this disorder. The most important aspect of this disorder is a considerable recovery in response to the early targeted immunotherapy. In this series, 3 such cases and their therapeutic management in our institution, which are often a bump in the smooth ride called childhood, is being demonstrated. So in my first case, 4 years, 8 months old child, developmentally normal, presented with the 3 days of non-remitting fever, followed by the vomiting and convulsions, which was GTCS in nature, 2 to 3 times per day, that lasting for the 2 to 3 minutes, and without any significant past and the family history. The child presented in a tachypneic condition. She was irritable, confused. GCS was 10/15. Pupils are bilaterally constricted. Meningeal signs was absent, and all 4 limbs have the normal tone, power, and the reflexes. So after shifting the PICU, we have taken the all neuroprotective measures, as well as we started the first line of anti-seizure medication. But due to the ongoing convulsive episodes, we have added the IV anesthetics. All initial investigations came as within the normal limit, and the bedside USG, optic nerve sheath diameter, was normal. On day 2, the lumbar puncture was done, and the CSF cell count was within the normal limit, whereas the fasting blood sugar level was, blood ammonia level was normal. And MRI brain was done, and flare cut section showing the mild prominent temporal horn bilaterally. Due to the suspicion of the underlying autoimmune pathology, we have started the IV methylprednisolone on day 4 after sending the CSF autoimmune panel, and CSF biofire and CBNAT came as negative. But due to the persistent focal seizures followed by the secondary generalized seizures, we have started the phenobarbital infusion as well as the injection lacosamide added. But after seeing the negative report of the autoimmune encephalitis panel, we have given the first dose of IV immunoglobulin on day 8. And on day 10, we have given the second dose of immunoglobulin at 1 gram per kg, and we have successfully extubated the child. The bedside EEG shows the presence of the extensive delta brush suggestive of the encephalitis. But due to the persistent abnormal movement with the frequent focal convulsions and the orofacial dyskinesia, we have added the oxcarbazepine as well as the tablet tetrabenazine and risperidone. By day 25, the child became afebrile, and we have given the first dose of the rituximab on day 28, and we have repeated the MRI on day 32, which shows the diffuse focal atrophy. So, but we discharged this child on day 45 with the help of multiple anti-seizure medication. So it was diagnosed as a case of the febrile infection-related epilepsy syndrome. In my second case, a 4-year-old developmentally normal girl presented with a history of the undocumented fever for 8 days, followed by vomiting, altered sensorium, and the focal seizures, followed by 3 episodes of the GTCS persisting more than 5 minutes with acute onset left-sided weakness. She has a previous history of the GTCS at 1.5 years of age. The child presented at year in a gasping conditions with the poor circulatory volume. She was drowsy, GCS was 7/15. Pupils are bilaterally sluggish, and on neurological examination there was increased tone, power was 1/5, and brisk reflexes involving both upper and lower limbs of the left side. After doing the IV access and the IV intubation, we have given the stat dose of the midazolam to abort the ongoing status and shift the child in the PICU. But after getting admitted in the PICU, we have started the first line anti-medication, as well as we have added the IV anesthetics due to the ongoing convulsive seizure activity. And all initial investigation came as negative except the raised CRP and the high TLC count. She required the inotrope support for the hemodynamic instability. On day 2, the lumbar puncture report was normal, and on day 4, the serum autoimmune panel APLA profile came as negative, whereas the ferritin and interleukin-6 was raised. MRI brain was done on the day 6, and FLAIR cut section shows the hyperintensities in the whole right hemisphere with the midline shift, whereas the MR angiography was within the normal limit. EEG shows the diffuse spikes burst followed by the biphasic or the triphasic diffuse slow waves. So after seeing the initial presentation as well as the neuroimaging findings, we diagnosed it as an acute stage of the hemiconvulsion hemiplegia epilepsy syndrome. We have the seizure frequency starts to reduce on day 10 onwards, and we have extubated the child on day 15. So this syndrome should be considered in children with refractory or the super refractory status epilepticus and hemiparesis, and can be a presenting features of the pediatric stroke. In my case, 3 years old male child, developmentally normal, presented with sudden onset of jerky movement since last 6 months. It involves the left wrist followed by the left upper limb, left side of the face, but and left lower limb and trunk of the same side. He was hemodynamically stable on presentation, and neurological examination shows decreased tone, power, as well as deep tendon reflex in both upper and lower limbs. All initial investigation came was normal, including the CSF report. We have done the MRI. MRI shows that T2 axial cut section hyperintensities in the right sided pre and post central gyral area, and the T1 showing the focal atrophy in the right parieto-occipital region. And EEG shows abnormal background with asymmetry, and the right hemisphere shows high amplitude slow waves. It was a case of the epilepsia partially discontinued due to the underlying Rasmussen encephalitis. After attempting with multiple anti-epileptic drugs due to intractable seizure, we have added the IV methylprednisolone followed by IV immunoglobulin, and after IV immunoglobulin administration, the frequency of the jerking decreased. So, though neuroimaging characteristic and the serological test confirms its disorders diagnosis, it's essential to suspect them clinically and start management before the reports are...
You've exceeded the time.
Okay, ma'am.
Nice presentation. Do you think serum biomarkers, inflammatory biomarkers basically will be helpful in such cases?
Sir, in such cases, the inflammatory, generally the inflammatory biomarkers has no role, but it, in my case too, that is the HHE syndrome, there is, there is some evidence of increased or raised titer of the interleukin-6.
In the first case, this sort of presentation, how will you specify fires?
Sir, as per
on the clinical criteria and all.
Yes, sir. As per the ILE recent guidelines, the age criteria for the fires is 2 to 17 years, and this child was 4 years and 8 months old. And there should be a febrile episodes before the 2 weeks to 24 hours prior of the onset of the refractory status epilepticus, and it was the refractory super refractory status epilepticus also. And there in the recent criteria, the fever the febrile episode need not be present at the initial during the onset of the status epilepticus, and the CSF report should be normal. It will be it should have the two stages. The acute stage, there is a fever, the febrile episodes followed by the status epilepticus, and in case of the chronic stage, there is the multiple drug-resistant epilepsy, and followed by. So
in the next case, second case, how common do HHE present as acutely as your?
Sir, as per the Chauvel et al. Literature review, it is 1.64% in the 10,000 children. Though the previous.
Presenting as acutely.
Sir, mainly the 50 to 60% of patients present.
Again, my similar question, what kind of a study design would this case
Ma'am, as it is a case series, so it is an individual descriptive study.
Okay. And you've heard of stroke guidelines and consort guidelines. What guidelines will you use for a case series?
Ma'am, please, can you repeat this question?
Have you heard of the stroke guidelines
Yes.
and the consort guidelines?
Yes, ma'am.
So which guidelines will be used when you are reporting or describing
Ma'am,
a
consort
case
guideline.
series? Can we have the next student? Thank you.
Thank you so much.
Next participant, Dr. Gajalakshmi.
Good morning, everybody. I'm Dr. Gajalakshmi, junior resident from Institute of Childhood. Today, my topic of presentation is atypical Guillain-Barré syndrome beyond the ordinary. So Guillain-Barré syndrome is an acute immune-mediated demyelinating polyneuropathy. It occurs due to the cross-reactivity between the viral and the neuronal antigens due to a phenomenon known as molecular mimicry. The hallmark of GB syndrome is ascending paralysis with areflexia. The diagnosis is mainly based on the clinical assessment. However, there are a number of GB variants with uncommon presentation. So the classical teaching is that when some of the features are present, we usually think of differential diagnosis other than that of GB syndrome. So some of these atypical presentations are like descending paralysis, ptosis on initial presentation, unilateral facial nerve palsy, involvement of extraocular muscles, CNS involvement in the form of altered sensorium or positive meningeal signs, and persistent bladder involvement at presentation. So here I present a case series of Guillain-Barré syndrome with atypical presentation that clustered in our hospital in November 23 to March 24. We had a total number of 10 cases, which was slightly male predominant, and we found that around 80% of the patients had preceding respiratory or GI infection. So initially we had a confusion regarding the diagnosis, so a detailed history and thorough clinical examination along with the electrodiagnostic studies and imaging helped us to come to a final diagnosis of GB syndrome. This indicative of variability in expression of GB syndrome in pediatric population. So the features suggestive of GB syndrome on CSF studies is albuminocytological dissociation. Typically the cell count is less than 10 cells and CSF protein is twice than that of the normal range. And MRI changes like thickening of nerve root, post-contrast enhancement of cardiac vena nerve roots are seen, and NCV changes like demyelination, decreased conduction velocity, increased F-wave latency, and absent H reflex are seen. So in my case series, we had 4 patients who presented with ptosis as initial presentation. There was descending paralysis in 50% of the patients. 2 patients had recurrent lung collapse as their presentation. Persistent bladder involvement was seen in 30% of the patients. And we saw external ophthalmoplegia in 4 patients. Unilateral facial nerve involvement was seen in 2 patients. And poor sensorium in the form of positive meningeal signs was seen in 20% of the patients. So because of these atypical presentations, we had to go ahead with the CSF, MRI, and NCV studies. CSF was inconclusive in most of the cases, but only 1 patient had albuminocytological dissociation. MRI was positive in 90% of the cases, and NCV was positive in all the cases. So these are few pictures from my case series. We can see that there is bilateral ptosis in the first 2 pictures. There was recurrent lung collapse in the third picture, and the last 2 pictures are post-contrast enhancement of cardiac vena. So to sum up, out of 10 cases, we saw that there was poor sensorium in 20%, neck stiffness in 20% of the cases, cough and persistent lung collapse was seen in 20%, persistent bladder involvement in the form of urinary retention was seen in 30% of the patient, unilateral facial nerve palsy was seen in 20% of the patients, ptosis and descending motor nerve paralysis was seen in 50% of the patients. 40% of the patients did not have gross limb weakness or weakness as the initial presentation, but they developed weakness during the course of the hospital stay. And 60% of the patients had autonomic dysfunction as well. So all the patients were managed with IVIG and they responded within an average time of 7 days. One patient required plasmapheresis and 9 out of 10 patients were discharged. One patient expired due to persistent respiratory weakness with hospital-acquired sepsis. So I would like to conclude my topic saying that atypical presentation in GB syndrome is not very uncommon and this may delay the diagnosis and treatment. Therefore, a high index of suspicion is required. And this again emphasizes the importance of history taking and clinical examination. And in such atypical cases comes the role of MRI and electrodiagnostic studies in diagnosing GB syndrome. So finally, I would say that these case series were helpful in including GB as a differential, promoting early diagnosis and treatment. Thank you.
Thank you. Finishing in time and case series in a systematic manner. The question is, how will you explain impaired sensorium in child with GBS, number one? Number two, how did you assess autonomic dysfunction?
I'm sorry, sir, I didn't get the first question.
How will you explain impaired sensorium in a child with GBS?
Hemiparesis.
Altered sensorium.
Sir, because of the disruption in the blood-brain barrier, there might be involvement of the cortex.
Why there will be disruption in blood-brain barrier? And can you assess autonomic dysfunction objectively?
Sir, autonomic dysfunction, we actually monitored, when we monitored the vitals regularly, we found that there was, in some patients, there was persistent tachycardia and labile blood pressure. And 2 patients had constipation and urinary retention, sir.
What are the bedside identification of autonomic dysfunction to check in GBS?
Sorry,
bedside parameters you can check to find out autonomic dysfunction in a case of GBS.
Sir, increased sweating, tachycardia and...
Objective, this is not subjective. Standing, sleeping, pulse rate, standing on sitting, BP, this sort of thing.
Postural
What are the other
hypotension.
things like that? These are the objective. Next, you find out on the different atypical presentation, why didn't you classify within the group of the GB syndrome? That means AIDP, AMAN, AMSAN, then you would have found that majority are falling within the spectrum, not outside the spectrum, except for the finding of this disordered sensorium, which should not be there. It may be due to a sepsis or like that. You could have point out in this group the variety, then you can find out majority are within the normal limits. And what are the incidence of MRI findings in GBS? Incidence of occurrence of MRI findings in childhood GBS?
Sir, MRI findings is usually positive in first 2 days. So it helps as it complements our diagnosis of GB syndrome. Sir, NCS usually like towards the end of the first week, it might become positive, but most cases will be positive towards the end of second week.
So you had 10 cases.
Yes,
What was the median duration of time in terms of their course of illness when they presented to you? Because that would also make a difference in the clinical presentation. That was not given in the table.
Ma'am, my median presentation was around 10 days, ma'am. They had a preceding infection 10 days before and then they presented to us.
What was the range?
Ma'am, range was around 8 to 15 days, ma'am.
Because again, extending from what Sir asked, most of these presentations are not unique. So what was the purpose of presenting this case series and the clinical features of GBS, which is something pretty commonplace?
Ma'am, because in some cases we saw that there was bladder and bowel involvement as an initial presentation. In GB syndrome, it usually presents in towards the end and it is usually transient. And when facial nerve is involved, it is bilateral involvement, but in 2 of our cases, we saw there was unilateral facial nerve palsy. And one more, usually the poor sensorium and positive meningeal signs are very atypical in case of GB syndrome. But we had such cases, and descending paralysis was also seen in few of our cases.
So, in case of cauda equina involvement, as I've told, what investigation you should check apart from other?
Sir, in one case we had done because it was post-varicella GB. Okay. Thank you.
So we'll have the next candidate. Thank you so much.
Our next participant, Dr. Trisha.
Good morning, respected judges and delegates. I am Trisha Roy Chaudhary, second year PGT, MD Pediatrics from CNMCH, here with my paper on Counting Sheep, Counting Dreams, Outwitting Epilepsy, One Snooze at a Time. Epilepsy is a complex neurological disease affecting more than 10 million children worldwide. Unlike adults, these children face serious challenges due to developing brains and growing bodies. Sleep disturbances are among the most prevalent comorbidities in these children, and sadly, the often overlooked ones as well, with the prevalence ranging from 45 to 95%. However, there is lack of sufficient data and studies to prove an intricate relationship between quality of study and sleep habits. My study has 2 aims. Number 1, to determine the association between quality of life and sleep habits in children with epilepsy, and number 2, to identify the predictors of quality of life and sleep habits. This is a cross-sectional study conducted over an 8-month period from November 23 to June 24 at Pediatric Outdoor and Indoor of CNMCH, consisting of 51 children with epilepsy aged 4 to 11 years selected by the conventional sampling technique who satisfied the ILAE criteria 2017, excluding children born less than 37 weeks with overt structural brain damage or cerebral palsy, with other confirmed physical and psychiatric diseases, and parents unable to understand Bengali. Now introducing our study tools. Number 1, the Children's Sleep Health Questionnaire, CSHQ, consisting of 5 parameters. They are bedtime, sleep behavior, waking during night, morning wakening, daytime sleepiness, each scored as 3, 2, and 1 against usually, sometimes, and rarely, respectively, with higher scores consistently indicating problem behavior. Our second tool being Quality of Life in Childhood Epilepsy Questionnaire, QOLCE, consisting of 4 domains of quality of life: cognitive, emotional, social, physical, each given a score of 0, 25, 50, 75, and 100 against each of the parameters shown in the slide. Higher scores indicate better well-being. These 2 questionnaires have been evaluated by the caregivers with our assistance against a recall of 1 week and 4 week for the Quality of Life Questionnaire and the Childhood Sleep Health Questionnaire, respectively. Now introducing our casting couch, our study variables: age, gender, quality of life score, and child sleep score. The data analysis for my paper has been done using the SPSS version 27 and descriptive statistics. Our study consisted of 22 girls and 29 boys, with 39 of them in the 4 to 8 years age group and 12 of them in the 8 to 11 years age group. More than 90% of them were compliant in the medications, with 60% on monotherapy. This shows the mean quality of life score, 70.1 plus minus 12, and the mean child sleep health score being 15.5 plus minus 5.7, as can be shown each parameters with their mean values. The Pearson correlation coefficient between the quality of life and the sleep habits being minus 0.85, which is a highly significant value, as can be shown from the calculation and the graph. Next, the correlation between each sleep parameter with each of the domains of quality of life has been beautifully shown in the graph depicted above. And as can be shown in the color coding, the sleep behavior has the maximum impact on each of the domains of quality of life. Next, for the predictors of sleep habits of quality of life, the linear regression analysis using the ANOVA model has calculated a significant predictive value of minus 0.85 with a significant p-value. Therefore, I can successfully infer that from my study, social domain was highly affected and cognitive domain was least affected in these children with epilepsy. There was a highly significant negative correlation between quality of life and sleep habits in children with epilepsy. The sleeping habits significantly predicted the quality of life in these children, and for every unit increase in quality of life score, the average sleep score decreases by minus 0.85. Sleep behavioral problems affected all the 4 domains of quality of life the most, followed by night awakening and daytime sleepiness. These are my study limitations. And therefore, I can successfully conclude that improved sleep quality was associated with better overall quality of life score. Addressing sleep disturbances in children, like proper sleep hygiene, cognitive behavioral therapy for insomnia, parental guidance regarding establishing proper bedtime schedules, medication compliances, and recognizing signs of sleep disorders do go a very long way in effective management of these children, and ensuring improved sleep quality may potentially contribute to better seizure management outcomes. These are the references for my study. Thank you.
Thank you, organized presentation. My question is, 2 factors influence quality of sleep in children with epilepsy. Number 1 is underlying etiology. For example, they have cerebral palsy or something else. Number 2, type of epilepsy. Have you looked at those 2 things?
Thank you, sir, for the question. Sir, as I've mentioned in the limitation for my study, that the compliance of medications and existing seizure or any comorbid conditions definitely do influence their sleep behavior. So this has been included as a study limitation. And while carrying out the study, I have, with each questionnaire, I have analyzed about the type of seizure medications they were on. So definitely they do count as a limitation for my study, along with the small sample size.
Your study is very good, but have you checked that the QALC and CHQ in Bengali validation, because you have told that you have excluded all patients without knowing Bengali?
Thank you, sir, for the question. Sir, actually, we have the neurology clinic in our pediatric ward, and when the caregivers come with their children, we hand one form to them, and we take time to explain each of the questions, since they do not understand English as well. And we explain to them each of the questions in Bengali, and we try to gain a response, and we sort of translate that into a response, and then we take that.
You have a better form with the translation of the Bengali. You have not validated, because its QALC is not validated in Bengali. You have even not without validation, have you translated it? And how can they understand? Because you are telling that they are all are excluded knowing Bengali. Why have you done that?
So we have done that because, sir, since each of the parameters, as we can see in the children's sleep score and the quality of life score, each of the parameters further have many other sub-questions. In fact, quality of life has 55 questions in total. So in case parents would not understand Bengali, it's difficult to translate and get an answer as well.
Okay, so I'm not very clear about this. So you have used 2 questionnaires. So you've used a combination of provider completed as well as parental completed questionnaires? Because you said you've explained each item and also you've asked them to also score the items? Because the methodology, like coming from what sir said, is suppose you had to translate it. There was a single interviewer who was doing it, or doing all the patients, or were there various interviewers, different interviewers?
No, ma'am. I carried out the study, and during each of the 51 children in my study,
So
I was
you
the
were
one
the single
present.
researcher?
Yes.
So did you translate all the questions so that it was like every single patient or parent was asked the same item in the same way
Yes.
in Bengali?
Yes, ma'am.
So what was the method that you used for translating your items? Which is the method that is recommended by standard protocol for such studies? Did you follow any standard protocol in translating it?
I did not follow any standard method in translating, ma'am. I just translated in local language.
And you said the sample size was 51. How did you arrive at that estimated sample size?
Ma'am, I had to calculate the from the P, to get a significant value, I had to get a,
Do you remember the parameters that you used?
ma'am, for the study, ma'am,
Do you remember the parameters that you used to arrive at that estimated sample size of 51?
yes, ma'am, one of them being the prevalence P into Q divided by
Prevalence of what?
prevalence of sleep disorders in children with epilepsy.
Okay. We can have the next student. Thank you
Thank
so
you, ma'am.
much. It was a
The
very
next
nice
participant, Dr. Nandita Munshi.
Hello. Good morning, respected judges and audience. I am Dr. Nandita Munshi, and I am going to present a case series on juvenile myasthenia gravis. As we all know, that myasthenia is a very uncommon disease in the adult, let it be in children, and in prepubertal age group, myasthenia gravis differs from the postpubertal age group in the fact that ocular-only myasthenia is more common in prepubertal age group, and also female to male ratio is altered in prepubertal age group. I will straight away go to my case series, and which are the cases presented in our department from 2022 to 24. The first case is of a 36-month-old female child who presented in our department with bilateral ptosis and diplopia for 1 month and progressive weakness, difficulty in squatting, and dysphagia for 10 days. In general examination, apart from ptosis, the child had overall decreased power in all 4 limbs. Deep tendon reflexes were within normal limits. Extraocular movement, muscle movement were decreased in all 4 quadrants. Gag reflex was diminished, and loss of neck control when holding head above examining surface. So, with a provisional diagnosis of myasthenia gravis and keeping in head the differentials like lip girdle myopathy, descending GB, SMA congenital myopathy, we went to neostigmine challenge test as hydrophonium was not available in our setup. So, the child improved dramatically after neostigmine challenge test, and anti-SCH receptor antibody was positive in this patient. Repeated nerve stimulation test showed decremental response in multiple nerves. The child was later started with oral pyridostigmine and corticosteroids. After improvement, the corticosteroid was tapered. The next case is of a 4-year-old male child presented with generalized weakness for 2 weeks and respiratory distress for 2 days. On examination, the child was on acute respiratory failure, and in CNS examination, though the tone was normal and power was somehow decreased in all 4 limbs, the deep tendon reflexes were diminished and gag reflex were also decreased. The child was shifted in PICU, mechanically ventilated, and after a stormy course in PICU, the child was finally extubated on day 5 and put on BiPAP. As the child couldn't be weaned from BiPAP support on day 8, and at this point of time, somewhat bilateral ptosis was also evident. Keeping in mind the previous CNS examination report, we suspected some neuromuscular condition. Later, anti-SAH receptor antibody came positive, and repetitive nerve stimulation tests also showed decremental effect. The child was started with IVIG, oral pyridostigmine, and corticosteroids, and discharged successfully from PICU on day 15 of admission. The third child is 39-month-old girl, presented with dysphagia and nasal intonation of voice for 5 days, and also had a history of bilateral ptosis for 10 days. Her CNS examination also showed decreased gag reflex and extraocular muscle movement restricted. Repeated nerve stimulation test consisted with neuromuscular junction disorder, but acetylcholine receptor antibody and mask antibody both were negative in this case. Also, I would like to mention that the child didn't respond on neostigmine challenge test. The last case is of a 23rd-month-old girl presented with bilateral fatigable ptosis for last 3 weeks. The CNS examination, apart from restricted extraocular muscle movement, was within normal limit. This child responded with neostigmine challenge test. Repetitive nerve stimulation test showed decremental effect on orbicularis oculi muscle only. Anti-SCH receptor antibody and anti-mask antibody both were negative in this case. Based on clinical suspicion, this child was started on oral pyridostigmine. So if we compare the 4 cases, the median age of the patient was 3 years with a slightly predisposition to the females. Initial presentation was ptosis in all the cases except the case 2, which presented with acute respiratory failure and needed mechanical ventilation. Anti-ACH receptor antibody was positive in the first 2 cases. Anti-MuSK antibody didn't show any positivity in any of the cases. Repetitive nerve stimulation test was positive in all the 4, and in the 4th case, it was only positive on orbicularis oculi muscle. The 3rd case didn't respond on neostigmine challenge test. All are started with pyridostigmine. Oral steroids were added in the first 2 cases. All responded dramatically with this first-line medication. If we compare our case series with one meta-analysis by Lin et al. And 2 other case series, we see somehow comparable results, but as our case had a very small number of population, so we can't draw any conclusions. Also, I would like to mention that none of these 4 cases showed any autoimmune features, and also CECT thorax was done in all 4 children, and thymic hyperplasia or thymoma was not evident in any of the reports. So in conclusion, I would like to say that myasthenia gravis in children can be of congenital myasthenia syndrome, juvenile myasthenia, or transient neonatal myasthenia cases. Antibody of SAH receptor antibody against SAH receptor is not always positive in children. Some of them shows antibody against mask, but also 15% of generalized and 50% of ocular myasthenia cases in children doesn't show any antibody at all. These are called double seronegative cases, and this picture shows a proposed algorithm of diagnosing double seronegative cases. This chart is obviously taken from Nelson 22nd edition, and this shows the detailed differentials which we should keep in mind before diagnosing any case as myasthenia. At last, I would want to say that even besides first-line treatments,
Yes, you can stop here, please.
Okay, sir.
So,
thank you.
Thank you. Interesting case series of young cases. So my question is, when such a young baby with antibodies are negative, how will you exclude congenital myasthenia?
Sir, actually, in cases where both the antibodies were negative, and in our setup, antibodies against LRP4, tyrosine, ryanodine, those are not available. And as the age group of the children were somehow around infantile, congenital myasthenia syndrome is difficult to rule out. Neonatal myasthenia is easy to rule out because neonatal myasthenia is a transient disorder, but congenital myasthenia syndrome without genetic testing is difficult to rule out, and some of the congenital myasthenia syndromes respond with oral pyridostigmine. So without genetic testing, congenital myasthenia gravis is difficult to rule out from juvenile myasthenia gravis if juvenile myasthenia gravis is seronegative in this age group.
In the 3rd case, as it has been all negative, the diagnostic tests.
Yes, sir.
Did the patient respond to pyridostigmine?
Yes, sir. All of the patients responded to pyridostigmine. The 3rd case...
What are the parameters? How you checked the response?
Sir, we didn't have any objective parameters, but with the improvement of ptosis and diplopia, and also the nasal intonation of voice decreased, dysphagia decreased, we used that only.
For the clinical estimation of myasthenia,
Yes,
when
sir.
the patient came, what was the objective clinical things you have checked regarding myasthenia?
Sir, the degree of ptosis and muscle weakness, muscle power.
Any single breath count?
Single breath count, yes, sir.
Any other thing? Diurnal variation of
Diurnal variation of ptosis, single breath count, yes, sir.
Are you aware that there are certain pediatric scales that are used for documenting the clinical response to pyridostigmine?
Can you, ma'am, please repeat the question again?
There are certain scales that are used to monitor the clinical signs and the progression.
Yes, sir. Like myasthenia gravis daily activity scoring, where we take breath, swallowing, and also the ability to combing, ability to
But
eat.
all your children were very young. They were all
Yes,
around
sir.
3.
And it is
So how
yes,
did you
madam.
do the breath holding for a 3-year-old?
Madam, actually it is very difficult to elicit single breath holding, but we can elicit degree of ptosis, we can elicit degree of daily activities, dysphagia, breathing, etc.
Because your duration of pyridostigmine would depend upon the clinical response, and your cessation would also depend upon that.
Yes, sir.
So did you make your own individualized kind of a format for that?
No, madam. As I said previously, that no structured or objective format was meant.
It's okay, thank you.
But we actually did it subjectively. No objective format was meant.
It's difficult. Thank you so much.
Thank you,
Do
ma'am.
you know power chatting? Power chatting?
Yes,
Power
sir.
chatting?
Yes, sir.
What is it?
We'll have the next last candidate, please. Dr. Bishwadip.
Hello. Start. Hello. So, a very good morning, members of the judges and members of the House. Myself, Dr. Bishwadip Das. Today, my topic of presentation is study of clinical epidemiological profile, imaging, and outcome of children admitted with autoimmune encephalitis and prediction of autoimmune-related epilepsy among them, a tertiary center study in Kolkata. Encephalopathy in children and adolescents is associated with a high rate of morbidity and mortality, and the differential diagnoses are diverse, including infectious, para-infectious, metabolic, genetic, traumatic, malignant, and toxic disorders. So careful observation, investigation, treatment often needed to be carried out simultaneously. On the other hand, antibody-mediated encephalopathies are conditions in which patients present with neurological syndromes usually associated with serum and/or CSF antibodies, and they preferentially affect children and younger adults. They are potentially fatal and severe. And autoimmune-related epilepsy, on the other hand, it comprises the 15 to 20% of the cryptogenic epilepsies, and a scoring system based on the clinical features and initial neurological assessment often predict the diagnosis of ARE and also the positive response following the immunotherapeutic agents. There are certain scoring systems. So our objective of our study was to find the clinical epidemiological profile, imaging, and outcome of children admitted with autoimmune encephalitis, and also to predict diagnosis and the management with immunotherapy of the autoimmune-related epilepsy among children with seizures. It was an observational prospective study and hospital-based study done over a period of 1.5 years between age 1 month to 12 years in pediatric ward and ICU of Calcutta National Medical College. A total 17 children included in our study. Out of them, 14 children diagnosed with ARE, and ARE comprises both acute symptomatic seizures secondary to autoimmune encephalitis and as well as autoimmune-associated epilepsy, and other differentials were excluded. Children admitted with features of acute onset less than or equal to 3 months of neurological and psychiatric symptoms, these listed here, were suspected to have autoimmune encephalitis. And CSF and blood serum for all patients sent for the autoimmune encephalitis panel, including the NMDR, voltage-gated potassium channel, AMPA1, AMPA2, CASPR2, LGI1, GABA-B1, GABA-B2, etc., and neuroimaging done. All demographic data were plotted analyzed with help of SPSS software, and those antibody came positive, termed as seropositive, that is definite autoimmune encephalitis, and negative were seronegative, that is probable autoimmune encephalitis. We used 2 scoring systems for ARE. One is antibody prevalence in epilepsy of unknown etiology, and right score, that is response to immunotherapy in epilepsy scoring, to predict ARE diagnosis and immunotherapy requirement respectively. So in our study we found that majority children presented in later half of the first decade, almost equal proportion of boys and girls, almost equal proportion of children affected from both rural and urban population, children belonging to all socioeconomic status groups. Most common clinical feature was altered sensorium, followed by seizures, and total CSF antibody present in 6 cases. 4 cases were NMDA receptor positive, 2 cases serum antibody positive, and 1 cases both serum and CSF antibody positive. Total seropositive cases ultimately was 7 out of 17, and more was seronegative cases, 10 out of 17, that was 59% cases. And maximum cases, there was normal MRI findings, and other cases, 8 cases, there were different types of MRI findings. And normal EEG findings were present in 41% cases, and there was other EEG findings like background rhythm slow or epileptic discharge in rest cases. So ultimately 17 patients, all of them received steroid as immunotherapy first line agent, IV methylprednisolone pulse doses. There was no improvement in 10 patients who received IVIG. There was no improvement again in 5 patients who received second line agent as rituximab. There was no improvement again in 2 patients who received cyclophosphamide, and no improvement in 1 patient who ultimately expired. So ultimately, successfully discharged without disability with modified Rankine scale of 0 in 9 patients, that was 53%, and mild, moderate to severe disability in 5 and 1 cases respectively, and death occurred in 1 case. So, and this is the quick comparison between seropositive and seronegative autoimmune encephalitis group. Only 2 findings we got to be p-value was statistically significant of less than 0.05. One was abnormal MRI, and another was second line agent requirement. So in more cases of seronegative autoimmune encephalitis group required was abnormal MRI findings were present and required second line agents. And also AP score and RIT scores, their sensitivity to predict the autoimmune encephalitis, ARD diagnosis, and also the immunotherapy requirement among the ARD cases was the statistically significant. And these were the review of literature. Mostly adult study, and some studies, pediatric studies are also now being done. And they're showing AP score and RIT scores. They have high sensitivity and specificity to diagnose, and also to predict the immunotherapy requirement, and also the antibodies required to do the diagnosis. So we can conclude that autoimmune encephalitis is a potentially fatal disease with significant morbidity and mortality. In our study, we have found abnormal MRI findings and response to second-line immunotherapy to be statistically significant, and AP and RIT score can predict diagnosis and response to immunotherapy respectively in patients with ARD with high sensitivity. However, we recommend people to do further studies in this field with more sample size. Limitations, we had for certain limitations like it was single center, tertiary center-based study, small sample size, short duration study, some antibodies could not be tested, and specificity of AP and RIT scores also could not be tested. And long-term follow-up was not mentioned in our study. These are the references. Thank you.
Okay, thank you. Interesting data. So my question is, how will you differentiate autoimmune epilepsy versus relapses of autoimmune encephalitis?
Sir, all of these data, these are taken during the course of admission. So basically, this was an unidirectional management guideline. So basically, first line we gave steroid, then we gave IVIG. If no response, we moved to the second line agent. So all cases invariably was, if there was no improvement, there was second line. So all cases, this was a unidirectional. So we did not consider relapse in this case.
How can you diagnose the seronegative? What are the guidelines of diagnosing seronegative autoimmune encephalitis in your case?
Yes, sir. Basically, there was the criteria is more or less same, except for the antibody positive or negative part. The other things are basically same for both seropositive and seronegative. There are the clinical features. It should be acute onset, less than or equal to 3 months. There should be clinical features like neurological and or psychiatric symptoms. Of those whole 7 to 8 symptoms, 2 or more should be present, like cognitive difficulties, focal neurological deficits, autonomic disturbances, and seizures, and all that. And also there are MRI and CSF findings, or if possible, brain biopsy findings. 1 or more should be present. So features, criteria is same.
MRI findings we have not found much in the autoimmune.
Yes, sir. We have found to be significant for seronegative encephalitis group.
And in the right score and other scores
AP
are basically for autoimmune epilepsy.
Yes, sir.
So how can you differentiate autoimmune epilepsy in a setting of autoimmune encephalitis?
Sir, autoimmune epilepsy is nothing, the seizures occurring in autoimmune encephalitis, if other causes excluded, is nothing but the autoimmune related epilepsy only.
Could you elaborate upon the right score? What were the parameters,
Yes, sir.
the interpretation
Yes,
and
ma'am,
scoring?
AP score is antibody prevalence in epilepsy of unknown origin, and right score is response to immunotherapy in epilepsy. Basically, AP scores, there are 6 criteria total. Most of them are clinical, and some MRI findings and EG findings and all that. So if we include with them some antibodies positive and requirement of immunotherapy in last 6 months, so it becomes right score. So AP score plus 2 other criteria is right score. And total score for AP score is 15, and total score for right score is 19. And if 4 or more than or 4 score is there in AP score, it is sensitive, it is highly sensitive. And for right score, if it is more than or equal to 7, it is highly sensitive.
So what is the sensitivity and specificity of right score, the exact in figures or roundabout?
It was more than 80% in our case. And right score was more sensitive.
Okay, thank you.
Thank you, ma'am.
I think
Thank
we've
you, sir.
finished with all the cases.
With that, we come to the end of our award paper presentation. We have to allow the judges some time for their tabulation of scores. We thank our judges for their precious time, especially coming at 8 a.m. on a Sunday morning. Now we'll start with our first session. At first, I'll call our chairpersons to the dais. First, Dr. Shomik Ghosh, consultant pediatrician with special interest in adolescent health, and Dr. Priyankar Pal, head of pediatric rheumatology, professor and head of pediatrics, Institute of Child Health. I request our chairpersons to kindly invite our speaker.
Can I request all the speakers to keep to time? We're already running about more than half an hour late, so requesting the speakers to keep to time. Thank you.
A very good morning to everyone, and we have a very eminent now neurologist of Kolkata, Dr. Arundhati Banerjee. She's doing excellent work, faculty at Medical College. Arundhati, please start.
Yes, so a very good morning to my eminent and learned audience and my eminent chairpersons. At the outset, I would like to thank the organizers for giving me the opportunity to speak on a very pertinent topic, one of the treatable conditions of neurology, pediatric neurology, that is autoimmune encephalitis. So it is not so rare a disease with an estimated prevalence of around, in Indian studies, 5 to 8 per 1 lakh population. And the highlights of my talk would be, I would begin with a prototypical case of an autoimmune encephalitis, and I have focused on the common ones that we get in pediatric population, that is the NMDR, and of course the new guidelines that we have, which has been published in Neurology 2021, when we have clear-cut guidelines of timelines when to escalate, when to de-escalate on the immunotherapy. So these are particular, because it is a vast topic, it has a lot of things, so I would begin with a case scenario. So my case, K, 12-year-old girl, pre-morbid, developmentally normal, presented with fever for the first 3 days, which was like 1 month. The entire duration was a stuttering course, a subacute course of 1 month. Seizures, 2 episodes which were biphasic. Day 4 and day 16 of illness, abnormal behavior which started from day 4 of illness, and abnormal body movements from the 3rd week of illness. So this is how the timeline looks like, and in which we have seizures, started with fever which persisted for 3 to 4 days. Then we had abnormal behavior in the form of irrelevant talk, running away from house, irritability, hitting others, and then proceeded to encephalopathy, in which the child became absolutely mute, no interaction, and sleep disturbances as well. And then the abnormal movement started towards the end of the subacute course, that is towards the end of the 4th week, in the form of oral facial dyskinesias, non-stereotypic, non-rhythmic, disappeared during sleep, and there were no diurnal fluctuations which were noted. At this point, when the child arrived, having seen the psychiatric OPD when the child came to our health facility. So on general physical examination, there was nothing much contributory except for chronic malnutrition with microcephaly. This is a video of the child, I hope it plays, in which if you can appreciate the orolingual dyskinesias, the lingual movements, and the dystonic posturing of the right hand. And there are some limb automatisms also, in which the child keeps on picking, but otherwise the child is unresponsive, awake but not alert, not conscious of the surroundings, and picking at the clothes with some limb and oral automatisms, which were very prominent. And on examination also, which I have highlighted later, I will say the rest. So you can appreciate the lingual dyskinesias and, of course, the limb automatisms, and the dystonic posturing of the right hand. So on neurological examination, the child was in a kind of vegetative, or rather a minimally conscious state when the child was awake, but unaware of the surroundings. There was hardly any response to verbal commands, tactile stimuli, no spontaneous vocalizations, and was completely mute, was not responding to anybody's call. As for the cranial nerve examination, there was nothing to have a cranial neuropathy which we could unearth on informal examination. Bulk was symmetrically reduced. There was chronic malnutrition. Tone was variable. Sometimes she appeared rigid. Sometimes it appeared normal. Power was definitely, there was no paresis. However, reflexes were elicitable and symmetrical bilaterally. Neurological examination, there were, as described on the video, extrapyramidal movements, hyperkinetic movements of the face and limbs. Otherwise, and the child remained bedbound with an MRS score of 5. So in database, we have a 12-year-old premorbid, developmentally normal, presented with subacute febrile encephalopathy, with behavioral changes from the first week of illness, orolingual dyskinesias from the third week of illness. On examination, she was in a minimally conscious vegetative state with extrapyramidal movements and with chronic malnutrition. So the clinical possibilities that we, initially viral encephalitis in the form of HSC, JE, EBV, those were one of the possibilities. Then of course, because of prolonged stuttering course could be, but then she should have worsened more. The immune encephalitis remained a dominant possibility once the infective were ruled out, and of course ADEM and other immunological disorders could also not be excluded without any neuroimaging that we had. So points in favor of immune encephalitis was this was a girl child, 12-year-old, with neuropsychiatric features in the form of behavioral problems, insomnia, mutism, markedly impaired cognition, orolingual, these were typical of NMDR. Orolingual appendicular dyskinetic movements, seizures, and prolonged course and persistent symptoms. So the investigations, they were otherwise non-contributory. CSF was non-infective, with all the infective etiologies being ruled out. The MRI brain, there were significant findings in the striatum and in the left putamen, and of course in the cerebellar hemispheres. The EEG showed interictal discharges in the frontocentral leads, but they were non-specific. We sometimes get the representative delta brushes, which are found in extremely premature infants. We get in 30% cases of NMDR, but those were not present in our case. So the strong possibility of autoimmune encephalitis was considered, and as the CSF was negative for infectious etiology, MRI, however, was not typical. Acyclovir, which was started upfront, was stopped, and the child was started on steroids. And the autoimmune profile, which was sent, came positive. So the unit's final diagnosis was anti-NMDA encephalitis. Now coming to the diagnostic criteria. With this, I come to the changes or the recent things that we have come across. So the previous diagnosis criteria of probable anti-NMDA was that there was a rapid onset of speech dysfunction, seizures, movement disorders, at least one of the following of lab results like abnormal EEG, CSF, and reasonable exclusion of others. And definite is, of course, we have the antibody positive. But now, according to recent classification, we have classified into definite, in which there is antibody positive, if we look at the third column, and probable, in which we again have possible and probable. And in which, in possible, we do not have the paraclinical evidence of neuroinflammation in the form of CSF inflammatory changes, MRI features of encephalitis, and brain biopsy showing infiltrates. So those are not present in possible. So that is how this is the new proposed classification that has come up. Next, coming to the course that is as the inflammatory changes are very much obvious, then we get the viral prodrome and then the psychiatric symptoms and delusions and hallucinations in older kids. And in younger kids, we get seizures. And then there are prolonged deficits as the inflammation subsides. However, the prolonged deficits without immunotherapy, this can lead to executive function, deficit, impulsivity, disinhibition, and sleep abnormalities. Now coming to, I have elaborated NMDR. The other two which are common in pediatric age group is the GAD65 and the MOG-associated encephalitis. So MOG, as we know, present with ADEM-ON, that is optic neuritis spectrum, but it can also present with autoimmune encephalitis without any features or without any MRI findings. So, and GAD65 also is a common autoimmune encephalitis, but is only pathologic if high titers in the serum are present. Clinical is encephalitis with memory loss and cognitive, and cerebellar ataxia and temporal lobe seizures are quite common. Epileptiform discharges may be seen, and CSF leukocytosis is quite common. So associations, especially in older age group in females, association of ovarian teratoma in 60%, male you have testicular teratoma, adolescent females, they also have ovarian tumors. Infection triggers are there, and of course immunization also, though minuscule, plays a role in the trigger. Now coming to risk stratification, which is important for the institution of therapy. So here again, what I would like to point out, this is the severely affected versus the standard score. Because we start the standard therapy in the standard group, and the severely affected, we directly go to aggressive therapy, first line. So here, depending on the safety profile, that is the need of intensive care at the outset, the mobility, whether the MRS score is on the higher side, presence of nursing care, presence of psychiatric symptoms, communication, alertness and epilepsy, and obviously adapted MRS score of 4 and 5. These all suggest severe, and the standard spectrum is thus the milder side of it. Now coming to the treatment, this is all that we know, that is steroids, IVIG, and Plex or plasmapheresis is the first line. Followed by second line, we have Ritux and cyclophosphamide. And then of course, third line, in severely affected non-responders, we can escalate to tocilizumab, and of course associated with chronic immunosuppression, which I will dwell with, and tumor screening and supportive care. So here our knowledge has been expanded with the current guidelines of this, in which they have given us clear-cut timelines of when to escalate. So here again, this is the first line. We all know IVMP, oral prednisolone, the doses are fine. What I want to point out is Ritux. Till now, we had 375 milligram per meter square body surface area weekly for 4 weeks. But higher doses has been advocated, because this is a guideline for pediatric and MDA. So 500 to 1,000 milligram, 500 in less than 40, more than 40,000 milligram has been advocated at a 2-weekly interval, 2 doses. So those are higher doses which are used in oncomedicine, I suppose, or maybe Sir has been using. We don't use it. In fact, we have been using lower doses, like 200 milligrams, with similar efficacy. But here again, there are higher doses of Ritux, which we should take in mind. And tocilizumab also, in poor responders, we can escalate to IV toci, which is 12 milligram per kg per dose, or 8 milligram per kg per dose, depending on the weight band. So coming to the concept of best responders, average responders, and poorest responders, because that is what the therapy would help. Best responders are those which show with first-line therapy, they show rapid improvement. Improvement within not even 3 months is required, within 2 to 3 months. And normalcy by 3 months. That is, pre-morbid levels are reached by 3 months. Whereas average responders, positive by 2 to 3 months, 6 months they gain, but there are some deficits with immunotherapy. And poorest responders are failure to improve by 3 months and impaired functional ability and requires rehab for more than 3 months. So keeping these responders in mind, now we come to the algorithmic approach that has been given by Neurology 2021, in which they say that standard disease, that is when we do not have high risk, we straight away start with the first line, that is IVMP, and then if there is no improvement after 7 days, then we can always escalate. But if there is adequate improvement, then we can continue with monthly corticosteroids, intrathecal is generally we avoid in our centers, IV, methylpred or IVIG if they are affording, for 3 to 6 months in best responders. Best responders will respond with this treatment. Whereas in severe disease, the first hour, if there is inadequate response at 1 week, then in addition, we can, to the first line therapy which we are using, supposing you are using MP, methylpred, then you can again add on to Plex or IVIG, and escalate at 2 weeks if there is insufficient response at 7 days. Then we have to wait for 2 weeks before we can escalate to the second line. Second line Ritux is preferred over cyclophosphamide, but if we can use one, and if there is no response, then we can use the other as well. So average responders are typically, they require 6 to 12 months overall of the first-line therapy and prolonged first-line immunosuppression for nearly 6 to 12 months, whereas poor responders, they require, even after response, they require rehab, one. Two is they require chronic immunosuppression in the form of monthly IV methylprednisolone or IVIG for nearly 18 to 24 months. So this is what the latest guidelines say. The prognosis depends, of course, on the standard as well as the high-risk patients. And 75% usually recover only with mild sequelae. Median time of recovery is 6 weeks, 2 to 28 weeks. 25% are severely disabled. Recovery is slow in reverse order. Relapse may be seen in 12 to 25% cases, and mortality is seen in 4% cases. Usually in younger children, severely affected, requiring intensive care at the outset are those which are worst affected. So depends on early diagnosis, appropriate immunomodulatory therapy, and early tumor removal if there is any paraneoplastic syndrome. Therefore, to sum up, it is not so rare an entity. We should have a high index of suspicion. It is a treatable entity in neurology, one of the rare ones. And there are, of course, challenges in diagnosis because we have the other infective etiologies which are not picked up by BioFire PCRs. Therefore, diagnosis and early institution is very important in order to prevent the neurological morbidity. With that, I would like to end my session and thank you for your patient hearing. I would like to thank all my learned audience as well as the patients from which the clinical material I have derived from all these institutes, premier institutes in which I have been associated with. Thank you.
Thank you, Arundhati, for a very lucid presentation on a very protean subject. So we can have, I think, 1 or 2 questions. She finished on time. Yes?
Anakindra, no, sir. Recent guidelines we have not found, but what we have found is that to escalate to tocilizumab in case of poorly responders, those who have not responded. Yes, for older children, as I said, and for females especially. It is almost like, because the incidence is quite high, so it is definitely mandatory to rule out. Ovarian tumors, teratomas, even testicular tumors in adolescent males. Ma'am, it is definitely.
Also neuroblastoma.
Yes, neuroblastoma also can be.
And regarding infections, we had one patient of COVID presenting with autoimmune encephalitis.
Autoimmune encephalitis. Yes, so HSV-triggered autoimmune encephalitis is a very thing. I have not mentioned it separately because the guideline says that the therapy will not differ. The therapy will be the same as a naive autoimmune encephalitis. But of course, there are any infections, in fact, can trigger autoimmune. We also had a case in which they had, this child had very poorly marginated large lesions. They had an ADEM-like presentation. So in 50% cases, autoimmune encephalitis MRI can be normal. And 50% we have some basal ganglia changes, some non-specific changes. Yes, ma'am. So
instead of doing puncture twice, sometimes I do
yes, in our restrained settings, I think that would be a prudent approach. If you can reasonably exclude infection, and if you say that the patient does not improve with anti-infective therapy or with acyclovir and other measures, then I think it would be reasonable to send. If you are getting any other features which are suggestive of this, especially mutism, especially psychiatric symptoms, seizures, even seizures, refractory seizures which are otherwise not responding, you should always think of autoimmune encephalitis.
So actually, this is a very expanding,
yes,
ever-expanding spectrum.
Even we are on the process of learning. It's not very easy.
Always new antibodies are being discovered.
Yes. Even intracellular, extracellular, there also, it is different.
But the response to therapy is usually very good.
Very
If you-
good.
So that is the thing. That
Usually we do not get poorly responders or quite so often, but yes, severely affected once a while we can have to. I myself have treated around 55, 60, but I have not had to escalate to tocilizumab as of now. So Ritux with Ritux,
with
I
Ritux.
have.
So have you ever combined Ritux and cyclophosphamide?
Yes, I have. So we have a follow-up in medical college in which we have a child, actually she suffered some secondary injuries. She was suffering from a stuttering course of refractory seizures. And then she went around, she didn't come to our facility, she went around using jhar-phook and indigenous medicines. So what happened was that she suffered from secondary hypoxia as well. There was perisylvian gliosis as well. So this child still has not gained, like she has deficits in the form of, she's not able to communicate. She was absolutely bedbound when she came. The seizures were controlled, then we gave Ritux, she improved, she started ambulating, still there was non-specific, so I started with 6 cycles of cyclo, but still pre-morbid levels I've not been able to reach. But then, of course, it's almost like 2 years' time. When 2 years' time, it is difficult. They go into a spent-up phase of inflammation. So it is actually the active inflammation which is persisting, which we should target, or it is a spent-up phase. Because once it is a spent-up phase, then the idea of escalating to immunotherapy would not be very, it would subject her to the risk of infections more, I suppose so.
Any further questions? Thank you, Arundhati, for a wonderful and very lucid presentation.
Thank you, sir.
I think so you've satisfied the audience questions also.
Thank you, sir.
Thank you so much.
So the next speaker, I'd request the next speaker, Dr. Vishwanath Kulkarni, he will be presenting on MOGAD. So autoimmune encephalitis followed by MOGAD. So the ball continues.
Just a quick announcement to make. All of you who haven't collected your certificates, they are available from the torrent stall. So if you can go and to the torrent stall for your certificates at any point.
Good morning, everybody. At the outset, I am thankful to the organizers for giving me this opportunity to talk on this more evolving topic, that is the myelin oligodendrocyte glycoprotein antibody associated disease, that is MOGAD. And greetings from City of Education to the City of Joy. So let's start. So it is an inflammatory demyelinating disease of the central nervous system with antibodies which are directed against the MOG protein. So in a nutshell, it is a oligodendrocytopathy. Vis-a-vis, when we talk about NMOSD, it is astrocytopathy, neuromyelitis optica spectrum. So MOG is a transmembrane protein, if you see, exclusively expressed at the outermost surface of the myelin sheath and oligodendrocyte membranes in the CNS. Now the reports describing this particular entity and the anti-MOG antibodies in MS and other demyelinating conditions, they were first appeared in the literature in late 1980s. But evidence to support their role in demyelinating disease was always weak and inconsistent. The probability of anti-MOG MS subtype was considered around 2000, and the turning point was in 2011 when Madar et al. She developed a cell-based assay using HEC93 cells, which increased the detection rate of these antibodies in the serum. And the reports about prevalence of anti-MOG in selected MS cases, began since 2016. Now, MOG antibodies in patients with monophasic optic neuritis and transverse myelitis, and in 50% patients with the ADEM. Almost all children with multiphasic demyelinating encephalomyelitis, those were MOG positive. MOG antibody is found in patients with ADEM followed by optic neuritis, relapsing inflammatory optic neuritis, that is RION, and relapsing brainstem demyelination and aquaporin 4 antibody negative NMOSD. So if you see this cartoon, so MOGAD, it is associated with ADEM, associated with optic neuritis, associated with transverse myelitis, associated with brainstem syndrome, associated with NMOSD, and associated with cortical encephalitis. So that is the spectrum of MOGAD, which we have to consider when we deal with our patient having demyelinating disorder. Now, ADAM is the commonest presentation of MOGAD in children less than 11 years of the age. How the least common phenotype is being the transverse myelitis, less than 11 years. Now, let's start with the cases. He is a 2-year-old male child with normal birth and developmental history, presented with complaints of fever of 5 days duration, altered sensorium of 3 days duration, seizures of 1 day. On examination, his GCS was 8/15. Cranial nerves were normal, tone was normal, power was 3/5, best observed in all 4 limbs, DTRs were brisk, and plantas were extensor. CSF routine microscopy showed mild pleocytosis, proteins were on the little higher side 40, glucose normal, and CSF viral panel was negative. MRI spine was normal. MRI brain, if you see, there are multiple fluffy lesions in the subcortical regions. Yesterday, if you have attended the panel discussion by Joshi sir and Dr. Vishal Sondhi, any child, when you are finding there are, say, demyelinating lesions of the brain, it is always necessary to get the optic cuts and the MRI spine. So MRI spine in this child was normal, and we got his MOG antibodies, and those were positive. So MOGAD-ADAM, it is the most common phenotype in young children, as we already saw. The associated prolonged fever might be there. MRI brain, classically bilateral, extensive, confluent, fluffy lesions involving juxtacortical white matter, deep gray matter, and cerebellar peduncles. Nodular contrast enhancement can also be seen, and sometimes you may find leukodystrophy-like pattern when it is very extensive. Monophasic course is seen in 50% of the cases with a good prognosis. The second case, she is a 9-year-old female who presented with complaints of acute onset diminution of vision of the right eye. There was no history of altered sensorium. There was history of recent infection 10 days prior to the symptomatology. On examination, her GCS was 15/15. Cranial nerve examination showed right-sided visual acuity. She was just able to count the fingers. Right side fundus showed papilledema. No other focal neurological deficits, and CSF routine and microscopy was normal. MRI brain showed thickening of the right optic nerve. Again, we got MRI spine, which was normal, and VP showed abnormal delayed P100 latency on the right side. So what is the diagnosis in this child? So it is an optic neuritis. Now, again, in this child, we got the MOG antibodies, and those were positive. So now, most common presentation of MOGAD in adolescents and adults is optic neuritis. So it is bilateral in 50% of the cases, recurrent in 50% of the cases. You may get papillitis in almost 86% of the cases, perineural enhancement in 50% cases, and MRI brain, if you find, there is long segment involvement in this MOG. Vis-a-vis, if you see NMOSD, neuromyelitis optica, there is involvement of the chiasma, that is the posterior part. And if you see MS, it is a short segment involvement. So long nerve segment affection, perineural enhancement, predilation for anterior segment, infrequent affection of the optic chiasma, and leptomeningeal enhancement can be seen in MOG-associated optic neuritis. Now let's move to case 3. He is 13-year-old male child who presented with fever, headache, drowsiness, acute onset weakness in bilateral lower limbs since 1 day associated with urinary retention. There was no significant fast history. Examination, his GCS was 12/15. Cranial nerves were intact. Hypotonia in bilateral lower limbs, power 2/5. DTRs were brisk, plantas were extensor, and got sensory level at T8. So it is very polyfocal presentation. So what is the diagnosis? Transverse myelitis. Again, in this child, CSF showed pleocytosis with lymphocytic predominance, elevated proteins. MRI brain with MRI whole spine screen showed hyperintensities in the, and it is like longitudinally extensive transverse myelitis. Again, MOG antibodies were positive. Now, if you see transverse myelitis, it is more common presentation in the adults. It is longitudinally extensive, lesions may be contiguous or patchy lesions you can find. It is having predilection for the conus. It affects both gray and white matter. And H sign, if you see the central affection, it is suggestive of MOG, but it is not the confirmatory one. Now come to the MOG-associated encephalitis, that is MOGE. It is distinct from other demyelinating phenotypes. Symptomatology include fever, headache, seizures, altered sensorium, aphasia, stroke-like episodes, personality changes, working memory deficits. In most selective cortical involvement, unilateral or bilateral, correlating with the hyperperfusion of the cortex. Increased chances of sequelae, severe brain atrophy, refractory symptomatic seizures you may get, motor impairment with cognitive decline. So it is, this MOGE is also called flames or fuel. Flames is flare hyperintense lesions in anti-MOG associated encephalitis with seizures, or fuel, that is the flare variable unilateral enhancement of the leptomeninges. Typically, cortical involvement is usually restricted to one hemisphere with unilateral flare hyperintensities without the involvement of the adjacent juxtacortical white matter. In children, cortical involvement is more diffuse and bilateral, and hippocampal involvement has also been described. Leptomeningeal enhancement along the cortical lesions can be seen. Now coming to the NMOSD-like presentation in the MOGAD. So it is the combination of unilateral or bilateral acute optic neuritis and longitudinally extensive transverse myelitis at the initial attack with aquaporin 4 antibodies negative NMOSD. Can be seen in 7.4% to 39%. And it is a very relapsing phenotype. So again, you can see how the optic neuritis in MOG look like. This is the involvement of the conus. Now coming to the anti-MOG testing. This is very interesting one. Now why you should always check MOG antibodies in the serum, number one. You should always do the cell-based assay. Now the cell-based assays are very scanty in all over the India. So we get the titers. Now, generally, if you do titers 1:10, the chances of false positivity becomes very high. So whenever you are getting results in your hand, always check the titer. Titer should be 1:100 and more than that to get the true positive results. At the same time, MOG might be positive in children with anti-NMDR encephalitis and anti-GFAP encephalitis. So coexisting autoimmunity might be exist. So the research is still going on this particular coimmunity. Coming to the treatment, corticosteroids, IV methylpirate 20 to 30 mg per kg per day for 3 to 5 days with some subsequent tapering with oral prednisolone 1 to 2 milligram per kg per day. Tapering duration varies from 6 weeks to 6 months depending upon the severity and topography of the initial attack. IV immunoglobulin, second line treatment in patients with inadequate response or any contraindication for the IV methylprednisolone. Dose is 2 gram per kg given over 2 days. Plasmapheresis, it is the second line rescue therapy for severe steroid unresponsive CNS demyelinating attacks, and 4 to 5 cycles on the alternate day is the management. Now coming to the optimal chronic relapse prevention treatment for those who are having the relapsing disease, it is the rituximab. As Dr. Arundhati already talked in her presentation about the autoimmune encephalitis, the dose can go as high as 500 milligram per meter square of the dose. Monitoring of the B cells, that is the CD19s, and you have to keep CD19 activity less than 1%. Mycophenolate mofetil, dose is 500 to 750 milligram per meter square per dose, orally twice a day, with maximum of 200 milligram total. Azathioprine, 2 to 3 milligram per kg, or in few cases, you can give monthly IVIG also for 6 months. Disease-modifying treatment in MS is ineffective in these relapsing phenotypes. Now, how to do follow-up in these children? So, MRI is generally indicated 3 to 6 months of the initial attack. Anti-MOG levels, better not to chase antibody titers. Now, why this is important not to chase? Because patients with persistent seropositivity, they may not relapse. And the seronegative patients may develop relapses with or without re-emerged antibodies. So prognosis is absolutely varied in anti-MOG antibody disease. The time to relapse may be as long as 10 years following the initial event, and the children with NMOSD-like phenotype and relapsing brainstem demyelination are associated with very high relapse rate. Here I rest my presentation. Thank you.
So I think we can have some questions. I'd invite some questions from the audience. Yes?
Thank you, sir, for the lucid presentation. Sir, regarding both autoimmune encephalitis and regarding MOGAD, the for chronic immunosuppression after treating the initial treatment, generally we will be having dilemma, which is generally institute protocols, whether to give a MMF, whether to give azithromycin, or whether to give monthly doses of steroids. So what's your experience and what's your advice? Generally, sometimes we take opinion of even chronic relapsing MOGAD and very difficult to treat MOGAD patients, we go for tocilizumab also, we have been using it. So which one you prefer, sir, initially for the treatment regarding the disease severity? Thank you,
For
sir.
these relapsing phenotypes, just now one child with seronegative NMOSD-like presentation of the MOGAD. Now she was initially treated with steroids. We have started on, then what you are supposed to do if the child is having, after giving 2-3 days, you come to know that the child is not responding to the steroids, then you add IVIG, correct? Now, after starting IVIG, we start with the tapering dose of prednisolone over 6 weeks to 6 months. Now, even though the child is not showing responses, say after 21 days, we start doing the Plex. And then followed by azathioprine or mycophenolate mofetil over next 6 months to 1 year. In one child, we continued for monthly IVIG protocol. And we are not finding any change in those patients who are being treated with monthly IVIG vis-a-vis azathioprine or mycophenolate mofetil.
Sir, thank you, sir. But yeah, regarding in our setup also, we have seen that monthly IVIG is like quite difficult to afford. That's why. So I'm just asking whether to give and continue on MMF like 800 mg per meter square, or you should give for a monthly IVIG. Means what's your experience? That's the thing, sir.
So experience-wise, we had given monthly IVIG, also the tapering dose of the steroids. And the follow-up is, mean follow-up is almost 1 year. And there is no change in the baseline characteristics of both the groups. Say whether it is monthly IVIG, but it is very cumbersome and costly at the resource-restrained settings. So you can start with mycophenolate mofetil or azathioprine over the period of time.
Thank you, sir.
There was an interesting slide showing GFAP positivity. So which is a new entity now. Priyanka sir is also there regarding autoimmunity. So in many patients we are getting in autoimmune encephalitis, in suspected ADEM, there may be in adolescents, older children, GFAP positivity. With or without leptomeningeal, how will you take that seriously? Because that is a different entity that is coming up now.
As far as GFAP positivity is in literature only, I didn't come across any child with MOG positive with coexisting immunity with the GFAP.
We recently came across whether GFAP was highly positive, but again we are not sure how to take that. Because it's a new entity coming up, like ADM with leptomeningeal enhancement showing GFAP positivity. The treatment, long-term treatment may be different. Again, that is a newer thing coming up. So it's interesting perspective.
So it's very protein, and the recent studies will be more important to follow up now.
So if there are no more questions, so I'd close the session. Thank you,
Thank
Dr.
you, sir.
Kulkarni.
Thank you.
So it was a session of brain on fire, I think. Huh? Thank you.
Thank you, respected chairpersons and our speakers, for the wonderful morning session. I would request you all to kindly collect your mementos from the memento corner. We would move to the next session, which is a panel discussion on management of demyelinating diseases. I invite our moderator, Dr. Debashish Panigrahi, consultant pediatric neurologist from Bhubaneswar, to kindly come on stage. And I request her to invite our panelists.
So, warm good morning to one and all, and I would like to thank the organizers for giving me this opportunity to talk on this important topic. So, it is a panel discussion, and I invite my esteemed panelists, Dr. Jeevan Silwal, Dr. Singhendu Ghosh, Dr. Joydeep Das, Dr. Sopan Mukhopadhyay, and Dr. Puneet Chaudhary to the stage. So, so after this an enlightening talk on MOGAD by Dr. Kulkarni, we'll go to this presentation on demyelinating disorder. So, some basic background. So, myelin is thing that covers the nerve. It's a lipid-rich myelin sheath. It is produced by the oligodendrocyte. It provides an axon insulation. These are sodium channel clustered around the rods of Ranvier. And as you all know, myelin increases the conduction speed and metabolic efficacy of this nerve. So whenever a nerve is demyelinated, there will be decreased conduction velocity and block. There will be destabilization of axonal cytoskeleton, remodeling of internodal membrane, and progressive axonal loss. So these are some of the common terminologies that are associated with white matter disorder. That is demyelination. It is the destruction of the normal myelin. And dysmyelination, this is the formation of abnormal myelin. Hypomyelination, this is the reduction of the amount of myelin, and there can be delayed myelination. So demyelination is most likely an acquired demyelination, which is damage to the previously normal myelin sheath, most likely immunomediated, but other causes like injury, viral infection, drug, toxic agent has also been implicated. So if we come to the classification or causes of acquired demyelinating disorder, inflammation and immunomediated disorder are most common, followed by infectious, granulomatous disease, then this chronic condition of myelin like genetic condition, and toxic and metabolic disorder. So today we will focus on this presentation mostly on the acquired demyelination, that is the ADEM, NMO, and multiple sclerosis. So acquired demyelinating disorders are CNS are neurologic dysfunction caused by immunomediated attack on the myelin sheath covering the brain, optic nerve, and the spinal cord. It is characterized by neurological deficit, presence or absence of encephalopathy, and the course of the disease. The course of the disease is very important. Either it will be an acute presentation, or it can be a monophagic or a multiphagic or a relapsing remitting course. So these are some of the common terminologies like CIS is clinically isolated syndrome. This is characterized by monofocal or ponifocal deficit without encephalopathy. ADEM is a polyfocal deficit with encephalopathy. Then we have NMOSD, that is neuromyelitis optica spectrum disorder, and pediatric multiple sclerosis. So with this background, we'll see 4 cases and some question at the end of the case. So this is a 4-year-old child with no past medical history presented to the emergency room with a 4-day history of progressive weakness and sleepiness. His parents initially noticed drooling followed by weakness and difficulty in walking. On the day of admission, he was noted to have asymmetry of the face and left-sided arm and leg weakness. In addition, he had altered mental status, alternating between lethargy and aggressive behavior. There was no history of recent illness, immunization, and trauma, and no family history of autoimmune disorder. Upon admission, the child was lethargic with intermittent irritability but responded to command. There was no meningeal sign. Cranial nerve examination shows a left-sided loss of nasolabial fluid indicating a facial palsy, and there was no apparent pupillary defect. There is a left-sided weakness of the upper and lower extremity with the ipsilateral extensor plantar. Right side was normal, and he was not able to walk due to this thing, and the patient had difficulty in performing finger nose testing on the left side and not able to walk. There was no sensory deficit noted. There was no truncal or appendicular ataxia. So Dr. Jeevan, so can you summarize the case and tell what are the differential diagnosis from the history and clinical examination in this scenario?
Yeah, good morning everyone. So this case has a very short history, just came with 4-day history. So, and from beginning there is some kind of encephalopathy with some irritability. And when the child arrived in the hospital, there was some left-sided hemiparesis was there. So, so this is a child coming with starting with encephalopathy. There is no fever to begin with in the history. So encephalopathy followed by some focal deficit in the form of left hemiparesis. So our thought process should be like any child coming with a focal deficit, focal neurological deficit is a kind of stroke unless otherwise proved. But the history here is not classical like what we see in ischemic stroke. There was some encephalopathy to begin, then child later on have a hemiparesis. So encephalopathy with some deficit, so I will think of in the line of same like stroke and its mimics like we like to rule out intracranial any space occupying lesions. And demyelination will be always on top of the list because short history, encephalopathy, and then the focal deficit.
So with this differential, what investigation you want to do initially, maybe?
So first, yeah, clinically, first thing is whenever we see such kind of child, always think we have to, whatever we have to think is we have to see what are the, if there we are missing out any, severe intracranial tensions, are there not? Such child is posturing, very sick child, though we have to manage the child first. That is the first thing in a casualty. Then after that, the first approach in investigation will be always a neuroimaging will be a first thing because doing in CSF and all, if there is a raised pressure can cause some other problems. So always a neuroimaging will be a first, that will give us the answer.
So we went ahead and did the neuroimaging. Dr. Jivan, can you describe the neuroimaging finding for us in this child?
Yeah, so this looks like a flare image showing a very fluffy, hyper-intense lesion on both the cerebral hemispheres involving the white matter and gray-white matter junction, more on the right side compared to the left.
So this is T2 flare hyperintense lesion. The most important part is the large lesion and asymmetric lesions. Then this is slight diffusion restriction.
Diffusion restriction.
And in contrast, there is no significant enhancement, there is slight enhancement. So with this MRI finding, we went ahead and did the cerebrospinal fluid, which showed 11 cell, a protein of 40 and glucose of 47. Nor IgG index was normal and no oligoclonal band. CSF PCR for herpes simplex was negative, and peripheral white cell count, ESR, everything came out to be normal. This meningoencephalitis panel was also negative. We went ahead and did NMO and MOG antibody also, which came out to be negative. And EEG demonstrated background slowing with no epileptiform discharges. So Dr. Punit, my question to you, what is your final diagnosis from this MRI finding and your lab finding, and how will you going to approach this child, treat this child?
So as the child had to begin with an febrile encephalopathy with the focal deficits, and the CSF is normal, doesn't suggest any infections. We have ruled out the usual infections which can cause this kind of presentation. Also, the MRI is very characteristic for EDEM, which shows fluffy, asymmetric hyperintensities which are into the subcortical white matter extending up to the deep and periventricular white matter, and there is a fair bit of asymmetry. So this suggests with encephalopathy in the background, this is the diagnosis of EDEM. To begin with, the first line of management would be supportive, as Dr. Jeevan was saying. Some children with EDEM can have fulminant and hemorrhagic kind of demyelination, and they can have raised ICP. So the basics first, we should be managing the raised ICP. Coming to the definitive management, with methylprednisolone pulses at 30 mg per kg per day is the first line of management, and most of the children will show improvement with this. Most of these children, we give tapering steroids 6 weeks or 4 weeks, followed by 4 weeks or 6 weeks. Now there is a question, suppose my child, I give methylprednisolone pulses for 5 days and he is completely fine by day 5. What should I do? Should I continue the oral steroids tapering, or should I stop? So there are some studies which show that if you give tapering steroids, it reduces the chance of recurrence, especially in the MOG positive EDEM, which is more than 50% of the MOGAD. So as this child, he completely improved after the steroids, and he was able to ambulate. So this was a very good response to the immunotherapy.
Okay, thank you, Dr. Punit. So after 3 months, we did an MRI. There is a complete, almost complete resolution of lesion. So this this is a case of ADAM, and it
Sir, one
responded.
thing I would highlight is in other cases of demyelination which are not ADAM, we repeat MRI after 1 month. But because ADAM, classically it is considered a illness which lasts for 3 months and doesn't recur after that. So MRI is repeated after 3 months.
So MRI helps you to classification also.
Classification, so that there are no further
No
lesions.
further lesion. That's why we
just
do
do
MRI.
monofysitic.
So these are some of these, again, Dr. Jeevan. In very short, can you tell what are the diagnostic criteria for ADAM? Because ADAM is very common. In all the demyelinating disorder, you will come across, as a pediatrician, you will come across more and more cases of ADAM. So we have a little bit more discussion of ADAM. So what are the diagnostic criteria of ADAM?
So the hallmark is encephalopathy. One thing that we all need to see is ADAM, the hallmark is encephalopathy, and encephalopathy may range from your simple lethargy, confusion, some behavioral change, sleepiness, to frank coma. So encephalopathy does not mean a very, very encephalopathic means kind of, very comatose child. We have to keep that thing, that is very important thing. So encephalopathy is the hallmark, followed by there are some focal or polyfocal or multifocal presentation will be there. So any child coming with an encephalopathy and there are some focal finding, like in our child there was a left hemiparesis, or sometime you may find a multifocal kind of presentation. Means it may not be fit into our what we cannot localize it sometimes. There might be some cranial nerve deficit, so those kind of presentations. So encephalopathy and some multifocal presentations are there. And always MRI is the most helpful, that what we discuss, very fluffy kind of discrete T2 flare lesions are there. And those MRI after 3 months, the lesions are completely resolved, then we are sure that it is a monophasic ADAM.
Okay, thank you. That Dr. Singendu, we have already discussed some of this. So can you briefly tell about the presentation of acuteness of the symptom, how you can differential diagnosis is input?
Temporal evolution of a disease helps us in arriving at diagnosis. In neurology, when a patient presents, suddenly only 3 possibilities are there: stroke, demyelination, neuroinfection. So in stroke, it is maximum at the presentation and remains static for few days or weeks, then gradually progresses depending on the severity of the stroke. So in this case, disease progress for the first 4 to 5 days, so stroke is unlikely. Then comes neuroinfection. It also presents suddenly, but it progresses. But I have not been given any history of systemic symptoms like fever, headache, meningeal signs, so I will keep aside neuroinfections. And those demyelinating disorders like leukodystrophies, they are very insidious in onset and very slow in progression, so that is also out. Then intracranial space occupying lesion also presents subacutely and progresses slowly, that is also out. So we are left with demyelinating disorders. So demyelinating disorders may be primary or secondary. Primary we all know, MS, NMO, SD and MOGADs, and secondary is ADAM and related disorders. So from history, we can maximum reach up to demyelinating disorder. And to further differentiate, we have to take the help of investigations like antibodies, etc.
Thank you, sir. Thank you for your help. So, Dr. Puneet, how does CSF examination helps in this case?
Lumbar puncture and a subsequent CSF examination is very central to the diagnosis and management of ADAM. So basically from 2 points of view, first we want to rule out the infections, as we live in a tropical to subtropical country. The infections, viral encephalitis and meningitis, these are very common. So we want to rule that out because our therapy is immunosuppressive. If at all there is an infection, we are going to flare up the infection. So first thing, we want to rule out the infections. The second thing is, as we have been seeing from the multiple sessions, these are the autoinflammatory disorders. So at the same point, we also want to see what are the markers of inflammation into the CSF. So protein which is high may not be very high to suggest an infection, could be a sign of the inflammatory process going on. Cells, lymphocytic predominant, we can see even in up to 100 cells per microliter can be seen. but not more than that. If it is more than that, then we should be suspicious of an infection. Also, we want to rule out HSV, which can have this sporadic presentation. So basically, also the other investigations, like sometimes CSF neopterin is done, monoclonal, oligoclonal bands are done. These are sometimes positive in about 20% of the patients, as compared to the MS, in which they are very specific and they can also replace dissemination in time. Here, in case of ADEM, if we find oligoclonal band, they are mostly non-specific. But then if we find a oligoclonal band positivity in CSF in children with ADEM, we should follow them more vigilantly. They might have some chances of evolving into the multiple sclerosis later on. So in conclusion, we want to rule out infections, and we want to also look at the CSF markers of inflammation.
So again, we should, Dr. Joydeep, can you just highlight briefly, because already discussed
Good
about
morning.
the MRI
So,
finding.
The ADEM per se is a white matter disease. So I have to look for what are the sites of white matter in the brain. So sites of white matter in the brain, the bulk white matter is centrum semiovale, followed by corona radiata bilaterally, followed by internal capsule, and down below. So I would like to get a multifocal white matter involvement, which is apparently looking at tumor of active lesion without any ill-defined margin. So, and another characteristic is that T1 hypo is very rare in ADEM. So all are T2 hyperintensity, and there is thalamic involvement is another classical feature of ADEM by which we can differentiate from MS and others.
So basically, large floppy asymmetrical hyperintensities, absent of black hole, that is the T1, that is more common in MS, and deep gray matter involvement. Basal ganglia thalamus involvement is not uncommon in ADM, can be there in ADM. So you should keep this in mind. So Dr. Swapon, again, little bit highlight on how to treatment.
As usual, like in other cases of demyelinating disorders, we usually start with high dose of methylprednisolone. That is the first line of treatment in all cases of ADM. The standard dose is varies between 20 to 30 milligram per kg per day, and not over 1000 milligram per day. And the span is of 3 to 5 days. And along with that, after that, we give a tapering course of oral prednisolone, usually varying between 2 to 4 milligram over 4 to 6 weeks. And if the patient doesn't respond to this first-line treatment or methylprednisolone, we have other options of anti-inflammatory and immunosuppressive drugs like IV immunoglobulin, which is given in as a dose of 2 gram per kg distributed over 5 days, or other which also has got a beneficial effects. And plasma exchange definitely is the third choice. It can be given for 5 to 10 cycles in those cases who are refractory to both these first-line treatments. And
so additional supportive measure as has been highlighted.
As Dr. Jeevan has already mentioned.
So basically, you must remember that ADM is a monophagic illness. There is one episode of ADM, and it can be sometimes multiphagic, that is one relapse after 3 months. But any child who is presenting with multiple relapses is unlikely ADM, and you should think for other demyelinating conditions. Therefore, doing serial MRI is always important in demyelinating.
And standard procedure in ADM is, if the child remains stable after oral prednisolone, you usually wait for 3 months to repeat the MRI to see total clearing of the lesions. Because if there is a reappearance of lesions, you'll have to reconsider your diagnosis. But in between, if the child deteriorates, clinical profile, like the appearance of new seizures or newer hemiparesis and others, or other pathology, you'll have to repeat
anything
an MRI
anything within 3 months, you have to take it as a same illness and treat it accordingly. So now going to case 2. A 3-year-old child presented with status epilepticus. At the time of presentation, there are no notable past medical history. She was well until 1 day prior to the admission and had a high temperature. At the time, she had diarrhea and she has rhinorrhea and cough also. Throughout the day, her parent noted she was lethargic and decreased physical activity. On the evening of the first day of illness, the father found her unresponsive and noted generalized muscle rigidity of both arm and leg. she was taken to an hospital where examination noted decerebrate posturing, nystagmus, and urinary incontinence. She was intubated and intravenous phenytoin and ceftriaxone were given. So it showed a comatose child with decerebrate posturing after stimulation. Deep tendon reflexes were brisk and plantar was extensor. EEG obtained on admission showed numerous electrographic seizures without clinical correlate occurring independently in bilateral posterior region, and background electrographic activity was slow and disorganized. So with this finding, we went ahead and did this MRI of this child. As you can see, there are marked swelling and diffuse asymmetrical sigmoid bilateral thalami and occipital cortex. There is some microhemorrhages also in this thalamus, and there are hyperintensity in the brainstem as well as in the cerebellum. So the CNS examination showed elevated protein, 4 white blood cell, elevated protein and normal glucose. IgG index was slightly high, no oligoclonal band, and rest examination was normal. So Dr. Jeevan, from this history and finding, what will be your clinical diagnosis and how will you approach this child?
So this is child coming with a one-day history and very
history.
suddenly going into a very bad encephalopathy.
Yes.
So posturing and all those things are signs of a very raised intracranial tension with all your pyramidal tract signs are there in examination. So very fulminant kind of a encephalopathy probably. So our approach should be like any child coming with fever, altered sensorium seizures, we should think in a line of like an acute encephalitic syndrome and go ahead. So viral encephalitis generally presents with such kind of presentation, very short history. And apart from that, we should think of all possible infections. Neuroinfections are the things which you need to think of. And once your imagings are done, your and CSFs are done, so all that will guide us further. So that will be the line of thinking.
So from this CSF and imaging finding, what will be your diagnosis?
This imaging is something that we all need to remember, because we should not miss out this condition. This is a very, very, I liked all the audience to take back, from this conference, this image. Okay, this is very, very important. Why? Because this is a very classical image of a necrotizing encephalitis. And why it is important to identify? Because, the pathogenesis says that there will be always a cytokine storm that comes and that makes the child very bad. So, and this is a condition which has a long-term sequelae. And early intervention in like when we give steroid IVIG at the same time, and nowadays there are studies with this tocilizumab. They are very frequently I have personally not used, but when I discuss with my colleagues all around, so now they are very frequently using tocilizumab. On the very first day with this, when you see this MRI, you can start the tocilizumab. That is the thing now. So this is a very important image. So bilaterally, classically involved. It looks like a metabolic disease sometimes when we see, because it's very classically involved thalamus, bilateral bulky thalamus, and involvement of your white matter, some supratemporal white matter, or some brainstem areas. We should think of acute necrotizing encephalitis.
So these are very, why I put this case, because this is a very important thing to identify, because if you identify and treat aggressively, you can make a difference. Otherwise, you are going to lose the child,
exactly.
Or there will be severe disability.
Yeah, so studies are saying if you give early, all those things at the same time, because this has a very bad long-term sequelae. 60 to 70% child will have a long-term neurodeficit throughout. So if we can give very early, we can make some difference in the child's life.
Definitely. So the message is that if you find a acute encephalopathic child with this type of MRI, go for corticosteroid and IVIG simultaneously and aggressively. Tocilizumab, because it's a high interleukin 6, the cytokine storm is there. Many people are doing CSF interleukin 6 also. So go for tocilizumab early also. That's one way. So this child also improvement, but there was some deficit after 6 months of age. So as already Dr. Jeevan has what is necrotizing encephalopathy. So we need to, Dr. Singhendu, why it is important to differentiate it from ADEM? Because
actually acute necrotizing encephalopathy is a para-infectious phenomenon. Para-infectious means it occurs during infection, and in this case it is very early in the infection. Whereas ADEM is a post-infectious phenomenon, that is it occurs after many days to few weeks after the illness subsides. Then in ADEM, in ANE, it occurs in infants and younger children, whereas ADEM may occur at any age, especially at a later age. Then CSF pleocytosis, it is found in ADEM, but CSF is perfectly normal in case of ANE. And ADEM severity is not that much, but ANE is very severe. These are the differentiating features between ANE and ADEM.
So we'll go a little fast because we are running short of time, 15 minutes more, 2 more cases to cover. So we'll go directly to case 3. So this is about ANE, and one should not miss the ANE. That's the very important message from this. Sometimes recurrent if you say recurrent ANE or multiple family members, then some genetic mutation in the RA and BP2 has also been implicated in familiar or genetic form of ANEs. So coming to case 3, so this is a 8-year-old female child, fever and headache with no altered sensorium initially, no focal neurological deficit. There is history of contact with TB. There was neck stiffness and submandibular lymph nodes were positive. X-ray chest was somehow suggestive of pneumonitis, and initially cell count was 300. Protein sugar was normal. So empirically, this was outside hospital. So empirically, they diagnosed this case as TBM. No imaging was done at that time. The child was started with 4 drug and steroid and oral steroid. And the child somehow improved after that. But after 6 months, the child again came with fever for 5 days with dullness and listlessness, decreased oral intake, and now there was a right-sided paresis with deterioration of speech. There was these deep tendon reflexes were exaggerated and plantar was extensor. So this was the presentation in the MRI. As you can see, there are multiple T2 hyperintense lesion in periventricular, juxtacortical lesion, and also in the brainstem in this child. So in this episode, this child was, but we continued the AKT, but this child was given methylprednisolone followed by oral steroid, and this child recovered in few days and again discharged. But after 7 months, this is the second relapse, it came after 7 months. Now the child came with inability to sit or stand or walk since 1 week, admitted with progressive weakness of left side more than the left side, but he had quadriparesis now, pain in all the lower limb, urinary incontinence. There was no change in speech and hair function. MRI, brain and spine was done. So Dr. Puneet, I will ask you, can you describe the MRI finding for us, and can we make what diagnosis we'll make in this episode?
Talking in terms of the neuroimaging, the child shows fairly asymmetric lesions which are involving the white matter, deep as well as the periventricular white matter. And if we look at the sagittal section, which is the third image, we find the slightly perpendicular lesions to the corpus callosum. Also, we find in the fourth image a lesion which is the cortical base, and there is also appears to be short segment transverse myelitis in the imaging of the spine. So overall, these characteristic cortical lesions, they are suggestive of a multiple sclerosis.
Mike.
Only closer to your mouth.
So the yes, this one is working. So the lesions, they are involving predominantly the white matter. Some of the lesions appear to be perpendicular to the corpus callosum, could be Dawson fingers, and with a clinical course in which the child has relapsive remitting, that suggests a dissemination in space. Here in the MRI, the child is satisfying the criteria of dissemination in time clinically and dissemination in space MRI wise. So imaging wise, this is a multiple sclerosis.
So with this CSF oligoclonal band was positive also, NMO negative. So in this attack, you say we can diagnose this child with multiple sclerosis.
So in this setting, the
in this
CSF
MRI
is
finding
very
and
specific.
with this relapsing and remitting course, we can diagnose this multiple sclerosis. So this child didn't improve with steroid. So we started the child on Plex, then he was given the rituximab also. So coming to so what are the differentiating feature and ADM and MS in this stage?
So here, if we look at the history, so multiple time interval, there are multiple clinical features, as well as if you see the radiology, there are also multiple sites of involvement, including brain, spinal cord, optic nerve. So probably it is, in spite of a low age group, it is recurrent episodes mimicking MS mimic actually. So to differentiate MS mimic from EDEM, so I can go through MR. In MR, there will be well-defined margin in MS lesions. In EDEM, there will be diffuse, and there are sites. So as classical textbook depicts that Dawson finger-like projections from corpus callosum upwards. So this a classical presentation of MS. So then especially meningeal presentation, if there is evidence of neck rigidity and encephalopathy, I will prefer EDEM, then the MS, and especially your ataxia is very less in EDEM. So this clinical plus, nobody can differentiate multiple, MDEM we call it, multiple attacks of EDEM and MS. So we have to take whole basket in consideration.
So basically in first attack, it is differentiate, we can't differentiate between EDEM and NF. When the child comes with multiple relapses and typical MRI finding, you are more certain to, because MS is a disease of young adult and pediatric MS is per se not very common. Yes. So difficult to, so that's why
another finding in your this long segment
yes,
myelitis. So when you come across long segment myelitis, it is in favor of EDEM. In MS, the involvement is very less and maybe discrete.
So Dr. Swapan, I will ask you, MS, as you all know, is a disease, pediatric MS is little different from MS in adult and young adult. So how to differ, what are the peculiar feature of MS in pediatric age group?
First of all, as you mentioned, MS per se is not so common in pre-pubertal age group, but if they present, the pattern of presentation is slightly different from MS presenting in older children, because usually they have a polyfocal presentation with ataxia is pretty common in case of pre-pubertal MS. And unlike older children, pre-pubertal MS can have some features of encephalopathy along with fevers and others, and cognitive performance impairment is also slightly more common in children below in pre-pubertal age group, and as two-thirds of the, as I mentioned, may be present in the higher, as two-thirds of pre-pubertal children in MS, and other features, boys and the sex distribution. In pre-pubertal MS group, the boys and girls are almost equally affected, and the female preponderance is seen in post-pubertal children, and hyperinterstitial lesions in MRI are very young children are not always very obvious to pick up, and not always so well defined like subcortical regions, and CSF positivity of oligoclonal is not so common in case of pre-pubertal.
So it is always very difficult to diagnose MS in pre-pubertal age group. There is a lot of overlap, so one should be exclusion. The diagnosis of exclusion, so one must be aware of this thing. So about relapse, how frequently children with MS have relapses?
Actually, multiple sclerosis are of three types: relapsing rheumatic multiple sclerosis, primary progressive multiple sclerosis, and secondary progressive multiple sclerosis. So secondary progressive multiple sclerosis does not occur in children, because by the time RRMS is converted to secondary progressive, by that time pediatric age is over. The child enters into adulthood. So RRMS is found in children. So in young children, relapse is very less, almost once in every 5-6 years. Whereas in adolescents, relapse is more, almost every 1 to 2 years. But there is a point, in very young children, it is very difficult to diagnose relapse.
Yes.
Because non-specific symptoms, and they cannot express their symptoms.
So we'll, because lack of time, 6 minutes more only, so we'll go little fast. So just Jeevan highlight what are the disease modifying therapy in pediatric age group for MS? Because MS will need disease modifying therapy. Once
So
you make
for
it
acute relapses, we always give steroid is the choice. Then for when there is a relapsing remitting course, it's always DMT, this disease modifying therapy is needed. So it is in oral form, some IV forms are there. And there are, the efficacy is also divided, mild, high, intermediate efficacious DMTs are there. So need to discuss with the family that they will prefer oral or IV, that also has to be discussed. And orals, there are fingolimod is there, dimethyl fumarate is there. And in IV, interferons are like, but these are mild efficacious. And rituximab, I think, is more commonly, because we as a pediatric neurologist use more of a rituxi. So I think this is more comfortable to give a child methylprednisolone and give 2 doses of rituximab and give every 6 monthly. So I think that is more preferable and easier one. But now we have to understand oral are also commonly used, like fingolimod is also monitoring the side effects. So need to discuss with the parents.
Generally, we are very comfortable with rituximab.
Rituximab, yeah,
Yes,
yes.
but I have no experience of using this drug, so maybe. So now coming to the last case. So a 7-year-old child presented with acute vision loss in the right eye. She has been evaluated by ophthalmologist 3 months prior to the presentation, secondary to poor visual acuity in the other eye, the left eye, and found to have optic nerve atrophy on that side. At that time of presentation, the right eye vision loss, her neurologic examination are significant for optic nerve pallor on the left with acuity limited to light and dark perception on that side, with right optic disc hyperemia with a visual acuity of 20/400, and rest of the general and neurological examination was normal. So this is a case of recurrent, he may have a prior history of optic neuritis on the left side. Now it has become atrophy, and now she has presented with acute vision loss in the left. So with this, we went ahead and did an MRI of orbit, I will show only. So there is, as you can see, there is enhancement and there is hyperintensity in the right optic nerve in this child. So MRI brain and orbit with and without contrast was done, and it demonstrated enlargement and contrast enhancement of the right optic nerve. MRI spine was normal, MRI brain was normal in this child. And cerebrospinal fluid shows 2 blood cells with normal glucose and normal protein. IgG index was normal, there was no oligoclonal band. CS serum was negative, but still, because it was a relapse, we went ahead and did a CSF aquaporin 4 antibody, and that came out to be positive in this child. So what are the common MRI, common presentation of neuromyelitis of Dr. Jeevan? What are the common presentation of neuromyelitis optica?
So NMO is also not very commonly we encounter. Mogard, all those are more commonly we see. So, but we need to be aware of these situations also. So as sir said initially, spinal cord, optic nerve, and brain. So these are the 3 sites. Whenever we see any lesion in MRI, never forget to do a spine and a optic nerve cut. In optic nerve, this NMO will involve more of a posterior pathway involving even the chiasma also. So that is in your optic nerve. In spine, there will be a longitudinally extensive transverse myelitis. That is more than 3 segments of the spinal cord will be involved. And other in the brain, there are some, this NMO has a very typical presentation involving the peripendymal regions, which is rich in the aquaporin antibodies, and especially the peripendymal region of 3rd and 4th ventricles. And they may have edema-like lesions in the cerebrum, white matter, apart from this. And involvement of your diencephalon, thalamus and hypothalamus is also there. So these are like array of all, if you see optic, along with optic neuritis, there is long segment elytium-like features. And MRI is showing a typical peripendymal regions, medulla being involved, the area prostrema involved. So these are classical of NMOs.
So these are the classical areas of brain. Area prostrema syndrome can sometimes present with persistent hiccup, nausea, and vomiting, and no other findings. So these are the common areas of the brain where aquaporin 4 antibody is more prominent. So these are the more commonly involved area. As already Dr. Jeevan has highlighted, the brainstem, the diencephalic region. So these are the more common. And cerebral involvement can also be there in the form of non-specific white matter lesions in NMO. But this long segment involvement of spinal cord is very typical of neuromyelitis optica. So whenever you are seeing a long segment spinal cord involvement along with other features, think of NMO and go for aquaporin 4 antibody testing. So diagnostic criteria, sir, we'll skip this one. There's a lot of big criteria. Just in two lines, sir. Huh? Not much. Only 1 minute.
When aquaporin P4 antibody is positive, diagnosis of NMOSD is very easy.
Yes.
Because you need that positivity plus one of the core clinical symptoms and exclusion of other diagnoses. But when aquaporin P4 antibody is negative, then you have to, it is difficult to diagnose, but you have to have two core clinical symptoms. One of them must be from the past three, like optic neuritis or spinal cord involvement or area postema involvement. And also there has to be dissemination in time. So at least 2 attacks has to be there, have to be there to diagnose NMOSD.
Yes, sir. Because both NMO and MS are relapsing remitting, so we need one episode you can't diagnose if it's negative, then it's definitely. So, Dr. Puneet, what are the tests recommended for initial diagnosis? Okay, sir. No, you can continue.
So as for all the demyelinated disorders, the MRI brain, spine and optic nerves with contrast is a must. Without that, I don't think so we can go ahead and diagnose. And more importantly, we should not be giving steroids or other immunomodulation without the contrast imaging involving all these 3 sites. Along with that, for the NMOSD, as sir said, positive aquaporin 4 antibody with ruling out the other differentials, closed differentials or the mimickers, it is virtually diagnostic of NMOSD. So, and also because Dr. Kulkarni was previously talking about the co-positivity of MOC. So in all the demyelination cases, we repeat this MRI and CSF oligoclonal bands and serum aquaporin 4 antibody and MOGAD. So this is kind of the complete workup for demyelination.
Very nicely. So don't forget to do a contrast MRI. This is very important. Many times we do a plain MRI and again sending the child for contrast becomes difficult. So as pediatrician, you must remember that you are suspecting demyelination, always ask for a contrast MRI in this child. So that will give you a lot of information. So this is important. So how to do this testing for aquaporin 4 antibody?
Yes, so we have to see the source. Where is the source? Source is the blood. From blood, it has to go to the brain. So your plasma cells. So sometimes we have seen that loss of vision, optic neuritis, steroid from OPD. And this can cause your suppression of the antibody producing cells and you may not get your positive aquaporin 4. And that's why you may get after an interval, maybe after 1 month or so. So if there is high suspicion, you have to go on checking the antibodies.
True. If you have high suspicion, you can go for repeat this antibody testing also. So what are the best treatment options, sir?
As usual, like in other demyelinating disorders, the treatment is divided into acute phase and preventive therapy. Acute phase always is, first line is IV methylprednisolone, same dose. The second line is, of course, plasma exchange and or...
Sir, Mike.
First line treatment is always the IV methylprednisolone, and second line definitely is either or plasma exchange or IVIG. In the preventive therapy, the preferred drug always is azathioprine to start with 2 to 3 milligram per kg per day, and that reduces the incidence of relapse, and also 60% of the patients, they remain attack-free for at least more than 1.5 years. The other options these days are available. Of course, they are much better and much safer options, quickly acting also. Rituximab, as we have already discussed, at the same dose as we have mentioned, 375 per meter square. And of course, mycophenolate mofetil and methotrexate are other options. The more newer therapies, like we have already discussed, eculizumab and other tocilizumab and aquaporin, like all these newer modifying drugs, they are available.
So mostly we are experienced with rituximab. We give a lot of
effort
to prevent relapse. So how long you are going to give rituximab in a NMO positive patient?
Yeah,
Dr. Puneet, Dr.
Priyankar Pal will be a better person to talk about how long we can use rituximab anticipating the relapses.
There are no controlled studies or big studies in the pediatrics because demyelination as such is very rare in the pediatrics. So there are no trials as such which have looked at the different durations of disease modifying therapy or preventing therapy to see which one is better. But what usually is practiced that we continue the immunomodulation for 5 years. So for rituximab to continue rituximab for 5 years in a country like ours where the infection rates are very high, so what can be individualized is that when the disease activity is high, when the child is having multiple relapses, we can continue rituximab. And then when we see that the disease activity has come down, the MRI has stabilized, the symptoms have improved, then we can switch on to the azathioprine. Azathioprine is a very good drug for NMOSD. It is cost effective, but given that we monitor for the bone marrow suppression and the liver and the renal toxicity. The other drugs, eculizumab, other new immunomodulators, they are limited by their high cost.
High cost, true. So, time is over. So, now a quick MCQ for this audience, pediatrics resident.
We just have 1 minute left.
1 minute, yes, sir.
Just 1 minute.
So, which is the following characteristic is a feature of acute disseminated encephalomyelitis? C, very good. Then, in children with MS, which of the following is true regarding the course of disease? B, very good. So, which of the following is an indication of plasmapheresis in children with demyelinating? All has been discussed. C, very good. So, in managing a child with acute demyelinating disorder, which supportive care is most important? A. Okay. Thank you so much. Thank you. Thank you for it. And I thank my panelists for the active participation. Thank you so much.
Thank you,
so much.
Debashish and all the panelists. It was a wonderful session. We have a 5-minute pause or interruption, and I'm handing over the mic to Dr. Joshodhara. Please stay back.
We would now like to welcome our National Treasurer of Indian Academy of Pediatrics, Dr. Atanu Bhodro, who has come to us on the dais. And sir, please come to the dais. And to felicitate him, I'd like to welcome President of AOPN, Dr. Sanjeev Joshi sir, and President of East Zone Neurology, Dr. Orichi Chatterjee sir. Kindly felicitate Dr. Atanu Bhodro sir.
There is only one ADSDI. It is okay? It is okay? It is not showing?
Thank you for the excellent panel. Now we will move on to your next session, which is on cerebral palsy and neurodevelopmental disorders. So I would like to call upon our chairpersons for this session, Dr. Shutapa Ganguly ma'am and Dr. Joydeep Ray sir. I would like to request our chairpersons to please call upon our first speaker.
Good morning, all. Now, after 2 sessions for hardcore pediatric neurologists, we are going to have a very important session on 2 neurobiological behavioral disorders which we are facing more and more commonly these days in our office practice. So, to, for the first lecture, I would like to invite Dr. Shoshmita Devi Agarwal, and she will speak on management of ADHD.
A very good morning. At the outset, I will wish to thank to the organizing committee and our national leadership for having me here today. My topic is attention deficit hyperactivity disorder. I will wish to have the attention of all of your attention for this topic because in the clinical practice we are getting many cases the incidence of ADHD has increased in the recent past very much. So you can see, whenever we are thinking about ADHD, means it is a very difficult child, okay? It is not that much difficult. If we can plan the management properly, it is not that much difficult. You can see here, even Albert Einstein, Abraham Lincoln, Graham Bell, Tom Cruise, and this gold medalist in Olympic gold medalist was having ADHD. So it is not difficult. Don't label them as a difficult child. So why we must know about ADHD if we cannot treat, if we cannot manage them, that will lead to academic deterioration, poor self-esteem, and because of hyperactivity, they will be prone for many kinds of accidents, substance abuse, self-injury, and will have a difficult peer relationship. So to control all these things, to avoid all these things, we should have a management, proper guideline, proper plan of management for the ADHD. So how the ADHD children are coming to us, as I've already told, they are the difficult child, right? So how they are coming to our OPD, you can see here, a 6-year-old male child brought by the working parent to the OPD with frequent school complaint of teasing others, okay? Don't pay attention to the studies. And he's very good at vocabulary and oral examination, but poor in writing skill. Means you have poor attention span, okay? That is the common presentation. And second one, you can see a 9-year-old boy changed to school in the recent past, beating his classmates and even the older sister, 16-year-old older sister. And he's very good at math. That means he's very intelligent boy. And both the parents are IT sector, working in the IT sector. And you can see here, he is having his own room with lots of toys, video games, smartphones, and television of its own. That means this environment is precipitating the ADHD. That you don't treat the child, you treat the parents and the environment to control the ADHD. Now coming to my topic proper. So what is ADHD? We must know what is ADHD, then we can plan for the treatment. And we must know the etiology so that we will plan for the management. The core clinical features and the subtypes of attention deficit hyperactivity disorder. And if the time will permit, I will differentiate how to differentiate a pure autism from ADHD. And the comorbidities should be treated also in cases of ADHD. And what are the diagnostic or evaluation or assessment methods are there to confirm the diagnosis of ADHD and definitely the management. So ADHD, it is defined as a neurodevelopmental disorder due to defect in the frontostriatal network, manifest early childhood with 3 core symptoms, that is inattention, hyperactivity, and impulsivity. So the ADHD diagnosis should be after the age of 3 years, at least 4 years, we can diagnose ADHD, not before that. The criteria are the behavior must be developmentally abnormal for that particular age. The age of onset should be below 12 years and it should be after 3 years. The duration should be 6 months, not for 1 day. Madam, today वो class में बहुत disturb कर लिया, सबको पीटने लगा. That is not ADHD. That is only in one setup, one time, right? It should be present for 6 month duration and 2 or more setting. The child is very aggressive, very hyperactive in the school, in the house, but he is very obedient in the school. That is not ADHD, okay? Should be in 2 different settings. And there should be clinically significant impairment due to the hyperactivity, inattention, there is decreased scholastic performance, then we can think of ADHD. And not explained by any other disorder, then we can put under ADHD. And according to the DSM-5, the I will tell later on, 6 out of 9 symptoms should be present of the DSM-5 to confirm the diagnosis of ADHD. Now you can see how the ADHD present. It is a very difficult child, but it is not that much difficult actually. Now if you look at the etiology, because it is a neurodevelopmental disorder, definitely genetics plays a very important role. Environment, as I have already told, this IT parents and many lead poisoning and many other things are leading to ADHD. And anything during the perinatal period, like a preterm, low birth weight, and IUGR, they are prone for all type of neurodevelopmental disorders, including ADHD. Now, the common syndromes associated with ADHD are Klinefelter syndrome, Fragile X syndrome, Turner syndrome, 22q deletion syndrome, William, and neurofibromatosis type 1. So if a boy coming with ADHD, you should do the Fragile X syndrome to rule out, because it is a treatable condition. Now coming to the subtype of ADHD, predominantly it is hyperactivity and inattention type, predominantly impulsive type, and combined type. There are 3 types of ADHD. Now coming to the age of presentation, hyperactivity and inattention type typically by 4 years of age, and impulsive type, inattention type typically not till the age of 8 to 9 years of age, and hyperactive and impulsive type, they start by the age of 3 to 4 years, peak at 7 to 8 years. Hyperactivity declines by adolescent years and then almost disappear. Out of the 3 core features, hyperactivity, inattention, and impulsivity, hyperactivity will go with the age. Impulsivity and inattention, it will persist throughout the life. Impulsivity persists throughout the life, always influenced by the child's environment. Now coming to the HI type, that is according to the DSM-5 criteria, the first is excessive fidgetiness, difficulty in remaining seated when sitting is required in the school or at workplace, feeling of restlessness, difficulty playing quietly. He cannot play quietly, as you know. I am showing that picture, the same picture. Difficulty to keep up with seeming to be always on the go. He cannot sit in one place, always on the go. Excessive talking, without any reason he is talking, he is explaining his thing, he is talking a lot of things, you think of ADHD. Difficulty waiting for his turn. You are asking 2 plus 2 is how much to this student, he will be answering 2 plus 2 is 4 before the question ends, and blurting out answers too quickly, and interruption or intrusions of others. So 6 out of this 9 feature is present, we can diagnose ADHD. Now inattention type, it is little late onset by the age of 8 to 9 years. Hyperactive type present after the age of 3 years, by the age of 4 years, okay. Inattention type, it is 8 to 9 years. It progress lifelong. Impulsivity and inattention will persist throughout the life. Impulsivity will not cause any harm, but definitely you have to take care of the inattention so that he can do good in his field. Now the symptoms of inattention are failure to provide close attention to the details, so he will be doing the careless mistakes. Difficulty in maintaining attention in play, school, or home activity. Seems not to listen even when directly addressed. Fail to follow through the homework. Difficulty in organizing the task. Avoid tasks that requires consistent mental effort. Loses object required for task and activity. Always you will forget the pen, pencil, books, and many things in the school. easily distracted by irrelevant stimuli. Even the classroom, the door will open, he will look at the door, who is entering into the class. The window, something is happening in the window, there is raining, he will see outside that what is happening outside. So easily distracted by the irrelevant stimuli and forgetfulness in the routine activities. So 6 out of these 9 criteria is present, we can diagnose ADHD. Now, how to differentiate ADHD from autism spectrum disorder? If it is a simple ADHD, and most of the autism spectrum disorder will be associated with ADHD, that is a different scenario. If it is a pure autism spectrum and pure ADHD, how to differentiate that? You see, in autism, the communication will be delayed. It is a social and communication disorder, so they will not be able to communicate. But in ADHD, the communication is good, but it is delayed. Attention, it is very difficult to have the attention in autism, but yes, it is difficult in ADHD also, but you can bring back the attention. Focus is self-focus or fixed focus in autism, but in ADHD, multiple focus, here, there, he is not sitting in one place, that means it is ADHD. And the child is playing the same thing repeatedly, that is autism. Language, there will be echolalia, and ADHD, that will be normal. I mean, what is your name? My name is such and such. In autism, what is your name? The answer will be, what is your name? Now, coming to the emotion, there will be lack of sympathy. In autistic children, they will not have any sympathy, but ADHD definitely will have the sympathy. If there is a group play, the teacher will fall down. All the children will say, "Oh, teacher, do you have anything?" But in autism, he will not respond anything. Whether he has fallen, whoever it is fallen. Joint attention will be absent in autism. It will be present in ADHD. Early development in autism may be normal, may be delayed, or there may be regression. But in ADHD, the development will be normal. By this way, we can differentiate autism from ADHD. Now, coming to the workup, no testing or imaging is usually required in ADHD. If they are fulfilling the DSM-5 criteria, 6 out of the 9 criteria is present, we can diagnose ADHD. It is a clinical diagnosis, like autism is a clinical diagnosis, ADHD is also a purely clinical diagnosis, but if there is some underlying etiology, genetic etiology is there, or any comorbidity is there, you should go for the investigation. Rating scales, there are various rating scales are there. I will not go into the detail about the rating scales. We can use that to understand how severely the child is affected. And consider psychological or neuropsychological testing if the cognitive ability is low, or if you are suspecting any kind of genetic etiology, you should go for the genetic study. But ADHD is a clinical diagnosis. By using the DSM-5 criteria, we can diagnose ADHD. Now, what are the screening tools available? The first is child behavior checklist, Corners rating scale, Vanderbilt rating scale, and INCLIN we are commonly using. But again, I will be telling, by using the DSM-5 criteria, you can diagnose ADHD. Now, again, this is the repetition. Below 17 years, you need 6 out of 9. And after 17 years, you need 5 out of 9 criteria to confirm the diagnosis. And the symptoms should persist at least 6-month duration. And the age of onset should be below 12 years. These are the criteria to diagnose ADHD. Now, coming to the comorbidity, ODD, conduction disorder, specific learning disorders. 70% children with ADHD will have a specific learning disorder. Anxiety, depression, antisocial, OCD, tics, and 40% of autistic children will have ADHD because of lack of communication. They cannot communicate with others. That will lead to hyperactivity, attention deficit hyperactivity disorder. Now, coming to the evaluation and assessment, the guideline, American Academy of Pediatrics 2011 guideline, any child from 4 to 18 years of age coming with decreased scholastic performance or any kind of behavioral issues, you assess for ADHD. rule out ADHD. Why? Because it is a treatable and manageable condition. He can be Tom Cruise, Abraham Lincoln, and he can be the gold medalist in the Olympiad. So it is our responsibility to identify as early as possible and plan the management for them. Now, what is the management protocol? The first is parental intervention. This is a neurodevelopmental disorder. In majority of cases, the environment plays a very important role. So you have to explain to the parents that they will change their behavior, they will change the environment. In majority of cases, without any medication, if it is a mild ADHD, they will improve. For example, don't tell the child, don't jump on the sofa, it will break, I will beat you. Come and jump down. He will never come and jump down. He will jump there only. So you ask, you don't give the option. Okay. So parental intervention, behavioral intervention, cognitive behavior therapy, educational intervention, psychotherapy, medication, and combined. Now coming to the behavior therapy, positive reinforcement therapy. So whatever he's doing good, you encourage, yes, you have done a very good job, and give some token money. For every good thing, you give some money or give some pencil that he can count. 1, 2, 3 pencil, okay? For good behavior, 3 pencil, and bad behavior, reduce 1. So at the end of the day, he will understand that he earned 20 rupees or 20 pencil and he lost 8 pencil. So from inside, he will think that I will correct my behavior and I will be the winner all the time. I will not lose anything. That is the positive reinforcement therapy and token money. And time out, punishment. Ask the child to sit without moving the hand and leg for the 5 to 10 minutes for any kind of very hyperactive and bad behavior. This is behavior intervention. Then, this is very important. These ADHD children are telling, if I cannot learn the way you teach me the way I can learn. So it is our responsibility, teacher's responsibility, to make a protocol for the child to teach. So how to teach? You can see individualized educational plan or individualized educational program is required. What is that? One-to-one in the classroom. Classroom modification, accommodation. I mean, ask the child to sit in the front row, in the middle, away from the door and the window, so that he will not be distracted by opening of the door and the windows. And don't teach all the subject. For example, there are 5 subjects per day. You teach him for 2 to 3, okay? In other countries, in the European and American setup, what they are doing, if the period is for 45 minutes, they are teaching for 25 minutes and ask the child to play for 20 minutes in a special area under observation, so that they can see the child, what he is doing actually, and after 20 minutes, he can return to the class and can listen to the teacher in the next class. And second is, for the parents, ask them to maintain the daily schedule and ask the teacher also to daily schedule, and they will exchange, the parent and the teacher will exchange the schedule. As I have already told, keeping the distraction to a minimum, limiting the choice. As I have told, don't jump there, jump here. You should tell like that. Providing specific logical places for the child to keep his schoolwork, toys, and clothes. Setting small reachable goal. I mean, if you want to give the homework, give homework of one subject. Don't give homework of all the subjects, math, English, science, and education. No, only give math, only give science. By that, they will improve. And rewarding, as I have already told, rewarding for positive behavior, and finding activities in which the child is successful, so that he will regain the confidence that he can do well in that in the reading also. So basically, the ADHD is due to decreased dopamine, norepinephrine, and serotonin, which is leading to decreased attention and decreased arousal and impulse control. So what are the drugs we are giving? Is the CNS stimulants like amphetamine and methylphenidate. So what are the medication? I will wrap up quickly because there is no much time. Stimulant medications are highly effective in controlling the core symptoms. Start with stimulant followed by non-stimulant. Give the stimulant for 6 to 8 weeks followed by non-stimulant. Start with low dose and if possible, a sustained release or extended release capsule. And add cyproheptadine. Whenever you are starting methylphenidate or something like that, they will have a loss of appetite and headache and irritability. In that particular condition, if you add cyproheptadine or you add clonidine, these two combination will work and they will respond very nicely. If any side effect, decrease the dose or you can discontinue the medication. Now, what are the stimulants commonly used is methylphenidate.
35 seconds only.
5 seconds, okay. Dexmethylphenidate, amphetamine, methamphetamine, and others non-stimulants like atomoxetine, guanfacine, clonidine, and these are, I will not go into the detail of the doses. I think everybody is knowing that I will not go to the dose. And in the preschool, if it is a mild ADHD, go for the behavioral therapy only. Positive reinforcement therapy, token, money, time out, that is enough, along with the cognitive behavior therapy. If not responding, then go for the medication. I will not go to the detail about these are the alternatives, like if has a sleep issue, go for melatonin, you can supplement with omega-3, megavitamine, and some diet, particularly high sugar diet should be avoided. Most important is high sugar diet and preserved diet. Don't allow to take any kind of chips, biscuit, and anything which is packet food, because there are so many preservative. What that preservative is doing to the developing brain, we have no idea. So try to avoid that. And these are the newer drug. I don't have any experience about the new drug, but
Madam,
this is
can you
theoretical.
wrap up, please? Can you please wrap up?
Yeah. So duration of medication, predominantly inattentive type, only in the school days, peer relationship issues daily, and duration after several years, try up. I'll not go to the differential diagnosis. Now conclusion is a neurodevelopmental disorder, should begin, the age of onset is below 12 years and should be after 4 years. After 3 years of age, you should think of ADHD. Long-term impact if not treated. Defect in the frontostriatal network. Behavior therapy with stimulant medication works very well. And don't take them as a difficult child. It is their duty to enjoy and be little hyperactive.
Thank you.
Thank you very much. They are
Thank
smart but scattered. Let's find a way to stop them being scattered. Thank you very much.
Thank you for your nice presentation. Madam already mentioned the differences between the ADHD and the autism. But really, when we came across the cases, we already has mentioned these comorbidities factor can, along with this ADHD, 40% cases is along with the ADHD. It is a clinical thing definitely, but sometimes it is very difficult. So our next speaker is none other than Dr. Ashok Datta. He will speak on the autism, and he is the president of West Bengal Academy of Pediatrics. Dr. Ashok Datta, please.
Good morning to all, respected chairpersons and the esteemed delegates and the gatherings of them who are waiting for the total conference. I'm very much hopeful the discussion. Now, autism spectrum disorders, actually everyone we know what is that. It has been discussed several times at different forums, starting from the Indian Academy of Pediatrics to every peripheral branches it has been discussed. But my questions are only 3 or 4. Is the option which are available for the management of autism is feasible in rural India? This is number 1 question. Number 2, is there any other alternative methods to treat the children with the autism? These are my 2 focuses which I will discuss. Remember, whenever I am talked, I will say anything about autism, it means autism spectrum disorders. And it is for the residents that autism spectrum disorder comprises of not only autism, but other syndromes like Asperger's syndrome, like childhood disintegration syndrome, where the child was normal up to the age of 2 years and then suddenly deteriorates the conditions. or it may be pervasive developmental disorders, not otherwise classified. It means it is not purely the features of autism, but the child is in older age, to some extent 6, 7 years of age. So these are the different components of the spectrum disorders. So when I talk about the autism, it means I am speaking about the autism spectrum disorders as a whole. Let us do the prevalency. You will get the different records at the different times. Yesterday we have heard that it is 1 in 36. Now you see that this is published from India, that is 1 in 65 to 9 years of age. So what it may be the prevalency is increasing, that autism cases are increasing. Those where we are practicing every day, even to the general practitioners, they will say definitely that we are getting large number of autism patients or behavioral abnormal patients. Is the patients are different from the rural and urban area? This is one question. I searched the literature, I found that there is no difference. Incidences are same in rural and urban area. It means what autism patients are seeing in Kolkata, that is also patients in very interior rural districts of West Bengal or Bihar or any other areas. Usual presentation, my previous speakers, she has elaborately explained. I am not going in details. I am skipping this slide. The most important thing is that these children, they are not responsive at all. They are aloof. You are asking something to the child, he will not respond. And the common presentation by the parents is that my child is not speaking at all. And another group is not communicating at all. So not interested. The parents are coming from the office and saying that the child is not looking to them at all. So where from this disorder arises? In India, the recommendation is that we should start scanning from 18 months to 24 months of age. And if the age of the child is below 12 months of age, if you suspect that there is any problem, you should screen again after 1 month. And if it is less than 12 months, then it should be after 3 months. My next speaker, Dr. Sharmila, will be there. And she will also elaborate in office practice how will detect by the autism spectrum disorder. And everybody, we know also that by modified checklist of autism toddlers, or MCHAT-R, and the follow-up, MCHAT-RF, they are very important tool for screening, and we are aware of that. Those who are aware about the early child development, the program going on long time for the last few years. So this is the time of screening. My question is that, is it true we should start suspect screening from the age of, say, 12 months or less than 12 months, or should we think it for before? Answer is that literature says that autism child may be suspected from very early period. Even you can suspect the autism from 4 to 6 months of age. Now here is the question of one thing, that is about the biological motion development in human beings. I have written this article in the souvenir of this conference, how the biological motion develops, how the human beings recognize the biological motion. There are two types of motion recognition. One is the biological motion, where the nucleus is situated in the superior temporal sulcus, and another is generalized motion, where the nucleus is situated in the medial temporal sulcus, and in association with the other areas of the brain, like, say, cingulate gyrosis, like prefrontal cortex, like the mind of the brain, the area 39, Barnick's area, they are all involved in the development of the human motion, biological motion. And it has been found the autism patients, due to various reasons, I am not going into the causes of the autism. Autism may happen due to genetic disorders, present in majority of the cases. Sometimes it may not be present. Sometimes maybe copy number variations. Sometimes it may be single genetic mutations. Sometimes it may be followed by some metabolic disorders like tuberous sclerosis, like 3-beta hydroxysteroid dehydrogenase deficiency, or sometimes it may be due to some other chromosomal abnormalities, a Down syndrome or Fragile X syndrome. Fragile X syndrome gives rise to 30% cases with autism spectrum disorders. Even if it present in the intrauterine life, if you do the amniotic fluid examination, you can detect the Fragile X syndrome in the newborn or the baby in the intrauterine life. So much is the importance. I'm not going into details of that. But what is that? You can detect the child is not interested to you. Parents, baby is not laughing or smiling towards the child. Baby is not interacting with the child. Baby is becoming aloof. You are moving a lead ball in front of the baby, baby is not looking at all. There is no vision defect. But here the baby is aloof. You are doing some interesting sound, baby is not responding. It is not the hearing defect. Hearing is intact. You have done the Vera test or other test. Where is the defect? Baby is not interested to that. So it can be detected from the very early period, and parents will have to interact. I should not say detected, it should be suspected in the very early period, and parents should interact with this type of patients from the very early. Why the very early cases are giving so much importance? Because the brain plasticity, huge brain plasticity is present in the first 2 years. And we can take the help of that if we find any abnormal. So it is our duty to teach the parents, when you suspect that there are some problems with your baby, so that they can interact. So whenever the scanning is positive, we should look for the history, everything in detail, starting from the intrauterine to extrauterine in the newborn and early infancy period, whether there is catastrophe, any dysmorphism, or any Fragile X syndrome features, or any developmental delay, not only to gross motor, fine motor, or oromotor, but also to language, non-verbal and verbal language, as well as the impulsivity and activity. All these developmental spheres, as per the Capote triangle, this is a very important triangle, known as Capote triangle. Capote triangle is professor of Johns Hopkins Medical College. Capote triangle is an important triangle where the tip of the triangle is motor development, and in the sides, one side there is a hyperactive attention, and the other side the language concerned. If we follow the triangle, we can detect any development issue easily. Go to the investigations. Susmita Devi, my previous speaker, discussed that there is no important clinical diagnosis is not very important, except in suspicion of, if there is Fragile X. You will have to do the DNA query. If you see some brain involvement is there, some sort of, convulsion is there, you should do the EEG, or if you see any other things, as per requirement, but it is not for the autism. Now it is a fashion to do the MRI in all cases of autism. It is a fashion to do the genetic study, whole exome genome sequencing in all cases of MRI. I am not telling that these are not important. These are important to some extent. And there are lots of examples where the simple copy number variation can give rise to two types of syndromes. For example, the autism spectrum disorders, the addition of chromosome number 7, some part of the chromosome extra addition, and Williams syndrome, the deletion of that part of the chromosome from that chromosome number 7. And you are getting two types of pictures there. So that may be. But what is the gain of the parents? Do, adjust this chromosome again? So it is not possible. So there may be some important the next issue that can be done. Your diagnosis is from the clinical criteria. And in India, we usually do the DSM-5 and increase tool. And from the Indian scale for assessment of autism, ISA, where you can gratify or stratify the degree of autism, mild, moderate, or severe type of autism. And childhood autism rating scale is another scale. But what the IIP recommends is diagnosed by this DSM or INT tool and grade by ISA tool. What is the accepted management till now? Applied behavior analysis therapy, or my previous speaker told that behavioral modification concept. In case of good behavior, positive reinforcement. In case of any bad behavior, negative reinforcement. Go to how much therapists are required for this. You see the recommended program requires 1:1 or 1:2 child to therapist ratio suggested by the consensus guidelines. And each therapist, how many number of therapists are required? Under the developmental pediatrician, you go child neurologist, psychiatrist, psychologist, occupational speech and language therapist, special educator, nutritionist, social worker, sensory integration therapy, music therapy, play therapist. So there may be 12 or 13 therapists required for single child, and each therapy ranges from rupees 500. What is the average rate of therapist? I studied this. There is an article. Article says that they have studied throughout the India the range from 500 to 3,000 or 5,000 per setting, per therapist. So if there is 15 therapists, and average is 2,000, to 30,000 per setting for the child. Is it possible for the rural child to spend all this for this ABA therapy? So I think in India, ABA therapy is not applicable, or it may be partially applicable. It is a very controversial drug because it is accepted throughout. Nobody will say that this is just at per line, but this should be in India. It is not possible. In India, it is feasible people for India. No, answer is no. So what is the intervention which is required? Well, the parental-based therapy, go to that. Parental-based therapy, where the parents should be the therapist in all lives. You should not be, or we should not be therapist dependent. If we are dependent on the therapist, then we will not follow up the patients, not able to catch up the patients, and the patients will, at the end, there is very bad prognosis of the patient, no improvement. There are different programs based on the total therapist dependent programs is ABA therapist, only under the control of the doctors. The structure stitching are there, this is also therapist dependent. Integrated program, that is also therapist dependent. Cognitive behavior therapy is very important therapy which doctors can give you also that. And that can be very much helpful for other problems associated like say depression, anxiety associated with the autism spectrum disorders. Pharmacotherapy, it is pharmacotherapy required in cases where there is associated problems. Like if there is convulsion, give antiepileptic drug. If there is ADHD, give the ADHD drugs which is proposed just before. If there is sleep disturbances, melatonin is required. If there is any other problem like say depression, anxiety, etc., give the fluoxetine. Or if there is, so if there is things of other problems, repetitive activity, again fluoxetine is required. If the very aggressive behavior, risperidone is a good drug. So those are required pharmacotherapy. Nowadays there are other pharmacotherapy are there, like say L-carnosine increasing brain stimulating agent like BNP. That is also drug which is under trial. We should not recommend that. There is another drug which is discussed in the last year is Oltrebin. There is another molecule that is coming up that can suppress the inflammation. Nowadays it is also considered as an inflammatory disease of the brain. And one of the scholars from Boston University published 2 articles 5 years back in relation to how the free radicals is causing autism. That is published in different literatures. And now it is accepted that probably the inflammation in the brain is causing the autism. We should suppress that inflammation by giving some drugs. So those are under study, so under evaluation. We are not going in details for that. But one thing is that melatonin has some important role because it has been found by Cochrane-based study that 60% of cases of autism has sleep disturbances, so melatonin has a very good role. So what is my focus of this today's discussion? It is not discussion of the general autism study. It is the parent-mediated early intervention is essential. Now this is accepted by the different authors. This article is published in Pediatrics in 2015. Another article published in 2017 by Indian Pediatrics Consensus Statement, I am showing that in the later on, and therapist, so parents should be that. Appropriate individual education plan is a early start Denmark model or to take therapy. So of which the early start Denmark model, more parents dependent in comparison to take therapy. Take therapy, you see the structure, if every just visual support and individual instruction, but here the family is involved, not giving full liberty to the parents. This is the drawback of this therapy. They are using the visual schedules, picture exchange, task analysis, social stories, etc. But all families are involved, but they are not giving full liberty. Individual assessment, it definitely shows some improvement is there. So outcome is also not very bad, but here the cost of the therapy prohibited is used in the rural India. In the Denmark model, here the therapist will teach the parents about the management. Parents are given more important here in the Denmark model, early start. By Dr. Rogers and others, they published this model, started from 1 year to 3 years of age in the early intervention. And they're giving more important to the parent, but therapy is required. So this is a mixture of the two, ABA and parents. Mix of the, this is evidence-based therapy. And now it is accepted by many people, and there are literatures at large numbers in relation to this therapy. The parents are involved. So every individual, every patient should be taken as individual. Parents are taught about the requirement for a particular domain, and after a few months assessment, a good result is there. So this is the same things. I'm not going to that. This is another program. This is not studied extensively in India. It is studied in America, but not accepted. It's not evidence-based. But this program shows that solely parent-dependent. Now, what are the components of this program? Finding out the isms. Isms means what is the repetitive activity. Join with the child by doing some playing activity. And when the child looks at your face, you see the child is motivated, and taking advantage of that motivation, do some activities of the child. And they are saying in this theory that
please wind up
there is some
your
improvement.
lecture because only 35 seconds only.
So it is a child-led program, nurturing environment there, and play-based approach is there. Limitation, it is not evidence-based. Now there is a disability certification is going on. There are lots of programs are there where in relation to that, say insurance, early intervention, scholarship, etc. by the government of India, we should use those programs. And IIP suggests that disability autism certificate should be given by the team, psychologists, psychiatrists, and pediatricians. And below 18 years, it should be 5 years, above 18 years, it should be permanent. This is acknowledgement, and thank you for your patient hearing.
Thank you, Professor Datta, for your extensive discussion on autism. Since the time of question answer is also used up, we can invite 1 or 2 questions at the end of the session. Thank you, sir.
Thank you, ma'am. Thank you.
Now I would like to invite Dr. Shormila Banerjee Mukherjee. She is the professor of pediatrics, Lady Harding Medical College, and her area of interest is developmental pediatrics, and an excellent orator. Please deliver your talk on operationalizing the evaluation of a child with autism in office practice.
Okay, so while he's putting everything here, how many of you, how many of you are aware of the DSM-5 criteria for autism spectrum disorder? Can you just give a show of hands, please?
Okay. And how many of you are postgraduate students? Show of hands. Okay. So that means the rest are all, the delegates are all practitioners
I think,
and
Surmila,
faculty.
mic is not working.
It's not? Is it? Huh. Audio lagi diye Actually, I have a couple of videos, so we're just checking whether the audio is working or not. Okay. So, coming back to my question, how many of you are suspect autism in your clinical practice? Show of hands. Okay, so lots of people are suspecting. Sure. Amke normal data lage do. Normal data standard. Emni kore amar bhal lage na. So what do you understand by operationalizing? I've used this word, operationalizing. It's like when you, all of you know how to assess dehydration? WHO stages of dehydration. Suppose you didn't know how to do a skin pinch. Would you be able to assess dehydration? So similarly, in autism, the clinical diagnosis depends upon your expertise at picking up symptoms. And the symptoms of autism or any neurodevelopmental disorder is slightly different from other run-of-the-mill pneumonia, diarrhea, etc. So here this talk has been customized for postgraduate students as well as clinical practitioners, basically how to go about diagnosing a child with autism. This is for general pediatricians. This is not for developmental pediatricians. Developmental pediatricians already know. So we'll be discussing when to suspect autism, what are the steps of a comprehensive assessment. I'm going to outline the strategy that we use in our hospital, how to obtain clinical information by establishing diagnosis based on DSM-5, familiarizing with the multidisciplinary management, which sir has made the job pretty easy for me, and the roles and responsibilities of a pediatrician for families, not a child and the families with autism. So for a medico, by definition, autism is a neurodevelopmental and behavioral condition of childhood, which is characterized by persistent deficits in social communication and social interaction, and the presence of restricted, repetitive patterns of behavior, interests, or activities. Blah, 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 blah. Is the patient going to come and tell you, Dr. Saab, my child has a problem in social communication? Is he going to come and tell you, my child has restrictive interests? No. He is going to tell you lots of complaints dealing with behavior and development. So you as a general pediatrician will need to understand what these are, the criteria, and how to fit this piece with this piece. And only then will you be able to make a diagnosis. So when the parent talks about the child, he will talk about these core symptoms. The core symptoms which I just enumerated, but that will come out as issues in behavior, issues in development, issues in social interaction, issues in play. And these are all either age inappropriate or unusual or atypical. And also he might come with some comorbid condition. So these are the two things that you will need to, as a pediatrician, pick up. And also for him, children with autism, their parents have a problem, because on one side you can see the spectrum. On one side you have extreme ability in some areas, like you all are familiar with My Name is Khan. And on the other side you have severe disability. And parents get very confused because some kids can do really very intelligent things, but on the other hand, they don't know how to eat, they don't know how to brush their teeth. So if they can't figure out, my child, is he intellectually disabled? Is there a problem? But if there is a problem, then how can he do this? So there's a lot of confusion. So what are the challenges for us as pediatricians? A lot of us do not have the expertise. A lot of us know that, okay, autism is a theory, long question which comes in the exam. But translating that into clinical practice is challenging. And all of us have a very heavy patient load. And we have this mindset that, okay, autism diagnosis or any neurodevelopmental disorder will take at least an hour, 2 hours, 3 hours, who has the time? Because of that, pediatricians state, okay, I have to refer to a developmental pediatrician. And for the parents have this need for an instant diagnosis. If you can give me a diagnosis of asthma, if you can give me a diagnosis of diarrhea, why can't you give me a diagnosis for my child who's having a developmental problem? But we know that's not realistic, but they don't know that. Then there's a lot of denial. Dr. XYZ has labeled the child as autism. He'll roam around to ABC, DEF, GEH until he finds somebody who gives him some label which is pleasing to his ear and his mind. And there is a mistrust. There's a lot of heterogeneity in the people who are treating autism. So that is why lots of patients or their families are a little uncomfortable. There's this distrust and that leads to doctor shopping. So what we have tried to do in Harding, Lady Harding, is that we've done this strategy because we also have these same problems. So our residents are now trained to use this strategy. We stagger the visits. How we're going to do that, I'll be coming to that. We schedule the evaluation. We use an evidence-based structured approach, and we practice with feedback. So my residents, because they are not so well versed with it, if they have an issue, they come and discuss with me. And for the parents, we try to establish rapport. The key point for that is listening actively. Listening actively means no interruption. Just listen and write down. Involve the parent as a primary care, key holder. Proper counseling before you refer him to XYZ therapists. Act as the team leader when he comes back to explain to the parent what the XYZ therapist has said and give them guidance regarding resources or support. You don't have to do it yourself, but you can just give them direction. So these are the cornerstones of the strategy. So high index of suspicion is during a health visit. Sir talked about the screening tool. Or sometimes when you're looking at a child with diarrhea, you might notice that there's some problem. Or sometimes it's a sibling of a child with autism. So these are all for a medical professional when he or she should be concerned or suspect. A parent might come with something like, okay, my child has a developmental problem, or if it's an older child, an academic problem, or there's something wrong with the vision, something wrong with the hearing, or there is some regression in language and social, or my child plays a little differently, behavior is a little unusual, or some medical complaints which I'm going to come to. And the teacher may complain that the child's not able to sit in class, he has poor scholastic performance, he doesn't play with his peers, abnormal behavior, and in an older child, maybe a mental health issue. So these are all the situations which should make your antenna stand up that, okay, does this child have a problem? Can it be autism? So now, how do we go about the diagnosis? So like any other clinical scenario, same thing, the presenting complaints, the history of present illness, past history, etc., etc., etc. Here, the presenting complaints are going to be the core symptoms, which is the DSM-5 criteria, which I'm going to come to, as well as the comorbid conditions, which I'm going to be enumerating. And all these other things, antenatal, family, miscellaneous, are important. And they're also very important because they help you establish a rapport with the parents. So now, the first visit, the patient has come to you. So now you're trying to make sense. Like if a child comes with distress, you know, okay, it might be bronchiolitis or asthma or pneumonia. If he comes with loose motions, you know, it might be acute diarrhea or persistent diarrhea. But the parent comes with a developmental problem or a behavioral problem or a neurological problem, try to categorize it. What are the sources of the concern? Are you the person who saw it? Are the parents oblivious? Has the teacher told the parent and the parent has come because the teacher has insisted, but the parent is, no, my child is fine. So that gives you a sense of understanding of how to deal and how to counsel the parents. Establish rapport, as I said, by listening. So he will come with his concerns, just keep on jotting it down. Don't ask any leading question, just keep on writing. Continue with the familiar ground. Why familiar ground, antenatal, natal, these are all within your zone of comfort and the zone of comfort of the parents. So you're asking these routine questions, he's answering. So the parent starts trusting you. Because otherwise, usually when parents come with developmental and behavioral issues, they're very defensive because they've moved from one place to the other. So we have to dispel that. Then the developmental profile. Developmental profile, all of you know how to do that by the developmental milestones. So you need to know what the last milestone has been attained in each developmental domain, and the next one sequential, which should have come but has not come. So that gives you a crude developmental age. And there are two patterns that emerge in the developmental profile of a child with autism. One on the left, in which the gross motor and fine motor is fine, age appropriate, but you will have some discrepancy in the social and language developmental age. And in the other, on the one on the right, you will have delay in all 4 domains, maybe even, maybe uneven. So now you look at the examination. Children with autism may have problems in head circumference, macrocephaly, which is a normal part of, considered normal in autism. Then you might have microcephaly if it's syndromic. Weight may be increased, decreased, head circumference, height, etc. Dental evaluation, very important, which we miss because children with autism usually have issues with brushing, so they have lots of dental issues which they cannot express, and then they get overlooked. Micronutrient deficiencies, again, because of feeding issues. Dysmorphism, in which you will have to evaluate the parents also, neurocutaneous markers. So you can see here, this child, what is the diagnosis here? Residents? This is what? Tuberous sclerosis complex, that's often associated with autism, and the kid above is Cornelia DeLange. So a neurological assessment, a bedside assessment of the development, the vision and hearing. These are all clinical assessments, and systemic examination. So then we go to now this child has come to me in the OPD. So I first of all ascertain the age, and I always write, personally I write the names of the parents and the educational level, because that helps if I address them by their names, it helps me in establish rapport. And if I know the educational level, then I can tailor my counseling according to his level of understanding. I ask about the concerns and the comorbid condition. This child is a 3-year-old. He was incidentally admitted in some private hospital for diarrhea, and when he was hospitalized for 2 or 3 days, the pediatrician there told the parents that your child has a problem. You must go and see a developmental pediatrician. And that is how he came to me. The parents were not very, concerned, bataya gaya hai, isliye hum aaye hai, which is quite a common scenario. We need to ask about the functional impairment and threat to self or others. So we're doing triaging. What are the really important things? Whether it's a nuclear family or joint family, check the immunization, screen time, diet, junk food, and note all the records. Like over here, there was some NICU stay. So I just wrote down that, okay, we need to review the NICU stay records. Then we do the developmental assessment, the way I just outlined. In this child, there is a problem with gross motor. The gross motor is fine, appropriate. The fine motor is plus minus. Language, verbal as well as non-verbal, according to the age, is definitely decreased, as well as the social. So there is a delay in more than in 2 domains, plus minus 1. And here, because at least in North India, I'm not sure about what is here in Bengal, we have a lot of nuclear families, and joint families are a lot less. Another thing is that parents themselves are not very familiar with the normal development of a child. So sometimes if you ask them that, when you ask them the milestones, they're not aware. So often I find out what their level of understanding is. And if suppose I feel that they don't know what normal development is, a normal child of that age is, I ask them to go and just in their own families, in the neighborhoods, to see other kids of the same age and the same gender, and then compare. And why is that important? You'll get to understand a little later. So now I have these questions. So I'm working in a government hospital in which my patients belong to a poor educational level and low socioeconomic strata. So I write in Hindi. So I'm pretty sure you can write it in Bengali, or you can ask, if they're illiterate, you can tell them that to get it read by somebody else. So I'm asking for 2 questions. One is that, here I'm going to speak in Hindi if you don't mind, that आपका बच्चा दूसरे बच्चे के तुलने में क्या क्या नहीं कर पाता है, which is basically I'm looking for a deficit in development. And the second question is कि आपका बच्चा दूसरे बच्चे के तुलने में क्या क्या करता रहता है जो दूसरे बच्चे आम तौर पे नहीं करते. Right? Got it? So here the second question is I'm looking for excessive behavior. So abnormal deficit, abnormal excessive. And it becomes easier for the parent to write it down. if you ask him on the spot, he will not remember. But if you give him this homework and you tell him that, okay, you've already established rapport, you've talked with him, you've done anthro, etc., so he feels, yes, the doctor has seen my patient, has listened to my concerns, and he is now interested. I've been given some work to do, so he will go home and he will do it. And also ask him to make short home video clips. Usually I ask for play. So play is with toys. Whether he plays or whether he doesn't play, you just tell them 6 to 8 different types of toys. हमें देखना है कि बच्चा क्या करता है. And the second is play with his repetitive activities. का आपका बच्चा कौन-कौन सा खेल में मग्न हो जाते हैं. Make those videos. Play with siblings or children within the family, and play with children in the park outside his family. Then the social interaction within the family, whoever you have the family members, 1:1 videos, whatever activity. What is important is that you must tell them that you are not going to tell the child what to do. It should be absolutely spontaneous. And activities of daily living, it's nice to ask them for a feeding, not bathing, etc., for feeding. Then ask them checking questions, which means, because this is very important, remember, you want to decrease the number of visits. So if they understand what you want, they will bring what you want. So if you have told them the questions, make sure you ask them 2 or 3 questions to understand whether they have understood what you want. Is that clear? And you can show them templates of other patients, you can show them videos of other patients so that they get an idea. And ask for multiple sources. If there is a caretaker at home, if there's a nanny at home, if the child is going to a preschool, you just write a short note and ask them to get information from there. So by the end of the first visit, you have found out what the primary concern of the parent is. You have also jotted down additional history that might have come and that you want to explore later on. You have done anthropometry and general physical examination. Here I didn't do because I didn't have time, so I wrote it down. I have to do it next time. You plan your investigations from whatever you've done. If you see that there's pallor, if you feel that there's rickets, etc., you just plan your investigations. And then you also plan the next visit. You tell them that you have to do the homework. These are the records that I want. These are the drugs that I need. And this is the date. This is mine?
5 left. 5 minutes left.
Oh, okay. So in the second now we have got the reason why we want that information and we want the videos is because we need to apply the DSM-5 criteria. So I'm not going to go into this. All of you have it in Nelson. So there's persistent deficits in social communication, social interaction, and repetitive patterns of behavior, and the symptoms must be present in the early developmental period. They should cause clinical significant impairment, and they should not be explained by intellectual disability or global developmental delay. So the second visit, you are going to now review the questions and the videos. So here, these are the aspects that you have to look into: communication, verbal, quality, frequency, content, non-verbal, eye contact, gaze avoidance, facial expressions, use and understanding of gestures, social interaction, whether they're initiating or responding, how are they doing it, to children, adults, behavior, excess deficit, what is the severity, what are the triggers, response to sensory stimuli, play. All this is the building blocks for you to apply your DSM-5 criteria. So over here, for instance, he has said कि बच्चा बोल नहीं पाता है. So like this child comes and says diarrhea hai, then you ask कि how much diarrhea, etc., etc. Similarly, I have also asked, and here what emerges is the child has problems with children of the same age, with adults, mostly with men, with women he is comfortable. He has some rituals with his food. If there's dahi, he will not eat, and he has some repetitive behaviors. So these kind of things emerge from the history. In the second one, also he has some issues that he will snatch the ball. Like these are the unusual behaviors. He will snatch the ball from other children. He has repetitive play. He likes putting things in and out of boxes, playing with switches. So these are confirmed with your videos. So this is the video of his speech. So can you see there is no speech at all? Okay, but he is not cognitively impaired, because when he plays with the ring stacker, and if you tell him put orange, put blue, put yellow, he can identify colors.
Yellow.
So this is the discrepancy that we were talking about. And here, over here, another reason why videos are very important, because they give you a very true picture. Like over here, the mother will say that बच्चा दूसरे बच्चों के साथ खेलता है. But if you look at the picture, if you look at the video, this is the child, the one in yellow. He's at the periphery. So he's in a group of children, he's in the middle of children, but he's not playing with those children. So often these things will emerge from the videos, which are not apparent otherwise. And this is basically a video of his putting these things in and out of the box. So all these things, if you ask them the history, you will not get. But like a picture is 1,000 words, a video is like 1,000,000 words, you get your information very easily. So these are another couple of videos. This is the one on the right is the snatching of ball from children who he has no idea about. And over here it's playing with a part of the toy. Like you all know how a child plays with a xylophone, ting, 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 ting. So over here you can see these buttons. So this child will only keep on twirling the buttons. So these are the building blocks that you're getting. And now in the third visit, what you're doing is that you're reviewing all the additional videos, you're performing the things that you didn't do before, and I also had asked for information from the nursery school teacher. They've given me that information. And now I'm applying the DSM-5 criteria. So according to the DSM-5 criteria, he is fulfilling deficit in social emotional reciprocity. We have that information from both the videos as well as the information. He's fulfilling all three of criteria A. He's fulfilling 3 out of 4 of B, and he needs to fulfill 2. And C, D, and E criteria are fulfilled. So we have the clinical diagnosis. Now we look for other possible mimickers, excludes excessive screen time, exclude social interaction, language impairment in the environment, etc. Look at the comorbid conditions, which are medical, psychiatric, genetic, environmental. So this, from usually by the second or third visits, you have identified the comorbidities, you have established the diagnosis. Now you plan the investigations. All children need to have an assessment, a structured assessment of hearing and vision, EEG as per the indications, MRI as per the indications. If the child is dysmorphic, the protocol, standard protocol. Because these kids have issues with nutrition, screen for anemia and nutritional deficiencies, sleep, dietary intake, lead studies if there's considerable significant pica, and if you suspect a genetic or metabolic thing, there's the AAP and the IAP guidelines, so you'll be able to look at the indicators and consult with an expert. These are the various referrals which Dr. Datta has already enumerated. You have the developmental pediatrician, the clinical psychologist, the speech and language pathologist, etc., etc. Family, we don't expect you to be a developmental pediatrician, but we expect you to be the team leader because you are going to liaison with the other people. So you need to know that a management plan is aimed at minimizing the core deficits, maximizing functional independence, eliminating problem behavior, managing comorbid conditions, promoting positive parent-child interactions, providing a safe and secure environment, and so this is the diagnosis of my child. This is the management that we have got together, and we have talked with the parents and counseled, and always write in a language that they understand. And because you have lots of stuff to do, tell them that, okay, come back after 2 weeks, even if you haven't completed, so that at least you know that they are on course, and they don't go sidetracked. So the management, just 2 minutes, sir. Just 2 minutes. Sorry, just 2 minutes. Just you need to be aware that you have to, when you're looking at the plan, is it individualized to the child? Is it multidisciplinary? Is it family-centered? Is it easily accessible? Is it frequent and intensive enough to cause an impact in the child? And is it being adhered to? So just a recap of the steps: high index of suspicion, clinical diagnosis by DSM-5, identify comorbid conditions, plan tests as indication, plan referrals as indication, make your synthesis, counsel, keep under follow-up. And the key message from this is that autism is common. It's 1 in 36 as of now by CDC. You have to keep a high index of suspicion. Establishing a diagnosis by DSM-5 criteria is easy. Don't get scared by all that language. Use the standard history examination observation. Use the systematic approach. Stagger the visits. Involve the parents so that they don't get very, the doctor is not listening to me. Document clearly. Make appropriate referrals. Obtain feedback from your experts so that you know, because you're learning this. So anything that you learn, you need to know whether you're doing it properly. Be ready to be the liaison officer, help in counseling, planning, monitoring, checking adherence, parental education and advocacy, as Sir had just talked about. Help in the transitional periods, adolescence, shift of school, and provide continuity of care from presentation in at whatever age the child comes, through adolescence to adulthood, hand them over. So thank you so much.
Thank you for the nice presentation. But one thing I want to give a message to the audience that Madam already told the clinical suspicion is one of the important things. Indian Academy of Pediatrics doing a good, the presidential office practice they are doing different. There it is a IIP ka baat with community ka saath. There is a autism model is there. So general practitioner from that can get a good idea about their suspicion. When you get the suspicion, parents are denial. But you are the primary physician. They rely on you very much. So convince them, send to the development pediatrician, and also monitor them after the chart, all these things, confirm the diagnosis, and multi-system approach should be done. In your busy practice, you cannot do all these things. So refer to the development pediatrician, and follow-up to be done by this. By this, we can help the autistic patient. Although you can help the development pediatrician to see the comorbid factor. With this, I want to give the Madam. Madam can say one, two word.
Thank you. As a general pediatrician, suspicion of the disease and parent counseling, telling no negative words, all positive words, and there are some high spectrum autism disorder patients who are intelligent and who are well aware of the computer works or have good reading skill, good school performance, give their examples, and then refer to the developmental pediatrician, and most importantly, when they come back, follow up for the improvement. And this much we can do to help the autistic children.
Thank you. Thank you very much, Chairperson.
Thank you. Thank you. The end of the session.
Thank you all the chairpersons and the speakers. May I request you to please proceed to the memento corner to collect your mementos. Next, we have a panel discussion on comprehensive management of cerebral palsy. For this, may I like to invite Dr. J.N. Goswami, Professor and HOD Pediatrics, Command Hospital, Kolkata.
Very quick announcement. For those who are staying in this hotel, the checkout time is 12 o'clock, might be extended till 1 o'clock. So please check out of your rooms if you haven't already. This is just for those who are staying in the hotel. Please make your checkouts.
Welcome to the session, sir. Sir, I would request you to please introduce us to the panelists.
Good morning, everyone. Today, we have got a crowd here which spans from maybe first-year PG residents to the most esteemed and senior pediatricians, pediatric neurologists. So, you will all agree that cerebral palsy never leaves us. Right from day one in MBBS till the day we practice, it is always there. So, the management of cerebral palsy is not just physiotherapy, like many a time we are taught, refer to physiotherapy, refer to occupational therapy. It's much more than that. It's not only treatment of the child, but the family as a whole and a role as a community, as a society. So we'll try to skim through. We have got an esteemed panel today. This is a bonus. Our chairperson today is Dr. Sudha Kaul, ma'am. I would like to invite ma'am on the dais. We are really fortunate to have ma'am here. She has been traveling with cerebral palsy for a very long time, seen it from very close quarters, and she had established the West Bengal Spastic Society in 1974, which is the Indian Association of Indian Institute of Cerebral Palsy. Ma'am has a PhD in augmentative and alternative communication. She has a huge array of publications and number of committees, multiple books. And for her fantastic work, she was given the Padma Shri by the President of India in 2010. And she was also one of the core architects for drafting the bill which finally became an act of parliament, the rights of persons with disabilities. Thank you, ma'am. So we have got an esteemed conglomeration of panelists. I'll be talking about the panelists when I start asking them questions. And these are arranged in alphabetical order so that I don't end up hurting anyone. Dr. Rupa Biswas, Dr. Sandeep Samanta, Dr. Shumana Dr. Kanjilal, Dr. Sumita Basu, Dr. Supratim Dutta, and Mr. Zahir Abbas. Can you please come and take your place on the dais? So we start off with Dr. Rupa. Ma'am is presently Associate Professor in Government Medical College in Calcutta National Medical College. She is a member of the EB of WB Academy of Pediatrics and also Society of Pediatric Neurology and a life member of IAP. She has multiple publications. So, ma'am, can you tell how common are seizures among CP children?
Thank you. There is a strong association between the seizure and the CP, and usually it occurs in the spastic type of CP and also in the dyskinetic or mixed type of CP. There are overall incidence ranges from 30 to 60% in case of CP, whereas in general population it is 0.3 to 0.6%. And the classification is, this is the
So when you must be seeing a lot of seizures, a lot of children with CP who have seizures. Is management of seizure in CP same or different?
No, it is, really it is difficult because there are some reasons. Because next slide please. There are so many non-epileptic paroxysmal disorders, and some movement disorder also may coexist with this seizure. And there may be the multiple seizure type, not only the single. So the recognition of the pattern of the seizure is very difficult in that cases. And some syndromic epilepsies also coexist with the CP, and it is also, and that's for why the treatment is also difficult, and the control the seizure is very difficult, and there is a high chance of relapse after discontinuation or.
So if I may, you have said treatment is difficult. Can you give a broad outline how you advise anti-seizure medications for CP in your practice?
Yes, the choice of the drugs depends upon the type of the seizure, EG finding, whether there is any comorbid condition and the underlying behavioral problem. So after choosing the appropriate drug, it is the same rule as the general seizure disorder. After choosing the appropriate drugs, we start with always try to start with the monotherapy with the lowest possible dose, and ultimately and gradually increase the dose. If the first line drugs is not working, then you have to add the second one, and after second one you can maintaining the first line first drugs, and after controlling the seizure you can taper off the first one and continue the second one. And the next slide.
And how do you stop the anti-seizure drugs?
There are other treatment options, there are other treatment options also other than medication, vagal nerve stimulation, the role of cannabis. Yesterday we heard the extensive lecture on the cannabis, and there is sometimes epileptic surgery is also required for the treatment. And regarding the discontinuation, it is general rule that if the child is seizure free for last 2 years, and there is no breakthrough seizure, so we can discontinue, we can give trial for discontinue after giving the proper counseling to the parents that the seizure may relapse anytime, and there is high chance of relapse in the syndromic epilepsy, mixed type of epilepsy, and so there are multiple drugs may be required in that cases.
Thank you, ma'am, for such an exhaustive list given in gist. Now, Dr. Sandeep Samanta, sir, he has teaching experience spanning more than 15 years, and he has got extensive experience in District Early Intervention Center and facility-based newborn care. He is serving and has served as executive board member of various academic bodies, and is also part of governmental projects. So, sir, can you briefly tell us about the role of early intervention in CP?
Frankly speaking, role of early intervention. Early intervention is the basically mainstay of treatment nowadays in CP. Majority of our pediatrician, we used to diagnose the CP even after 4 years of age. Average age of diagnosis CP is 4.3 years as per literature. So when the important time is lost, then we are trying to improve that child by different type of intervention, therapy, and all this. So you can see this slide is there, where the golden period is basically birth to 2 years, when the malleability of the brain, that is the plasticity, that is the main important zone, the window period, where we should intervene. Because at that time, there is a huge chance of arborization and a huge chance of pruning and all this up to 6 years of age. So what will be the now next question will come, how early, what will be the dose, and what will be the modalities. So as in the early phase, that is non-specific. All the area of the brain is growing with multiple connection and all this. So at that phase, up to 6 months or even up to 1 year, we can think for multisensory stimulation using all the sensory modalities, because we know the sensory system is mature much earlier than any other organ, than any other system in the brain. So that opportunity we should not miss. So our aim as a pediatrician should be, we should diagnose it earlier and we should treat as early as possible, even from the very day 1 of the NICU, the early intervention and stimulation program should be started. And then at the follow-up in the SNCU, we should be follow those child with different modalities of intervention. For the early phase, from 6 months onwards to 2 years, we can think for play-based therapy. Play-based therapy, no, learning through everyday activity with the parents, that we can say LEAP. So there are different modalities, so that needs a huge discussion. Here we should discuss for the home-based care, because home-based care is basically a complementary model with institutional care. And the person who is sitting in the institute, be it therapist, be it a professional like us, we should supervise and we should treat with the adequate level of therapy, adequate duration, and adequate modalities whether the parents are using. So main target basically in the home-based treatment, there is the goal-based therapy, basically the milestone-based. So we should target according to the level of maturity, level of achievement of the milestone. So whether baby is able to prone or roll or supine or head control, trunk control, and accordingly we should give them the motor activities. Other than the multimodal sensory activity, so not only sensory, it should be the multimodal, so the different way of activities. So that's a huge number of lists are there. One should practice involving parents. Parental involvement is more important, and the time duration, that's it should be at least 2 to 3 hours per week, per day should be there. The patient should be engaged in different type of activity to come out from the disability. Our target is not to cure the CP, it is not possible also, but our target is to reduce the disability. So disability reduction is our target. So even we can start earlier, we can reduce disability up to 80 to 90%. In our experience, in my experience, I can say more than 90% child has gone out of disabilities. Another component of the home-based therapy is to prevent the disability, deformity. So deformity reduction, that is also a big issue. So that is the different of posture and home-based therapy scope is there using aids and appliances, and we can think for.
Thank you, sir. Now we go to Dr. Shumana ma'am. Ma'am was ex-professor and HOD of SSKM and IPGMER, and she has got extensive teaching experience spanning 30 years, multiple examinerships, researches, as has been flashed in the slide. And she was formerly the editor-in-chief of The Child and Newborn. And from Boston Children's Hospital, ma'am had done observership in pediatric neurology. And she's a life member of multiple academies. So, ma'am, can you tell about the various feeding-related issues in CP children, and what are the management, the options that can be offered?
There are many feeding-related issues in CP children. because it is very difficult to feed the child, CP child. And that's why 30% of CP children, they suffer from malnutrition. And many of them also suffer from reduced linear growth. As growth and nutrition depends upon many factors, but the feeding is one of them. The issues are number one is pseudobulbar palsy. It is an upper motor neuron palsy which causes poor coordination of sucking, swallowing, and chewing movement, resulting in reduced feeding. Also, they suffer from gastroesophageal reflux, which causes recurrent vomiting, regurgitation, aspiration, and aspiration pneumonia also. Sometimes they feel so much pain due to this reflux, they refuse to take food. And sometimes they suffer from dystonic dysphagia. It's a condition, it is found in severe gastroesophageal reflux. They assume a dystonic posture which mimics seizure. And another cause is due to constipation. Actually, there is reduced appetite. And
do you recommend any special diets for CP children? Because many a time the mothers, the fathers, they come and ask you. So what do you advise, ma'am?
Management is oral feeding because they cannot chew. They are given semi-solid food orally, and that should be given in erect posture to prevent aspiration. In small children, it's very easy to keep the child in mother's lap, but in older children, a special designed chair is prepared for adaptive sitting to prevent aspiration. And if it fails, if oral feeding fails, nasogastric tube feeding can be given, but it has some problem because nasal irritation, sinusitis, tube blockade, it is used for short time. But long-term basis, if it is absolutely required, gastrostomy tube feeding is given. It is introduced surgically or endoscopically. And diet is actually, it is individualized. Depends upon the age, sex, body weight, and muscle tone and activity level. If the muscle tone and activity levels are more, the calorie requirements are also increased. And calorie requirements are given according to age. Calorie, total calorie, protein, vitamin, minerals, and fluids are very important. And the second thing is that right amount of calorie should be given from home-based, normally available food, no special thing is required. But as the CP children are deprived of sunlight, they should be additional vitamin D, calcium, phosphorus for bone health. And also vitamin C, vitamin K, manganese, calcium are all required because they are deficient. This diet should be given in a way that the child feels happy. He or she enjoys the feeding and is satisfied so that he likes to take the food again. And forceful feeding is not allowed and it should be avoided. And if all these things fail, the child should be monitored regularly for proper growth. If there is deficiency, additional protein or mineral supplement can be given.
Thank you, ma'am. We came to know about a very important aspect which is often neglected. And the last line probably has the pearl that you can't force feed and then the child should like. So now Dr. Shumita Basu, ma'am, she is an advisor of the Social Pediatrics Wing of WBAP, National Spokesperson of IAP Ki Baat Community Ke Saath, is Zonal Coordinator, multiple publications again, and a member of Indian Child Protection Medical Professional Network, and life membership of multiple bodies. Ma'am is Professor and HOD of WIMS. And so, ma'am, can you please tell us about the issues that parents of a child with CP may face and how a pediatrician who's confronted with that situation deals with parental burnout?
Thank you, Dr. Goswami, for that question, and good afternoon, everybody. Now we know that as pediatricians, we have children coming with illnesses, various illnesses, fever, pneumonia, diarrheas, and they are temporary. And then we understand the anxiety the parents feel even when they have a temporary illness. But here we are talking about a lifelong illness and a mother who's the primary caregiver, and she faces multiple issues while looking after these children. There are physical, emotional, psychological stresses that she goes through. And primarily, I have seen very often that even the own family members are not very supportive. And as a pediatrician, we have to understand that if we want to really look after these children, when we talk about the multidisciplinary approach, we also have to understand the health of the caregiver, because if that is not being addressed, the care of the child also is going to be will suffer. So yes, multiple issues of parental stresses, and parental burnout is a very common thing that we see. And we need to understand that, and as a ma'am will be able to talk about it often, and as a parent therapy, and as a society at large, actually, we are so very, even in case of this gross motor functional classification stage 1 and 2, at least these children can walk, maybe on wanting to play outside. They would want to go to the park, but no other children want to play with them. They're not invited to birthday parties. And these kind of emotional stresses that the mothers go through are very often ignored. And I think as a society, we need to be more empathetic and understand these issues.
And what is your take on special situations? For example, we have got abuse which goes unreported, and things like that, ma'am.
Yeah, so child sexual abuse is a huge gamut of problem that, especially in India, the statistics say is 1 in every 3 child is being abused every day. Both boys as well as girls. And here we have another vulnerable child, a child with special needs, who doesn't understand what's happening to her or him, and they are immobile, they are restricted to a place, they don't know how to say no, the term no, which we teach all our children, they don't know any of that. And very often the family member is the abuser, and it's not getting reported. Even the mother sometimes ignores those issues, and we have seen so many children with disabilities coming pregnant, and it's such a big social evil that we actually face. We really need to address that.
Thank you, ma'am. I think for junior pediatricians, there is a lot to learn, and empathy is a message which ma'am had given. Now, Dr. Supratim Datta, sir, he was an ex-professor and head Department of Pediatrics of IPGMER. Again, multiple publications, author of a chapter in textbooks, and his life member of multiple bodies. So, sir, can you give a brief overview of the management of various comorbidities of CP?
Thanks, Dr. Goswami. Although the CP, we all know that this is basically a motor deficit disorder, but the associated abnormalities called comorbidities, they are also equally important, and they need the same emphasis as on the motor deficit. And I will just touch upon the problems and just the 1 or 2 lines about the management plan. The first is the intellectual impairment and the learning disabilities, and that's why sometimes this is more common in the quadriplegic spastic CP, and the role of special educator is there. The seizure disorder is another problem. They well explained by Dr. Rupa, so no need to repeat it. Often this is very refractory, especially in hemiplegic CP. And the multiple seizure types can happen, and the clinician, we better try to avoid the phenobarbital as it causes the hyperactivity as well as the cognition impairment. So these are the few issues in seizure management. And the next is the hearing impairment. So if there is hearing impairment is there, the hearing aids and all those things, sometimes maybe an audiologist opinion. The next is the visual impairment, very common, the cortical, other than the cortical blindness, the diffraction error, the strabismus, loss of binocular vision. So from the very beginning, there is a role of the ophthalmologist. Next is the speech problem or the communication problem. So I will deal with later on the speech therapies, the audiological assessment, hearing issues, all those things are there. The GI problem, nutrition, oromotor dysfunction, already Shumana madam has told nicely how to deal with them. The GERD management is one important issue. Drooling is another thing. Sometimes it needs in a very refractory case, the injection botulinum toxin in the salivary glands. And really the child may need the gastrostomy tube. The other issues are in relation to the behavioral issues, psychosocial issues, so nicely explained by Shumita madam. The thing is that the respiratory abnormality, aspiration, pneumonia, sometimes they should be taken care of. And the another important issue is the bowel and bladder problem. So the incontinence, constipation, all those things, they need the bladder and proper bladder and bowel training from the very beginning as appropriate age. So truly, that is why the CP needs a multidisciplinary approach. And all these comorbidities, they also need the same attention as well as the motor deficit.
Very true, sir. In fact, it is the entire textbook of pediatrics and can't be finished in 30 minutes. So how do you manage spasticity in a child with CP? Because it's a very common problem.
The tone is maintained by reflex arc, all of us know, at the spinal cord level, and this is controlled by the motor cortex, basal ganglia, extrapyramidal system, and the cerebellum. And that reflex arc, the excitatory as well as the inhibitory impulses go to the anterior horn cell through the interneurons. The higher levels, they send either the excitatory or the inhibitory impulses to this reflex arc. And in the cerebral palsy, as there is damage to the cerebral cortex, there is an imbalance between the excitatory and the inhibitory impulses reaching to the anterior horn cell through the interneurons. And because of this imbalance, the tone is increased, which is called the spasticity. Now, what are the problems with the spasticity? If the child is a spastic one, it will impair the movement, posture, the daily activity of daily living. Not only that, that will create the contracture, deformity, the pressure, sore, pain, whatnot. So that is why the spasticity needs the measures, different intervention measures. And what are the measures which will control the spasticity? So the first is, of course, the first and foremost is the various physical therapy, like positioning, like stress exercises, like neurofacilitation techniques. So that will be well explained by Mr. Abbas, or the expert in occupational therapy. The second is the certain oral medications which will cause the reduced spasticity. They are basically muscle relaxant. So to name a few, the first is the oral baclofen. The baclofen, it has got a very poor, it crosses blood-brain barrier very poorly. So that's why if you have to give it through oral form, the dose is very high. And that high dose can create some problem like somnolence, drowsiness, the generalized muscle weakness, and sometimes it decreases the seizure threshold. But still, this baclofen sometimes used by the clinician. And the another drug is the benzodiazepine. Two drugs are well mentioned here. The one is the diazepam, another is the clonazepam. The clonazepam is preferred over diazepam as it has got fewer side effects and the duration of action is long. Two other drugs are there. One is the dantrolene, not very popular because of the hepatotoxicity. Another is the tigeninidine, and that is not, its role is not established in pediatric age group. It has been used in adult. So these are the oral medication which will help, and to start with, the low dose is given and gradually the dose is increased. Side effects already I said. And the thing is that the generalized muscular weakness is one of the important complications. So that's why in ambulatory patient, better to be avoided these drugs. So the non-ambulatory patient, better to be tried. The next is the certain neuromuscular blocking agent. Various drugs are there, but most the drug which is popular in this aspect is the injection botulinum toxin. So botulinum toxin that is produced by the Clostridium bacilli, various toxins are there. The therapeutic importance lies in relation to the injection botulinum toxin A. This is given in the muscle injectable form. The dosage limit is there as well as the maximum muscles, number of muscles, and all guidelines are there. But this is a very helpful thing, not only in case of spasticity, sometimes it can be helpful in dystonia also, and sometimes in case of severe drooling, the injection is to be given to the salivary gland. So role of botulinum toxin reducing spasticity is there. Other than these measures, two other measures in advanced center, they are usually carried out. One is the intrathecal baclofen, another is the selective dorsal rhizotomy. Both these techniques, they need the neurosurgery help. The selective dorsal rhizotomy is a purely neurosurgical procedure, And for the implantation of the catheter into the intrathecal space, in intrathecal baclofen, the role of neurosurgery is there.
Thank you, sir. Now we go to Mr. Zahir Abbas. He is an accomplished occupational therapist and very academically oriented, as you see from the slide, multiple awards and a special interest in CP and autism. Can you give a brief overview of the common OT modalities that you administer in CP, and what are your strategies for promoting functional independence of a CP child?
Good afternoon all. Thank you for giving me this opportunity with this esteemed panel of panelists. Thank you, Dr. Goswami. The major thing about modalities is first, we learn from each and every family and each and every child. So it's a journey with the child. So for each and every practitioner, like following through a child in a regular basis is very important. So modalities comes next. First is the rapport, trust, and building a ecosystem for the families. So the first modality that I'll choose for myself is parent training, parental awareness. What is going to be the journey in next 5 years? That makes sure in a very diluted fashion. So that is the first modality I'll target in my practice in daily life. Second is to learn from each and every child. We need to give the service that benefits the families. Like it is not your name, not your fame, not your expertise. It is how your deeds are getting reflected on that particular child. So the next modality is a empathetic and evidence-based approach. So now comes to the modalities, as you might be knowing about all those approaches going through long time, like positioning, some movement-based approaches, like constant induced movement therapies. We deal with mostly functionality, so we deal most on the upper limbs. So like constant induced movement therapies, modified constant induced movement therapies. But nowadays, as the domains are shifting from more about functionality, so playing games through video games, virtual reality is coming in. There are a lot of companies which are now developing. One of the most important research institutes is McMaster University, Canada. So you can follow their website. They have the best CP active channel network. So they give you a lot of insights into the evidence-based updates. So you can go through that. So this is about the modalities. There's n number of modalities. No modalities is worth unless you can achieve the goal of the families.
And what are your strategies for promoting functional independence?
Right. So functional independence is the major goal, as Dr. Shamunta has told, like you have to spend 3-4 hours. Like there is a consensus in Robin McWilliams approach, routine-based intervention. So in that routine-based intervention by Robin McWilliams, they have found that 4 hours per day, 30 hours per week should be the intervention time for a minimum period of 1 year for each and every child who is having some sort of delay. And this routine-based intervention talks about ADL, basically, the activities of daily living. So whatever capacity the child is having, involve the child with the various forms of actions. So if the child is unable to reach the hand to the mouth, so help and assist with adaptive devices that reach the hand to the mouth for the feeding, for brushing, for taking out the dress. So this is the major important thing, like finding out a school that allows these children where they can participate, finding out a ecosystem which allows this child to go into the community, finding out the society which makes them more included in day-to-day life. Thank you.
Thank you so much. So we come to Dr. Rupa once again. How do you differentiate movement disorders from seizures? Because you had mentioned that movement disorders are quite common.
The movement, yes, the movement disorder is quite common, and it is mainly seen in the dyskinetic and the spastic type of CP, whereas the dystonia is the commonest. So, and also the choreoathetoid and mixed type of features we can also see, and both movement disorder and seizure. Movement disorder and the seizure are overlapping phenomenology, but there are some differentiating point, like seizure has the cortical origin and may occur during the sleep. Usually the movement disorder doesn't occur in the sleep, and there are the specific EEG finding in case of seizure, and there may be the pre-ictal aura, or there is post-ictal confusion or unconsciousness may be seen in the seizure, which is not seen in case of movement disorder.
And how do you, ma'am, can you tell how you manage these movement disorders?
Regarding the management, the goal is the management is the strengthening of the muscle power and the improvement of the coordination and the improvement of the quality of the life. So there are some drugs, medicine for the dystonia, and there are also some non-medicinal treatment. Regarding the drugs, already Sir mentioned regarding the baclofen and diazepam, and the first line drug is the trihexyphenidyl. We know that this is anticholinergic drugs, and I'm not going to the details regarding the doses. And there is also the choice of baclofen, clonazepam, and so in few cases if there is dopa responsive, the dopamine levodopa can be tried. And the last one is the tetrabenzene, which is the vesicular monoamine transport inhibitor, and this is not the first line drugs but can be given as an add-on therapy. And other medicines like muscle relaxant, levetiracetam, zonisamide, sodium oxybate are also tried, but no such robust evidence is seen. And Saris told that about the intrathecal baclofen, which is also very emerging treatment, and also the deep vein stimulation is nowadays tried for the refractory cases. And other than intrathecal baclofen, interventricular baclofen is an alternative choice. And the targeted botulinum toxin that is used for focal dystonia, especially in the cervical dystonia, oromandibular dystonia, and the laryngeal dystonia, and also the limb dystonia. And yesterday discussed extensively, that is cannabinoids. This is helpful for cervical dystonia, blepharospasm, focal hand dystonia, and also the general dystonia. And the other least modality is the basal ganglia and the thalamic stereotactic ablative surgery.
Thank you,
These are the treatment modalities.
Thank you, ma'am. Dr. Shandip, can you tell what is the current scenario of comprehensive CP management in our country today, and what are the challenges that young pediatricians may face?
I have already told in the community level or as a whole, diagnosis of CP is grossly delayed. We are diagnosing at the age of 4 to 5 years. So you can understand where we are. So in community level, we are in big zero. There is no such structured intervention center for CP child or even developmental disability. Very recently, last 5 or 6 years, Government of India, they have started DEIC, District Early Intervention Center, which is basically an activity hub for developmental delay as a whole. So definitely cerebral palsy is most important, but all the developmental delay is being addressed. So how we can approach in the community level as a whole? So we can screen at the Anganwadi worker, at the PSC, CHC level. Most important, the essential level, where high-risk baby are being gathered, and some school and all this. So what will be the approach? So after screening, so we can add the community early intervention. So here we have no structure set up. Block early intervention center, there is also some just education department like this all. Only functioning is the district early intervention center, where all the therapists, different multimodal therapy we are talking, so they are available there. But again, the training related to pediatrics also we are grossly lacking. Whatever may be, so we can do something even at the early intervention center, provided we all participate there and we all refer our children, our baby at the early age, what we are talking, that from the day one we should start. So what will be the approach? So here that the multidisciplinary approach we are talking till date, so that is obsolete now. So, sir, previous slide, please, sir. So multidisciplinary, where different disciplinary specialists, so they are treating the child individually, it's not the right approach. So what is the right approach? So this is the interdisciplinary, that is in the district level, where the A, B, C, D, different therapists, they are individually treating the child and they are interacting each other, how to improve the individual situation and as a whole overall. And the last one, that is the transdisciplinary approach that can be used in individual level, that is as a pediatrician level, or in the block level, or in the chamber, or whatever may be. So that is the current recommendation, So transdisciplinary approach. So we should be equipped with that, being a pediatrician, being a team leader, whatever may be. So we should know everything in superficial or in depth, whatever may be. We should know every therapy, every aspect of therapy, and we will play a role as a case manager, and as a we will treat the child. And accordingly, we will refer to the previous slide, please. Next, previous one. So last and the top. So then we will refer to the rehabilitation centers and other assistive technology and devices, whatever may be, that is like IACP or other institute, big institute, they are.
Sir, if I may, sir, since we have got 4 more listing, can I just go to the next question, sir? Major challenges faced?
Sir, we know that the challenges, the early diagnosis, but there is again from the day one, general movement assessment, even HINE, neonatal HINE is also there, so we can diagnose from the day one also. And individual pediatrician I have already discussed, and team approach we have to be open so that we can take all the help of other team members, other therapists in same team. So that is the big issue. And other issues, that is the maternal depression, nutrition, that has been already discussed. And again, financial burden and related issue is a big challenge for a country like us.
Thank you, sir. Now we are running against time, so we are just asking for brief comments. Ma'am, Dr. Sumana, can you please outline the management tips that you advise the parents of a child with quadriplegic CP, and any advice for the junior pediatricians?
Actually, this quadriplegic CP is the severest form. And family counseling of parents is very, very important for holistic attitude. The parents should be counseled that their child may not attain the normal growth and development like others, but may attain optimal growth and development depending upon his or her disability if they are given early stimulation and are taken on long-term follow-up. They should be given proper nutritional support for growth and development. Immunization is very, very important to prevent them from infection from like other normal children. Medical management of comorbidities, they should be, the thing is that spasticity management already described. The management of gastroesophageal reflux, the domperidone, sucral, etc. can be given. Management of UTI depends upon the organism type. For constipation, fluid and vegetables should be given, dietary modification, and reflux disease also explained. And the second is the medical management. After that, physical therapy already described by Jahid Abbas. Apart from occupational therapy, wheel mobility, bracing is advised. And corrective orthopedic surgery may be required sometimes, that should be counseled to the mother in extreme cases. They should be counseled speech therapy, hearing impairment and vision impairment. And the most important thing that they should be told that they should continue lifelong therapy. And they should keep the child happy, always happy, and so that to allow them to mix with the other child in the society for better cognition and adaptive productive life.
Thank you, ma'am. And Dr. Sumita, ma'am, what is the current Indian scenario, and what advice pertaining to education do you give?
So the current Indian scenario is extremely poor, like we all know. A child who's cerebral palsy, and very often it's kept indoors because very unlike the Western countries where the children are included into the society every day in every sphere. So quickly, a little bit, since we're running short of time, a little bit about the education. We know the government of India has made many programs, and Madam has been a part of that. The Children with Disabilities Act, the Samagra Shikha Abhijan, which has been included in 2018-19. So, but what do they talk about? They talk about inclusive education for these children in the integrated into the normal school, especially if the gross motor functional classification stage 1 and 2. It can be a simple thing as a ramp we do not have in the schools, in the public spaces. A visual aid, a braille. We have a long way to go. We have many laws, but we are not implementing them, and we are neglecting these children. So I'll just quickly wrap up because I think we need to listen from ma'am.
Definitely,
a few words.
And with 7 people here, at least 20 years each. So 140 years of experience summarized in 30 minutes is a colossal task. So now we'll be really waiting for some tips, whatever you would like to say, your journey. And mind you, ladies and gentlemen, ma'am, if I may be permitted, also had a very personal experience with cerebral palsy. And she turned that challenge into a gift. Yes, ma'am, please.
Thank you very much for inviting me. It's a real privilege to be here. And more so because since the morning I've been hearing doctors, which I don't usually hear, talking about how important it is to involve the family and the parents. So it is really encouraging from a parental perspective to see all the medical profession sitting here recognizing the fact that without the family and parents' involvement, what you're trying to do would really not go very far. In my own institute, IICP, Indian Institute of Cerebral Palsy, we have what many of you have been talking about, a family-centered approach to intervention, with child being the central point. You were quite right in saying that we have a long, long way to go, but 50 years in the field have taught me that we shouldn't lose hope. And my own journey, to put very quickly, has really been guided by doctors. And I'll go through this very, very quickly. 54 years ago, my son Arjun is 54 years now. At that point of time, we had gone to a very well-known specialist in Bombay who said, I'll try and do an IQ test with this 2-year-old child who had no sitting balance and was not really reacting, and then just gave a certificate saying has cerebral palsy. Not much can be done. But we as parents didn't quite accept that, so we were fortunate enough to go to London, to the Bobath Center, and all of you in the field know Dr. Bobath, who gave me a very, very valuable advice. He diagnosed him as cerebral palsy with multiple disability and said, go back to your country and do something. We came back to Calcutta, and we came across a wonderful doctor, and I will name him, Dr. Anupam Das Gupta, who sadly passed away a few weeks ago, not years ago. And he was wonderful because by that time it was very evident that Arjun not only had a physical disability but also had profound intellectual disability. He had started having epileptic fits, so that's why we'd gone to him, to Dr. Das Gupta. And he said something which always remained in my mind. He said, yes, he needs medication, gave the prescription and everything. And he said, I'm going to tell you when to actually give this medicine because your child must be aware and he has the capacity to learn. We don't want him to go into a school and because of the medicine be sleeping all the time. So here was a doctor who actually believed that all children have the capacity to learn. And the last doctor that I want to talk about who also sadly passed away is Dr. Zareen Dadina, a pediatrician. And there again, it was the doctor's attitudes which gave parents encouragement to really move forward. So I think it's wonderful to be here, and I'm personally very encouraged to see all you young doctors and see the mindset of the doctors, which is so very important. And I think if we work together with NGOs, and there are many like many in the city itself, I'm sure we can move forward. So there is hope. Thank you so much.
Thank you, ma'am. And with your valuable words, we come to the end of this panel. Thank you, everyone.
Thank you, faculties, for this extremely important panel. I request our moderator and speakers to kindly collect their mementos from the memento corner. Our next panel is on key challenges in SMA management. I invite our moderator, Dr. Sanjukta De, Clinical Director, Department of Pediatrics and Neonatology, Peerless Hospital, Kolkata. And I request ma'am to kindly invite our panelists.
Good afternoon, everyone. Today it's an honor to be here, and I am indeed honored by the presence of our doctor who is the Director of Health Services, and very special because Sir is a senior alumni of my own medical college, NRS Medical College. So first I invite on stage Dr. Siddhartha Niyogi, Director Health Services. Sir, please come and grace the occasion. Next, I invite on stage Dr. Kalpana Datta, who again has been my teacher. When I was a postgraduate trainee, she was my RMO cum clinical tutor. So ma'am is also very close to my heart, and now she is known to everyone. So Kalpana Di, please. Next, I invite on stage Dr. Manjari Mitra. I worked with Manjari Di in ICH, so again, we go back a long way. And she works with various rare diseases and genetic disorders. Next, I invite Joshodhara, Dr. Joshodhara on stage. Dr. Joshodhara Chaudhary is a pediatric neurologist, and she again has helped me a lot with many of my pediatric patients. I'm indeed grateful to have such panel here. Now, just to start off with key things is, first of all, the disclaimer as I start is that I'm not a neurologist. I'm a pediatrician with special interest in pulmonary medicine, and everyone might be wondering why I'm talking on spinal muscular atrophy here, not being a neurologist. The fact remains that in spinal muscular atrophy, many of the patients are admitted with pulmonary complications, and that is the way I have got involved in their care and in their journey. And as Dr. Kaul was here in the previous panel, talking about parents' hope, limitations, fears, and journey, here I got involved too with the parents of the patients, and that's how my journey started with SMA. So spinal muscular atrophy, we have standard of care, but in India, the main problem becomes the limitations that we face in establishing multidisciplinary services and also in acquiring the drugs. So as you may be aware, there are 3 types of medicines available for spinal muscular atrophy. One is risdiplam, which is an oral medicine. Again, this is the only drug that is available to buy in India. The second one is nusinersen or Spinraza, and that also is not available to buy in India. And third is gene therapy. All 3 are very expensive, and I'm happy to say that I have 7 patients on risdiplam compassionate use program, and there are several more who are being funded in various ways. And I have on nusinersen 10 patients. I've already dosed a patient on gene therapy, the medicine that costs 16 crore rupees. And in our hospital, we are also having the STEER trial where 4 patients will get the 16 crore medicine free of cost. So the journey has started, and the journey in a small way has been a journey that has been very difficult but very eye-opening for me, because I have got help from quarters that I never expected to have. We have started with no rare disease policy. Now we have a rare disease policy. We have multidisciplinary clinics. And the first ever multidisciplinary clinic was started in Peerless. And at this point in time, we have all these, as you see, specialists sitting every 3 months and taking the parents and the patients through the journey of SMA. Now, this is a picture that I have included on the right with this multidisciplinary clinic going on in COVID times. I cannot tell you how challenging that was. And my first ever SMA conference held in 2019, which changed the face of people's perception of SMA and rare diseases. So, sir, I would first start with asking you a question that As I have said, highlighted that there is a multidisciplinary care needed for spinal muscular atrophy, but we have very few of these multidisciplinary clinics either in the medical colleges or in other hospitals. What is your feeling about this, whether it can be something as a way forward, something that is doable, something that is inexpensive and accessible to all the patients who get diagnosed with SMA. So, and the next question would be, what would be your take on public-private partnerships? Sir, Dr. Neogi.
Good afternoon. First of all, I should thank the organizer to invite me in a program where pediatrician and neurophysicians are there. Anyhow, what the question, we are doing a clinic in SSKM hospital for rare diseases, but it is done by the state government only. So here was a question whether a central government can come forward. But still now they don't have such program. Anyhow, patients are coming to SSKM and they are being treated. Even costly medicines are provided to them as a special cases. So we hope in future this program will increase and we can access. But next question was public-private partnership. It is welcome. We are doing in public-private partnership in many cases, CT scan, MRI, even many works, field of medicine, we are having PPP. So we will welcome if any organization applies to us for doing this rare diseases program under PPP model. So then the government will maybe consider. So we will welcome any application from any corner for PPP model.
Thank you, sir, for that hope. The same question, Joshadhara, I will ask you because, Kalpana, I'll come to you also. Joshadhara, because...
Actually, I wanted to say because there is a policy from the government of West Bengal and rare disease policies there in the state. And it is there regularly, there is an OPD in SSKM hospital in Tuesday. So for information for all the delegates, there is an OPD running regularly on the Tuesday, and that is the organized way. And we do have in medical college the multidisciplinary clinic for NDA, neurodevelopmental
yes,
NDC clinic is there. So it is not organized, but all the departments, they help. But because of the workload and all, they don't come physically all the time, but we do get the help from the different departments. And regarding the public-private partnership, like newborn hearing screening is going. That is one of the screening procedure in the NDC clinic, and that is by the public-private partnership and is very well running in our department, college.
The reason I'm bringing this question up is because the patients that are diagnosed of SMA, the pool that I have, about 73 patients, and we have other genetic disorders as well, Dr. Manjari Mitra will say. So the problem happens is the whole concentration is on SSKM. SSKM is doing a brilliant job, but as Joshodhara, I wanted to ask her that question, is I used to send patients to her, and it is a kind of a thing that it's getting to the doctor in such a busy clinic where there is 100 odd patients waiting to see you. What do you feel as a doctor is the biggest challenge of being part of such a clinic in SSKM? Because it is the nodal center. So my hope for the future would be not only SSKM, but every medical college in West Bengal has a multidisciplinary clinic in pediatrics for neuromuscular disorders. It may not be for SMA. It could be for genetic disorders, it could be for neuromuscular disorders, but every hospital, if it has a sensitization, the workload gets distributed. So what is your take on that, Joshua?
Ma'am, at NRS Medical College, we have started an SMA clinic, multidisciplinary one, which has been started in local level and which the notice has been given as well to Shastha Bhavan, so that we have orthopedicians also, because these children, when they grow up, they need the surgery, which is very expensive.
Extremely expensive.
Extremely
25
expensive.
lakhs for spine surgery.
25 lakhs. So we have, in our government setup, we do have very good spine surgeons. These people need to know. And these surgeries, if they can be done, if in a government hospital, that will benefit so many people. And
Absolutely.
also they get the other supports, like physiotherapy support, like pulmonary support, the investigations, free of cost in government hospitals. So it is very important that we start such clinics in government hospitals as well,
Absolutely.
to cater to a majority of the population who cannot afford the private hospitals.
Absolutely. And Dr. Monjo, sir, please.
In government hospital, all investigations are free.
Ab-
But genetic study is going on in SSK, but that we are very short of the experts. So if we get the experts, I think it will also increase. And another thing, the drug, all the drugs, as I have heard, are imported.
Except one drug, sir. Except one drug which is
And
available
it becomes very costly to import it.
here. Absolutely, sir.
So thing is that it takes time also. So if the some manufacturers comes forward and can produce it in India, I think the availability and cost of the medicines will come down. So there is Roche, I think, with this program. So I would request Roche to come forward, and even if imported, for the sake of the patients, can we make it a cheaper one? That is my suggestion and request to them.
Thank you, sir. Dr. Manjari, Mitra, please, because you look after many children with rare diseases, not only SMA, what is your take about our response as a medical fraternity to genetic disorders? Because I think we are less sensitized to that while we are medical students, and we do not understand the needs this special group has. So what is your take on that?
So I'm coming from Institute of Child Health, which is neither a public nor a private. So, but we do have a status, and in the...
We also give you some grant.
Yeah, we get a grant, but then we are more of a public, if I can put it in bracket. Now, what is happening about the rare disease, I can tell you for last 20 years, I think we were the first Eastern sector who started a rare disease under the guidance of Dr. Apurva Ghosh. And today, I would say that our postgraduates are well sensitized with the rare disease, and we make a diagnosis and we have a huge database. Well, our rare disease covers all the different types of rare disease, and what is important, when we went to Health Secretary also, we made many statements that ICH being one of the interested area, and we have a passion for that. Rare disease, I believe that everybody would understand, it's a lot of passion you have to have for the patient and the disease. Now with that, when we have thought of one thing important, which the state government can also take up, sensitize and put priority on that particular chapter from the undergrad days. Because it is very important, when we were undergraduate, we never put focus on rare disease because we didn't have any treatment. You diagnose and then you cannot offer anything. There is a question of the cost, but I'm sure tomorrow the cost will come down. Now it's a question of the postgraduates. I was very happy to see many postgraduates come. It is right away that they should have a suspicion, high rate of suspicion should be there to make a diagnosis of rare disease. Starting from simple unexplained anemia with hepatosplenomegaly, should we go for rule out Gaucher, something like that. Simple, a patient is not being able to sit at the right time, should we rule out SMA? So that type of suspicion, why it is important? Because for any treatment of rare disease, it is very, very important. The moment we do early diagnosis, early institution of treatment, the patient response is far better than a delayed diagnosis, which is happening. And so obviously when the central government and the state government is taking care of rare disease, they would like to see a very good response for the very exorbitant, prohibitively high cost. So that is one of the important things. I'm sure we have all the public hospitals, Kalpana is there to take up this as an important, to sensitize the undergraduates, because after 10 years, I'm sure this rare disease will be something like we have seen any other. Considering the large population of India, it will not be a meager numbers. And many other companies will also come forward, what doctor said, that we will have to have cheaper version. So that is the thing. Okay.
You see, all the SNA patients are coming to the hospital for handicap certificate. Problem is when they receive the handicap cert, they are satisfied. So in the handicap board, there is orthopedic surgeon, physician, everybody. So we can make aware them also that if you get such patient, you refer it. And another program government is doing, that is Shishu Shakti program. In Shishu Shakti program, many hospitals are doing, especially they are doing heart surgeries. So I think one can apply for it. So we may consider if we can compensate it. So I think whole cost cannot be given by the government. So now central government is not giving money. So we can think of it, so to include it in the Shishu Shakti. And another thing I would say, when the baby is born, the pediatrician checks the patients. And they identify whether there are any birth defect or not. And those are recorded in the, so it is recorded in the Matrima portal also. So if those, especially the pediatrician and Jatok Seva, another program. So that is done by the pediatrician specially. So they also get the information who are having SNA, especially during the birth or during the infant period.
Thank you, sir. Like I mentioned in the beginning of the program, that there are 3 medications for SMA, out of which only 1 is available to buy in India. And rest we get on compassionate use. So the 2 other medicines that we get on compassionate use, I'm thankful to the DCGI because they waived under special provisions of the Rare Diseases Act, they have waived the licensing and the import costs. But regarding the risdiplam, which is available to buy in India, in certain countries, they're subsidizing fully, which is not possible for a resource-poor country like ours. We cannot consider a full subsidy, but some countries are also buying it at a subsidized cost and making it available to the patients. Some of the patients, sir, under the rare disease policy, they are getting risdiplam directly from your rare disease fund. But could it be like that? Because this is getting available to people who know how to go through the official rigmarole. But it could also be that as Kerala government has certain funds set aside, and part of that fund is used for these high-end medicines or for these patients, could in the long term, government of West Bengal also consider subsidizing to an extent, not the entire amount, for the patients who will benefit from this medicine. That would be a question to Sir also and to Kalpanadi also. What are your thoughts on that? That whether or not we are thinking of indigenous medications, but that is another thing. But what about patients who are doing well and who benefit from risdiplam? Because that is another thing we face, that patients getting only 3 months of medicine or 1 year of medicine, and then they cannot carry this forward. And there is also the CSIR initiatives which we can use to fund these patients. How can the government help us to do that?
So I think from government point of view, Sir will explain better. But before going to any policy, we should have a national registry, which is not existing in SMA. Now we have started recently the LSDs. And when I've gone through the ICMR registry website, I have seen there are registry for the SSP and other rare diseases, though very rare. SMA is not that rare, it's one of the fertile rare disease, but it's not that rare SMA. So should we have one national registry so that we can have a burden of the disease and the prevalence also. Then we can think of the cost of the treatment, and as a government employee, whatever the government can help, from the government point of view, like multidisciplinary clinics, free of cost investigations, and we have some centers in the government set of geneticists, and the genetics are done, the testing. That can, we can provide, the rest is a very costly drug, and even government cannot go on giving the lifelong treatment for this type of patients.
Now we will have to consider models where there is, like all the public sector companies have, private sector companies have a CSIR initiative. So how to use those funds? I mean, sometimes there are funds, I have spoken, but it is not channeled in the right way. So, you know, if we have initiatives and more awareness, people will come forward. Sir is going to say something.
Any organization, if you want from CSR fund for this disease, they will want to give some money. It is welcome by the government. But thing is that for private sector, we can't make it a rule that they have to give a fund for CSR. That is, government can't do it. So it is the companies that they will decide. So you can approach many companies so that they can give the CSR fund. And I think government, private, previously I have told that if anybody interested, they apply to us, we will consider. And also in the Shishu Sati program, if we can see, we can include it. I think something is done, but thing is that previously what is my notice, that when people were with SNA, the people knew that nothing can be done. Even the physician is to say that nothing can be done. And they were their rather abundant child.
Absolutely.
So that is going to change.
Already
Absolutely.
changed.
So
that has
is
already
going
changed
that
a
is
lot.
a good sign, I would say. So sorry. If more patients are coming to us, so government, I think, will think how to help those. Original government is doing it, but thing is that for a mass scale, we have to think about it.
Of course.
I'll just
Let us
add,
hope one day it will be done.
Absolutely, sir.
I'll just add one more thing which pointed from Dr. Kalpana, a registry, a very important, it is not a very difficult thing. Every individual hospital, be it private, be it government, you can just maintain a registry. Once the larger volume is seen, today we may have a couple of companies, tomorrow we can have a lot of other companies, interested companies, because volume of India is huge. So if you consider 1 in 7,000, if I put all the rare diseases together,
Yes, and
so that is very important.
SMA, the carrier rate is 1 in 50.
Just so
Carrier
there's the
rate.
right person to say about the gene therapy. Recently, she has done
Yes,
one in
this is the
so
next
please
question
share
is
your
to
experience regarding the
Joshadhara,
gene.
because I gave a the gene therapy, sir, we get by lottery. You also got by lottery. I got one patient who I dosed in September. And then I think recently who have dosed a patient, it came out in the papers. So my experience with gene therapy is that after it's given, the response is pretty good. But the parents feel that gene therapy mil gaya, so it's done. I don't need to come for any further follow-ups. So what is your take on the patient you have dosed with the 16 crore medicine? What is the response you have seen and how the patient is faring?
First, it was a huge hurdle to cross in a government setup to arrange for this, because we do not have manpower, as madam will also say. There is manpower crisis and people will say, why will I do extra work for nothing? And then there are a lot of paperwork involved. You must be knowing there are import licenses we have to take from the India government. Then there are the airport authorities of India, whom we have to convince that an 18 crore thing is going to come and we do not have any stake. We are not doing any smuggling. So we have to convince that. And that
it's
is
more difficult. We are working in a private hospital. More difficult.
And government, it's also because we do not have any manpower, as madam will also say. Then it comes, and then we have to store that. Again, we found that difficult to store this because there were no, so there were many hurdles, and then we gave, and then the most important thing is there is chance of liver failure. And we need to have, they have a check, and we need to have a pediatric gastroenterologist, and that we have to arrange from a government setup. We cannot ask the patient to buy anything in our government rules. So in this particular case, we doctors had a fund. We ourselves contributed and bought some medicines for the parents because they have some, the child had some infection and stuff. So it's very difficult, but the result, as you said, is very gratifying because now the child, after gene therapy, 4 months later, free of cost, everything has been done. The child was in ICU free of cost. The child is now doing well. The child can now wave bye-bye, which he was not previously able to do, and it is so gratifying to see that.
Same experience here with the patient I dosed with gene therapy. 2 year, he was just going to turn 2. Now he can sit without support, and he can talk, and he can again wave bye-bye. The main thing that we find talking to other patients who have, other doctors, I mean, who have done gene therapy, is to keep on maintaining this physiotherapy regime for them, which they feel is not any longer necessary. But that is very gratifying, and we still, the lottery is closing worldwide on 30th of July.
Madam,
No
that
more
is the
lottery.
problem. Every
No
parent
more
is
lottery
coming
for
now.
gene therapy now anymore. So I have managed to get one patient, and they are doing the STEER clinical trial. For those of you who don't know, for above 2 years, gene therapy is not licensed for use. So the STEER trial aims at using this gene therapy medicine, which is dosed via the intrathecal route. So 4 of my patients, I am blinded, in the blinded team, so I don't know. 4 of my patients are receiving in this STEER trial, but after the trial is over, no more lottery, so the only way we could get the medicine is to buy it. So physical therapy questions, I will not go into details about ventilation, just I would ask Dr. Kalpana Datta to talk about, as you said, nutrition, gastrostomy, and feeding issues in SMA.
Okay, as usual, the nutrition is important for each and everyone, of course the SMA patients also. So role of adequate nutrition is very important because they have a weak chewing power, weak muscles, and there is a they take increased time to consume the food, and there is a delayed gastric emptying time. There may be lots of complications, aspirations and all. They may have a hypoventilations. So although they are easily malnourished. So if you won't care, and there's no immobilization, there's no exposure to sun, so they are deficient in the multiminerals and vitamins. So you have to give the, depending on the ability to swallow, you have to give the diet like semi-solid or in a thick taste, in the consistency, in a calorie-rich diet to be given. And you have to take care of the minerals and multiminerals and vitamin supplementation, especially the vitamin D, calcium and phosphorus, because they are not exposed at all to the sun rays and all, and they are not mobile. So it's very important, but who cannot take orally, then you have to give gastrogestal feeding or nasogastric feeding. For prolonged period, you cannot give the nasogastric feeding for prolonged period. So if you need to have the nutrition to give in nasogastric feed more than 3 months, you have to do the gastrostomy. And in case of gastrostomy, there is a chance of GR quite high. They'll end up in the GRD also. So these things to be taken care of while taking the nutritional part in the SMA.
Nutritional part in SMA, the other flip side of the coin is I find that many of the children become obese. Because they're sitting for prolonged periods in the wheelchair, they tend to become obese. And also because all these drugs that I have been using, the baseline from all the directives is that you have to do liver function test. And many of them have altered SGOT, SGPT, slightly raised transaminase. And that can itself be a problem, as Joshadhara mentioned, while we are doing gene therapy, the SGOT, SGPT might shoot up. So issues with nutrition is prevalent with overnutrition also. And bone health is also important because bone health is not addressed. Many of these children have undiagnosed vertebral fractures, fractures from minor falls. So what happens is those who even were ambulatory become wheelchair bound. I think sir wants to say something.
There was a problem with physiotherapy, I just heard, but we are doing district early intervention center in medical colleges and also in all district hospitals. And district hospital which have been turned to now medical college, there also we are having it. So if patients come there, physiotherapists are there, pediatrician also there in the clinic. So if they can train our physiotherapists, what training has to be done, I think it will be easier one. And for nutrition part, for special nutrition, it has to be done in a specialized nutrition. If patient is ventilator, where rice to be given. But in other cases, we have the NRC, that is Nutrition and Rehabilitation Center, where pediatrician is to visit. We have medical officers and also dietitians. So they can advise that. Patients are kept there. When they are mostly rehabilitated, then they are discharged with advice to the mothers and parents rather that you do this type of food that is locally available. We try to make the food with the locally available food so that after going to the home, they can continue this. So government is doing this.
Yes, sir, absolutely, I agree.
But take
We
what
just
you are
want
asking.
more. We are like children who want more. Pediatricians always want more.
I want to add one other thing. Previously, for hemolytic diseases, we don't have this disease treatment. Now, free treatment is provided to all patients. Every medicines are given free, whether it is child or adult. So we don't have any complication with the hepatitis while previously patient used to die bleeding. So that improvement has coming. So they are going to have bone marrow transplantation program also coming. So we hope in future, so if that fund is, we can reduce, so then we can spread it to the other pieces, also more fund can be provided.
Thank you.
But resource is limited, that is the main thing.
Absolutely.
Government of India, whatever they give, that resource is also limited. So
Next
within
question.
this, we have to do it. We have to give the prioritization. So which diseases are more, that has been looked at much more. But we are not telling that we are not doing for this special care for this SMA patient.
Just Manjari, 10 seconds because Shudeep is showing me eyes.
No, I think
10 seconds
it
on the
was
last
very well
question.
summarized. This is only for the postgraduates. When you hear physical therapy, you feel that it is not very important. But in this particular case, physical therapy is so important because it will initiate the osteoclast activity and will help the bone density. Pulmocare will help in the reducing the respiratory care. So supportive therapy, while you work for the drug, supportive therapy, particularly in SMA, is very important. So don't give hope when you have something else.
I will finish, Sudeep, with showing the last slide. Yeah.
So one thing, we have shortage of faculties, especially pediatric neurologists in our system. So even neurologists who are passing, they are going to the private sector or outside West Bengal. So if anybody from the private sector wants to give service to the government sector, per day we
Sir,
have
আমরা
a program.
privately থেকেই free service দেব আমাদের
Public-private partnership is very important, sir.
Yeah, I agree. But that also we are inviting so that we can train our present doctors, pediatricians more efficiently. So that pediatrician can also take on the cases.
Sir, I will just ask you everyone to look at the last slide because these are all patients of SMA and the patients here in the red frocks are getting Risdiplam, compassionate use program. But I lost Urjo Shoti very sadly to an adenovirus outbreak and she's no longer with us. But this lady, she is getting Risdiplam. Anushka, she is graduated from IIT Kanpur from computer science department. So basically she started getting Risdiplam, compassionate use from the age of 16 years. She used to require oxygen. She's completely wheelchair bound. but that she has not given up. She passed from Kanpur recently. And another of my patients also, Ridhima, she has got a very good rank, so she is also going to IIT Kanpur. So these children are very much, have very high IQ. They are socially extreme, wonderful to be with. They can contribute to the society. So it's not a waste of space to think about them. So that's on that note, I end the panel. Thank you very much.
Sir, if I may, I could...
I would thank Saudukta for organizing such program and inviting me. And I think if the interest is grown into all of us, we can succeed one day.
Absolutely. I'll just take a moment, sir. Thank you so much, sir, and respected panelists. I'm Shatabdi, I'm from Roche. As sir was mentioning very well about the public-private partnerships. So I completely believe that's a thing. For now, we can discuss because we have a case in Kerala. Kerala government has done a managed entry agreement with Roche to address the affordability and the pricing point of view. We can also have those collaborations in West Bengal also. Sir, if you may, we could come to you and talk more about it because, of course, we do believe that patient is the center and it's always about the patient and their journey. So we would like to come to you to talk about what we are doing in other states and what are the collaborations in place and how...
Always welcome.
Surely,
We'll try to do it.
Of course, sir. Sure. Thank you so much.
Thank you, speakers, for this esteemed panel.
Absolutely, sir.
I request you to collect your mementos from the memento corner. I request Dr. Kalpana ma'am to kindly stay on stage for her session. And I invite our chairpersons for this session, Dr. Shubhashish Roy, Consultant Pediatrician, Kolkata, and Dr. C.K. Ghosh to kindly come on stage.
Where is the speaker's introduction? Anyway, good afternoon. And where is the slide of the speaker? So, Professor Kalpana Datta, head of the Department Pediatrics, Medical College, Kolkata. This is a long list. If I go on talking about her, it will be endless. She's a very good friend of mine. And one thing let me tell you, she's equally versatile in respiratory diseases as well. Not only in neurology, she is equally versatile in respiratory diseases. And she is going to speak on risdiplam regarding what we have heard a lot in the previous session. It's a RNA splicer modifier, and let us hear from Dr. Kalpana Datta.
Thank you, Dr. Subhashish Roy, for a nice introduction. And there is a disclaimer that these slides are given to me from the Roche. This is the sponsor session, and the slides continuing from the scientific division. So as we already discussed in a panel discussion about the SMA, here we know we don't have any clinical guidelines. Before 2007, there are no standard care guidelines for the treatment of individual SMA. Since 2007, the before availability of the drug disease modifying therapies like disease management focus on non-pharmacological interventions. When we were students, we have seen the SMA patient to give only the respiratory support, different modalities, and we have seen that our patients are long time under ventilation, occupying one bed, feeling so pity for the patients and caregivers. So there is some standard care guidelines regarding the respiratory care, nutritional support and orthopedic complications they can arise as we had discussed in the previous session. So there are treating, now the therapeutic options are available for people living with the SMA, and the initiating treatment before potentially irreversible neuronal loss occurs, it should be started. We know there is a continuous neuronal loss, there is a loss of proteins going on, and in the month of, if you delay, the more loss will be there. Like we see in the picture, 0 to 6 months, there are 95% of the motor units are lost. So if you delay in initiating therapy, you will expect the result very less. So it should be started as early as possible. So there is a clinical trial in risdiplam, and it has 2 phases, and the unique mechanism, risdiplam has a unique mechanism of action. It introduces the synthesis of protein, that SMN2 mRNA splicing modifiers, and it increases the amount of functional survival motor neurons protein. So it is very good compliance will be there because it's orally administered, and it crosses the blood-brain barrier and is used throughout the CNS as well as throughout the body. So the cases where the samples were chosen, total number of 58, and who are genetically diagnosed with having 5q SMA deletion or mutant gene with, we have to have 2 SMA gene copies, and the children were selected to 1 to 7 months, and there are 2 points of this study. There's a Firefish study, have part 1 and part 2. In part 1, it has been seen the dose, what should be the dose, what should be the safety, whether the safety is there or not, tolerability, pharmacokinetics, pharmacodynamics, and the mechanism of the drug. In part 2 of the study, it has been shown whether baby could sit without support at least for 5 seconds, and in the gross motor scale, and at the end of the study, that is after 12 months. So if you see the summary of 24 months results, risdiplam treatment result in rapid and sustained increase in SMN protein levels, as it has been chosen early. So if infant continues to be treatment on risdiplam, so 100% continues, no infants were omitted the study. Of infants, 88% were alive and even free, 100% infant alive maintained the ability to swallow. 93% of infants alive were able to feed orally also. If you see the infants who can sit without support for at least 5%, it's near 59%, and we can motor milestone, other motor milestone like sitting and momentarily standing is there, and 1% is having infant who achieved the score of, this is the study of Child Health School of Philadelphia, in the neuromotor scoring system, it is more than 40. And in case 35% of infant did not require any hospitalization due to the other complications. Then part 2, if you see the child who could, without support for at least 5 seconds, then at the end of the 12 months of the study, 29% can sit, and if we continue the study up to 24 months, the 61% of the children were on the study could sit. And if you consider 30 seconds sitting without support, at 12 months is 17%, and at the end of the 24 months it's the 44%. So data now available after 48 months, that is after 2 years, 91% of the children were alive at 4 years of age. And you know, in the type 1, usually the children die of within 2 years. So after 4 years treatment, even free survival was greatly improved compared to the natural history. So now the part 2, there's a sitting without support is a 60% after 24 months, and it is continued to improve even the drug is continued up to 4 years. Even in the sitting with without support for 32 months, the 40% achieved this, and it is continued to improve even after 48 months, that is 62%. So if you see the different parameters like a Heinz score, hemorrhagic neurological examination, 2 motor milestones were seen over 4 years, and you see the head control, sitting, rolling, standing, walking, all are improved gradually from 24 months to 48 months as the drug is continuing. So again, adverse event and serious adverse events declined over 48 months. In their study, they have taken the adverse event as a upper respiratory tract infection, and severe adverse event as a pneumonia. They have taken as a their inclusion criteria. And if you see this bar chart, there's a gradual declining of all those complications and side effects, adverse events or serious adverse event after 48 months. After 4 years of treatment with the risdiplam, event-free survival greatly improved. You can see it is very clearly visible from the graph. Median time to reaching the death or permanent ventilation spool in a firefish study part 1 and part 2 was not estimable due to lack of events. It's still going on. And the natural history, you know, it have gone to succumb to the death. There is a sunfish study where 2-part study was enrolled where type 2 and type 3 SMA children were enrolled from 2 to 25 years. And the endpoint rationality is to evaluate the safety, efficacy in case of SMA 2 and 3. And in primary endpoints, the part 1 was determine the dose of confirmatory part 2. And evaluate the motor function using the motor function measurement 32 at 12 months. And assess the safety, tolerability, pharmacokinetics, and pharmacodynamics of the risdiplam. So risdiplam achieved motor functions maintained about 48 hours. We have seen the percentage is gradually the childs are improving on their motor functions when the treatment is continuing. Patients and caregivers reported stabilization or continuous improvement in the SMAs and upper limb movements, total score changes from baseline after 48 months, as we've taken the SMA 2 and 3 who could sit. So summary was sunfish study part 1. 100% individuals of sunfish have been treated with up to 12 months and helped to determine their part 2 continuation of the treatment and 100% survival till the treatment was going on. And it is still going on globally. So motor functions measurement 32 and upper limb movements scoring is showed that risdiplam significantly improved the motor functions after 12 months and it is continuously improving. So Jewelfish is evaluating the third study, safety of the risdiplam for pharmacokinetics and pharmacodynamics in a case of previously treated individuals with SMA of any type of treatment they have received. So first 2 studies with the naive patients, where first study type 1, in second study was type 2 and 3, and in case of third study, the Jewelfish study, where the patients enrolled who had a treatment of any mode of treatment previously. So either nusinersen, oligoximine, or the gene therapy was given. Risdiplam is put on after 24 months and it's continued in an extension phase, and this study is still going on. So Jewelfish study is a clinical trial investigating risdiplam in individuals with previously treated SMA patients. So they are no more naive patients. They have received other mode of therapy, and now they are enrolled in the Moonfish clinical trial, and previous treatment with the nusinersen, olexisimab, or onasemnosium ABB parvovac. That is the gene therapy. Jewelfish population is broad and heterogeneous group because it is a type 2 to 3 we're already on treatment with a high degree of motor impairment at the baseline, reflecting the real world SMA population. So it is a heterogeneous populations. The 12-month interim analysis safety shows the adverse event and side effect, the severe adverse events were reflectively underlying the disease. So very less. Risdiplam treatment has shown sustained improvement with more than 2-fold increase who were treated with the other mode of therapies. Low rate of discontinuation. So no one, out of 174 patients recruited, only 9 patients has been withdrawn from this study site. Interim exploratory efficacy data showed that overall stabilization in motor function was observed in patients who began treatment with risdiplam following previous treatments. So even the naive patients or treated patient, there is constant gradual improvement after risdiplam. So in so this is again rainbow fish study. Again there also they have seen the PK, that is pharmacokinetics and pharmacodynamic safety, and the other measurements like developmental survival and the movements, motor movements they have taken as a part of the study. And up to 6 weeks, 42 days of the age at the time of first dose. So at the time of rainbow fish study data, 4 out of 7 SMA2 copies, 2 infants had a baseline compound muscle action potential, and 2 infants had a baseline compound muscle action potential less than 1.5 millivolt. So most of the infant with the 2 SMA2 copies treated with the more than 12 months achieve motor milestones within the WHO window. So if you can see the graph, they have constantly gaining the motor milestones according to the WHO guideline. So this is the summary of the presentation as of February 2022. The worldwide recruitment for RemoFish is complete. Now the study is going on. And 7 infants who were treated with the risdiplam for more than 12 months. Most achieved motor milestone with the WHO window for healthy children. So it is compared with the healthy children, that is the quite good hope. All achieved sitting without thought by 12 months, and all maintain the ability to swallow and were able to feed exclusively by mouth. None required hospitalization or permanent ventilations. No severe adverse events were reported after therapy. So this is the presentations. Thank you for patience hearing, and this slides from the Rose. I thank Rose for sponsoring this session.
Thank you, ma'am. Very nice presentation for the the treatment of the SMA. I know heard from the previous lectures that this is serious disease. Now, one thing I asked the question: is there any carrier? How can we diagnose the carrier, and how
So there's a genetic studies there, but it's not so easily available and the costly affair. And if you are a geneticist and all, they can do it in the, and sometimes they might think of the screening in the newborn area times also.
And during marriage, there is screening system is must necessary for the patient is carrier. Then
Yeah, actually it's such a huge cost of the treatment, diagnosis, and also now we no one is thinking of career, but in the future we might think of the diagnosing at the newborn and all, it may come in the policy later on.
Genetic treatment is very costly, and this is hard. One injection is 2 injection is cost about 17 crores rupees.
Yes,
that's right.
In crores, not in lakhs.
Not in lakhs.
Can we wrap up? We are running short of time.
Yes, yes, thank you.
Difficult to
Can we wrap up the session, please?
But you this type of treatment should be.
So thank you so much. Let us conclude the session. Just one question. What is the cost of the therapy per month with the risdiplam?
Actually, I have not started giving the drugs, so I don't have any idea. I think if the Roche people is there, they can take this question. Anyone from Roche?
We are running short of time.
Zikanya?
I will get the question. Okay, okay. Thank you so much.
So I think, thank you audience, and thank you chairpersons.
So the next session, ICHD approach to childhood migraine.
No.
Precision. Oh yeah, I'm so sorry. The next session will be precision medicine in neurometabolic disorder, and the speaker is Vineet Wankere. Dr. Wankere, please.
Yeah. Thank you, sir. At the outset, I want to thank Dr. Arijit sir, Dr. Kalpana madam, Jashodhara madam, and Sudeep Shah sir for inviting me. So the topic is precision medicine in neurometabolic disorders. So the current era of the medicine is of 4 Ps. What are those? Earlier we had a symptomatic medicine and then the definitive medicine when the era was of infectious disorders. But now we have a non-infectious, non-communicable disorders. That's why we're talking about the preventive medicine. That's the first P. Second is a predictive medicine. Now we have different tools. Now the person is likely to be healthy and now he want to know whether I will suffer a heart attack, whether I will suffer in carcinoma. So you have some tools to diagnose those. So that's called as predictive medicine. Then, and we have studies to see the natural course of the disorders. Third is the precision medicine. What is this? You have a target. Now with the advent of the genetic science, you have a definite mutation for the particular disorder and you are hitting the target. This is called as precision medicine. And last is a participatory medicine where the person is involved in the formulating the plan for the patient. So this is called this is the 4 P's of the current medicine practice, out of which we will be talking on the precision medicine. That too, my topic is precision medicine in neurometabolic disorders. So you all, as been already told, the fundamental concept of precision medicine is personalizing treatment to target the precise molecular pathogenesis at a given condition. So you all know IEMs are a group of more than 600 heterogeneous disorders presenting in newborn and infant, manifesting in the form of drug-resistant seizures and an or encephalopathy. So how common are they? The global prevalence is almost 49, and they have been studied across the 40 years. And now to come to know, 1 in 2,000 kid or the newborn has a IEM. So recent advances in neurometabolic disease, a genetic role in the modern era. This is a beautiful paper, very recent, August 2023 in Grid Teen. Careful phenotyping, clinical phenotyping, biochemical and metabolic screening, and high index of clinics in suspicion can facilitate the early treatment trials, which have a critical impact on reducing the neurological morbidity and mortality. Now, these adjectives are very important. So not all the patients need to go for a genetic testing. Nowadays, there is routine practice that people are sending the genetic diagnosis here and wire, because these genetic companies are coming to you and asking you to send the panel. So it requires a proper clinical phenotyping and a biochemical screening and a high index of clinical suspicions. I think there is the bridge, there is a lacking, we are lacking that gap. So this is particularly true for the vitamin responsive and cofactor responsive early onset epileptic encephalopathy and the seizures. So what are the genetic tests available with us? Chromosomal microarray, single target sequencing, DNA methylation analysis, nuclear clinical exome sequencing, mitochondrial sequencing, and now the latest one is the rapid exome sequencing and whole exome sequencing. So what is the overall, this is a beautiful paper which was published in Lancet 2019. It talks about the clinical application. Okay, we're sending the samples, but what is the clinical utility in patients of pediatric neurology? So overall, they have studied all different categories of the disorders, what we look in pediatric neurology, and what is the clinical application. So on this axis, it's the number of patients. So the size of the circle tells you the number of patients studied, and the vertical axis tell you the number of the percentage of the patients got the diagnosis. So if you see autism, it's around 20. If epilepsy, it's around 30 to 35. Dystonia, around 40 to 45. So neuromuscular disorders, around 20. So more or less, if you see all disorders in toto, 1/3 of the diagnosis can be achieved by doing this test. Okay, this is what the summary. So what is the recent thing which is coming up is a whole genome sequencing. In usually whole exome sequencing, we test the exome region, that is the protein codon region. And in whole genome sequencing, you are testing the introns plus exons, means non-coding regions and coding regions both. And the more important thing is the rapid exome sequencing. What is this? So what is the time limit for if you send a sample of clinical exome sequencing, what is the problem? Is that the report comes after 4 to 6 weeks, and that is very important for the neurometabolic disorders, because then and there you have to act very fast. The child is admitted in your ICU, and you will getting report after 6 weeks. So that's not going to solve a problem. So the new thing which are coming up is a rapid exome sequencing, where you will get the report in 7 days, in a week. And then there is an ultra rapid sequencing, in which you will get a report in 3 days. So before your TMS and GCMS comes, you will have a genetic report in your hand. Okay, so if we make it ultra rapid like this, what is this utility? So this is a very recent paper, this year only. So these are the 2 RCTs, which tells about, one in California and another in Australia studies, which talks about what is the use of this rapid genome sequencing. So it has told, so you just see the data. So RGS is highly clinically useful in 77% of the patients of 201 infants that they are tested. It has changed the clinical management in 28% of infants. and overall outcome in 15% of patients. So you can see, even you can prognosticate bad or worse or this, that, it has changed the management in 28% and outcome in 15%. And Australian studies also say, tell you same thing about the 108 critically ill patients. The diagnostic yield is, so if you are not getting any cause, child is having encephalopathy, you must be getting those all patients in your PICUs and NICU specifically. The child is having an unexplained neonatal encephalopathy, and your all workup is negative. They have categorically selected those patients, and the result is diagnostic yield is 51%. So that is something very important. So everyone is saying this, that thing, but the high index of clinical suspicion is something where we are lacking. I feel that with the case discussion, how to suspect clinically has to be focused. So let's go to some cases, because we are all clinicians. We're always interested in discussing cases, and that's how we'll take home some messages. So let's go to the case 1. This is a 7-day-old male child, neonate, with a recurrent and refractory seizures since day 1 of life. But there is uneventful birth history. But seizures are drug resistant and persistent. There is a mild but disproportionate encephalopathy. Means what? If you have persistent seizures since the birth, you should have a dense encephalopathy. But it's a disproportionate encephalopathy. Encephalopathy component is less, and you have a seizures more. Ammonia and lactate normal, the usual what the pediatrician send. TMS is negative, GCM is negative. What is your thinking process? Let me show the video. There is no HIE. Look at the child. Sorry for this video, because the patient has taken this video and there was no seizures when we saw the child. Can you see the eyes of the child? So it's a continuous, like opsoclonic kind of movement with a jitteriness, with myoclonic jerks, something like that. So, will you repeat a TMS? Because TMS was negative, the possibility of metabolic seizures is very high. Okay? So, will you repeat a TMS? Sometimes we say that the TMS was done erroneously, or there's some sampling error. So, what is your take home on this? So, what are the steps? So, will you repeat? Will you send exome sequencing? And if you send exome sequencing, does it replace the need of metabolic testing? Okay, we will first go systematically. Let's look at the EEG. That is the first thing to do. It has shown a burst suppression pattern. So, how to go ahead with these cases? Now we have unexplained seizures, which are predominantly myoclonic, and you have EEG showing a burst suppression, likely to be metabolic. So the clinical diagnosis is early metabolic epileptic encephalopathy. That is the syndromic diagnosis in neonate if you have metabolic seizures in neonate. So we got to know, we did an MRI. MRI was normal. Now MRI is normal. You have a EEG showing burst suppression pattern. So what was missed is you are not mentioned the type of seizures. The child is hyper alert. Can you see the video again? So child is hyper alert during the seizure type. So this is a clinical clue for pyridoxine dependent epilepsy. So somebody started a pyridoxine, we started a pyridoxine, and then the seizures completely stopped. So this is a classic clinical phenotype of pyridoxine dependent epilepsy. And the things which was missed was the clinician have not noted the findings in toto. So, so the workup was done, and then we have got the ALDH71A mutation. So you have a different genetic disorders out of it, and few are responsive, few are not. So treatment is lifelong. So we did a pyridoxine, and the EEG is totally normal. So basically it's a glutamate to GABA. Glutamate is excitotoxin, and GABA is inhibitory. And the single step between that transamination is guided by your pyridoxine, which is lacking. That's why you have a lot of glutamate in your brain, and that causes all things. So treatment is lifelong pyridoxine. So is the story that simple? Some pediatrician, senior pediatrician might say, okay, otherwise we were trying pyridoxine in all cases of neonatal seizures. So how does a genetic diagnosis helps in the diagnosis otherwise? So this is a very new paper, April 2024. It talks about the long-term follow-up of these patients. So 75% of this pyridoxine-dependent epilepsy will suffer from intellectual disability. 75%. So story is not that simple. So it needs additional, it talks about, it is a paper, it talks about an additional therapeutic intervention beyond pyridoxine. So they have found that the supplementation of pyrimidine rescues the abnormal neurogenesis and cognitive impairment in a mice study. So what I want to say to you is genetic diagnosis make the understanding better and find out the future options for the therapeutic treatment, not only for two disorders, but also the associated comorbidity and associated abnormalities it causes because of the primary metabolic disorder. So this is something important. That's why we should work up all those cases. Mere starting of pyridoxine and ending is not the final thing. Another take home is there are a lot of metabolic disorders which are not covered in your TMS. Pyridoxine dependent epilepsy, and we must know this list. Sulfitide oxidase deficiency, folinic acid, creatine deficiency, molybdenum, GLUT1, and mitochondriopathies. Out of this, pyridoxine, folinic acid, creatine, and GLUT1 have a proper standard treatment protocols. So if you miss by any chance, you are liable for, so you know all this, the medical legal scenario these days, and you can be trapped. So clinician, so what is the learning lesson out of this? Is the clinical suspicion is must and gathered through a systematic approach and a careful observation of the seizures, the videos, and the systematic plan. So we must know the metabolic disorders which are not covered. The trial of pyridoxine is must in all cases. The genetic diagnosis is easy way and effective for the diagnosis and the designing a perfect management strategy. Let's go to case 2. So this is a seizure in early infancy. This is a 2-month-old child, infant, with a normal perinatal history, normal for first 2 weeks. And these are the seizures. They become frequent and then continuous. So I went for this call, and the pediatrician loaded with first phenobarb, then phenytoin, then levera, then midazolam, then pyridoxine, but nothing worked. So look at the type of seizures. What is your take on this? Anyone can volunteer? So what are these type of seizures? So usually whenever the seizing child comes to you, you look at the how to manage those seizures. Let's stop these seizures first. And you go with the status protocol. So that is the usual mistakes done by the commonly pediatricians. See, this child was interactively, between the seizures was normal. So can it be possible that the child is seizing since 2, 3, 4, 5 days and it's normal, having a no encephalopathy component? It's very less likely. This was a pointer for something abnormal. This is something fishy, so likely to be a metabolic cause. But nobody paid attention, and everyone was pushing the anticonvulsants. So look at the type of seizures. So ILE tells you the first look at the type of seizures. So what is this type? This is myoclonus, but is it a normal myoclonus? Myoclonus has to be symmetrical and proximal and jerky. Is it symmetrical? This is not symmetrical. This like this, like this, like this, like this. The different group of muscles are affected in asymmetrical fashion, in a rapid succession, in a neonate. It's called erratic myoclonus. This myoclonus is not the usual one. This is erratic myoclonus, and this is very classical of IEM, because the diagnosis is again early infantile metabolic encephalopathy. So age of onset of seizures has to be taken into seizure classification. Type of seizures, the multifocal and erratic myoclonus, drug refractory, and common causes are excluded, sepsis and all. So it's 10 minutes or 20. Okay, so this is burst suppression. So approach is 2 weeks, type of seizures, EME. So can it still be a channelopathy? Again, it's a 2-month age, the common presentation for channelopathies. So look at the type of seizures. It's always mostly tonic seizures in channelopathies. It's erratic myoclonus in your IEMs. So the things are revising up, and ILE is coming up with the guidelines. We need to update ourselves with these guidelines. So because we have a specific patterns of channelopathies which do present in this age group, and we have a specific treatment. So people feel that channelopathies or whatsoever diagnosis you're getting on clinical exams doesn't have any practical relevance. No, it has a lot of relevance, and there is the role of the precision medicine. So if you are KCNQ2, you have sodium channel blockers as a treatment. SCN2A, the seizures less than 2, sodium channels more than 3, non-sodium channel blockers. SCA8, here all are sodium channelopathies, but here you have to avoid the sodium channel, and here's the high dose of phenytoin is a treatment. So sodium channelopathies, but variable phenotype with the variable treatment options. It depends on a loss and gain of function. So we'll not go into the details. So what was missed in our case was the hair loss. Have you anyone noted the hair loss in the video? So it was a case of biotinase deficiency. So you all know, after 2 months of supplements of biotin, the child is having absolutely normal development. Child is having perfect head control and everything. Only treatment is biotin. Lesson learned, always look at the type of seizures, develop a systemic approach, crime to miss such clinical phenotype. Always remember the triad of EME and look at the clinical pointers. So this is a genome-based therapeutics, the era of precision medicine in genetic studies. They have recruited, this is a case of 400 they have pulled the data of 4,000 patients, out of which 20%, 768 they have typically suspected of genetic etiology, and out of this, the 27%, one-third turn out to be genetic cause. So you can see, and then accordingly they have formulated the different, what the actual, really we can make a difference in a management. So almost one-third of the patients in those suspected got a different modality after the exome sequencing. So this is how we can confer the data. Let's go to case 3. 18-day-old male child, seizures followed by encephalopathy, got mechanical ventilation, sepsis workup negative, but it was at periphery. No TMS available, nothing. This was a MRI showing a lot of hyperintensities, recorded by the radiologist as leukodystrophy. I went and saw the child. There was no money at all with the parents. I started some cocktail, reported as a leukodystrophy. I started these supplements. Child sent DAMA. Can you believe after 6 months they came to me with a normal development and perfectly normal child. So this was a case of biotinase deficiency, and I just started biotin and patient responded at home. So what I mean to say, why I included this case, you may not get a classical phenotype always. You may not get those erratic myoclonus always. You may not get the hair loss always. So do not rely on MRI reports blindly. Do investigate in drug refractory cases, send baseline studies. If not avoiding, at least start those cocktail regime. So let's go to, I think I need to be very rapid. This is a case of Leig's disease. So I want to tell you a few, so if you get a diagnosis of Leig's disease, you again send the patient home. That's the usual dictum we were following, pediatricians were following. But now we have a complex 1 deficiency which can be treatable with a ketogenic diet. There are some variants of thymine responsive leaks and biotin responsive leaks, which has a good prognosis. A case was reported from PGI Chandigarh. So this is again a case, had a refractory seizures, but the 3-year-old presentation with the absence and myoclonic jerks. Recurrent admission with the status. So EEG showing absence status. What is your comment? Can the absence epilepsy be there in 3-year child? So epilepsy, so if you have a childhood absence epilepsy, the spectrum is always from 4 to 10 years. So usual clinical childhood absence epilepsy, CAE, has a defined age limit. So you will not get seizures as the first absence in 18 years of life. No. 3 years, no. If you are getting early absences, that is telling me something fishy. Can the absence epilepsy have a abnormal development? Normal childhood absence epilepsy always have a normal development before the onset of absence seizures. So if you have abnormal development before the onset of seizures, again it's fishy. So if your absence is less than 4 years, if your developmental delay, if your investigations are normal, what is your diagnosis? This is actually a postgraduate question. This is GLUT1. That is a glucose transporter. And this is a hypoglycoria. The CSF glucose levels are low. So this is how you have to suspect. But the clinical suspicion, so nobody has paid attention, everybody started valproate and this is not going to work that way because you are not seen, you are not defined the syndrome properly. Okay? So we have started, so the treatment choices, why you included in this? Because there is a modality, ketogenic diet. So those who have not seen the tonic falls, please see this child. So this was having a very bad atonic falls. So just look at the child after, I think, 5-6 seconds he will have a, so he's on the bed. Look at the child and then, yeah. Can you see that? He just fall like anything. If your atonic seizures, lot of EGs we are getting for sitting atonic seizures. If your atonic seizures, child has to hit the injury. Then it's not atonic seizures if you are not hitting the injuries. So this is a atonic seizures, which is classical in this, atypical absences, myoclonic seizures. On day 7 of child is okay. And on day 21, child is doing far better. So what I mean to say is there is a treatment option. GLUT1 has a recommendations and when to start KD, there are recommendations and this is getting fine and fine every single year. So I think
we wrap up?
1 minute just, last one case,
Can we wrap up, please?
28-month-old with a recurrent seizures, with a febrile seizures and atypical seizures, ataxia neuroregression. This is a case of SCN1 mutation. What I want to highlight is genomic testing in pediatric epilepsy has a lot of significance. And this is a paper which is published in 2020 that talk about the emerging therapeutic consideration for number of genetic clinical epilepsy syndromes. And there is a list. So if you have this mutation, the drug of choice is pyridoxine. If you have CACN1 mutation, have you anyone started acetazolamide for your child or for drug refractory cases? Hardly you will start that. Unless you have a mutation, then only you will start the acetazolamide. That's the drug of choice, not all anticonvulsants. So likewise, what to avoid, what to start, not only the drug of choice, but what to avoid also. So the list is getting increased day by day. So this is 2020, now the list is getting updated. Okay, so evaluate all cases of drug refractory seizures with unexplained encephalopathy, neuroregression, with episodic presentation, normal or inconsistent MRI. You have clinical suspicion, different MRI showing something different. Progressive myoclonic epilepsy, suspected IM, go for clinical exome sequencing. I think we'll finish, we'll skip those all cases, but these are something very important. So just one word. So this was a case of 12-year-old male and came with a progressive cognitive decline.
I think we
and
have to
reported
stop.
as a hyperintensity and it came out to be homocystinuria. This is again a treatable cause. So final slide. So inherited, these are the metabolic epilepsies you should never miss. Top 10 diagnosis, it's never missed in your practice. So conclusion, with the emergence of the diagnostic techniques, understanding is getting better. Use of precision medicine in IEM is increasing. This has helped us in designing the better management strategies. However, it's crucial to have a systematic and pragmatic approach for the diagnosis of genetic disorder, not sending clinical exome sequencing randomly. Thank you so much.
Thank you so much for a very elaborate talk. I have a small question. Is always erratic myoclonus related to IEM?
Yes.
Thank you.
Erratic myoclonus is neonatal. Is always fishy, you should suspect because that is the classical seizure type of that clinical syndrome, that is epileptic myoclonic, early myoclonic epileptic encephalopathy. Thank you.
Thank you so much.
Thank you, sir.
Dr. Shubhashish Roy has to leave, but I would request Dr. C.K. Ghosh to kindly chair our last session. So please invite our next speaker.
Dr. Dipankar Gupta. Dr. Dipankar Gupta is a deceased DNB and ND pediatrics. He is
Hello.
DNB neurology from Kolkata. PG DN Development Neurology Associated Professor of Pediatric IPGMR Kolkata. Consultant Pediatrics Neurologist teaching experience more and more, and he is a member of the IP and ASCON and INN. Thank you, Dr. Dipankar Gupta. Please start.
Good afternoon. Headache is one of the important subjects because this is the most common neurological disease in children.
It's a case of
But
migraine.
headache is a subspecialty or specialty in the different other countries. Like headache medicine is a different specialty just like neurology. So because it's an enormous aspect and the diagnosis does not give much results, and basically you have to identify the different variety of headaches by criteria itself because neuroimaging and other studies do not help. So I will start with a case itself. I will go very fast because the main topic is how to use the ICHD criteria for diagnosis of headache. This is an 11-year-old child presented with repeated headache episodes. This is the only starting slide. So her headache was initially episodic. The episodes were bifrontal, throbbing, and lasted for 2 and 2.5 hours between it, and escalated quickly between photophobia and phonophobia, loss of appetite, but no vomiting. She would seek a dark, quiet room and unable to read or exercise during the headache episodes. The headache remained bifrontal with fluctuating levels of pain, mainly moderate in intensity, but occasionally severe. And the mother and brother also have migraine. So what do the symptoms suggest? So analysis, this a headache is basically a long history of headache, the return to normal health between attacks, and normal clinical examination. This type of headaches, more than 10, length of attacks, severity of pain, and the nausea, vomiting, return to normalcy during attack, we have used the ICHD-3 criteria, not the beta. The ICHD-3 is already published. And the different criteria, headache lasting 2 to 72 hours, headache at least 2 or 4 hours, it fits into the infrequent episodic migraine with aura. Now you have to find, you will get headache in a lot of your practice, but we should use the ICHD criteria because to diagnose and the ICD classification of it to administer the drug. So ICD criteria is very important. So objects of this study is find to the epidemiology and types of headache, use the ICHD criteria, and brief on management. And this is, I have told you, the most common, with the majority type in childhood age group are the migraine, tension type, and attacks are very rare. And recurrent headaches are important because they significantly disrupt the quality of life, because this is the main childhood period of development and studying and all up to the college life. So it impairs the quality of life. The academic performance gets much disrupted. And the episodic tension type is the most common, much commoner than migraine. And secondary identification of headache is important to find out the migraine to eliminate the secondary headaches. And this is the most common type, and the quality of life lost is the most criteria to find out and identify therapy where it's required or not. We should not administer therapy vis-a-vis. And it averages in different studies from 5 to 82% of children. In different studies with different parameters using different criteria like ICHD criteria, IHS criteria. And it's more common in the childhood part in the between the 5 to 12 years in children and also adolescent. And this is to clear the primary and secondary headaches. And because we need MRI and all the imagings to screen the secondary headaches. The primary are mainly recurrent tension type, and secondary as acute serious after a fall or just a brief jerking movement, a head injury, or infection like that, or in case of a brain tumor, which is present with early morning vomiting and severe headache like that. So this is the criteria based from IHS criteria, not the ICHD, of the classification of primary headache. Mainly, there are a lot of types, but migraine, tension type, cluster headache, and these are the important. And mainly the secondary headache are headache, neck trauma, cervical, spondylosis, or vascular disorders, infection, disorders in hemostasis, psychiatric problems, a lot. Now the type 2, the case 2. Sunil is a 10-year-old boy presented with recurrent headaches, and his headache started 3 months earlier, had a head trauma in the football match, lost his consciousness for a few minutes, but CT scan showed nothing abnormal. After a few days, he had headaches occurring nearly every day, from 6 to 8 weeks, and then reduced to 3 times per day. Each episode lasts between 1 to 1.5 hours. The pain is mainly on the forehead. So what the history suggests? This suggests that Sunil may have an episodic tension type headache with a mild pressure pain, and this is the ICHD criteria of post-traumatic headache. where the trauma has occurred, the headache occurring 7 days after the occurrence, the injury to the head, regaining of consciousness, the CT may reveal nothing, and headache if it persists for 3 months. So we can use the ICHD criteria, though this is not always used, but we should use for the commoner varieties. And this is the ICHD variety. The 3 beta has been lost. Now the 3 is available in the net. I'll not go into the details with the criteria for migraine with aura, because this is much classification of the, basically it lasts 4 to 72 hours, and headache has 2 or, all the other criteria are similar. The 2 or more, the 4 characteristic, the location, the quality, the pulsating, and severe intensity. And this is with aura. Basically, with aura, this means the headache with the fully reversible aura with visual, sensory, speech, motor, brainstem, and retinal. Other parts remain the same. And now the ICHD treated migraine may be classified as migraine without aura, with brainstem aura, hemiplegic migraine, chronic migraine, status migrainosus, probable migraine, episodic migraine, and migraine variants like cyclic vomiting syndrome, abdominal migraine, benign positional vertigo, which are migraine variants because they initially present in the childhood age group, but later on will turn up to be migraine. So this is a brief picture how to present, because we cannot use the video of migraine or how like that. Intensity, the hammering, throbbing headache. This is a picture which can be used in a scale which is known as PET Midas, how the patient draws the headache on the paper. It can be used to classify the headache. On activity or not. This is the drawing of the headache, this nausea, what the child draws can give you a brief diagnosis. Vomiting, this is the picture, what is the actually patient drawn. Photophobia, what the child has actually drawn. Now, headache by location, as basically the sinus is in the head, is the secondary one. The cluster is behind one eye. Tension is a band-like or pressure-like sensation. And the migraine, we commonly know the throbbing, pulsating type. Now, case 3. A 11-year-old child, Geeta, presented to the hospital with repeated vomiting episodes and after the administration of IV saline. Since 3.5 years old, she has repeated retching and vomiting, and attacks lasted 4 and 4.5 years. There's a history of migraine in the mother, and the systemic investigations are uneventful. What do the case suggest? The repeat cyclical vomiting. Now, this is the similar. The child has been unwell and vomiting, predictable regulatory symptoms. Geeta returns to normal health during episodes, normal development, benign condition, GI conditions excluded. We can use the ICHD beta criteria, which to foods for the migraine. This is the migraine variant. Now, periodic migraines are associated migraine, a cyclical vomiting. Also, there may be abdominal discomfort, anorexia, abdominal migraine, recurrent attacks of abdominal pain, anorexia, nausea, vomiting. Case 4, a 10-year-old child needs to present with recurrent bouts of umbilical pain. Her pain is vague, dull, with constant pain, holding the tummy during the pain and bends forwards. The episodes last 1 to 2 hours. Her problem started in infancy with history of colic attack between infant colic at 3 to 4 months, 7 months of life. And the mother noticed she started screaming 2 to 3 hours. During the episodes, she was pale, sweating, photophobic. What do the system diagnosis suggest? Abdominal migraine. A lot of patients you see, the child with infant colic, if you take the history from the mother, she is suffering from probable migraine or migraine. The infant colic, if it persists, may turn out that this is the precursor of migraine itself. So we can use the criteria. The criteria that basically the pain is midline location, periumbilical, poorly localized, dull, sore-like quality, and the anorexia, nausea, vomiting, you can put into the ICHD criteria of migraine. A 5-year-old child, G2, presented to a pediatric OPD for panic attacks. They was occurring 3 to 4 weeks interval and unprovoked. During the episode, she looked pale, frightened, and hold tightly to the mother. The mother would pick up, and the attacks passed away between 2 to 3 minutes. Initially, the child was unable to describe the symptoms, prompting she would notice the floor was spinning. My mother initially did not see the eyes of the patient, and would pick up during the attacks because she would pick up, she would not see the eyes. And 2 occasions, the eyes started spinning sideways. So what is the diagnosis? Benign positional vertigo. This is also a migraine variant. This is the full awareness, return of awareness during the episodes of vertiginous feeling. This combination of features, normal neurological, ENT, normal MRI scan, you have to screen the MRI scan in this case. And these 5 attacks, at least one of the 4 nystagmus, ataxia, vomiting, and pallor, fearfulness, you can put into this criteria of benign positional vertigo. I've just briefly covered which are more common in the pediatric world. So basically, the initial evaluation is the tension type is diffuse, non-throbbing. The migraine headaches are bifrontal and unilateral, moderate to severe intensity. Aura may take a long time, 5 to 60 minutes, though majority of studies use 1.5 to 2 hours. And you have to also screen for the secondary causes of outbreak. This is the approach basically. I have briefly summarized by the cases. And basically, the history taking is important. And the child sits close to the clinician. And if the child is more than 5 years of old, the child's view can also be taken. The red flags of the headache are worsening after supine posture, Valsalva maneuver, cough, thunderclap headache, which may ICH or some hemorrhage, new onset headache. There was no other history or in the family. Visual changes, not characteristics of the migraine, like photomata or zigzag sensation, focal neurological signs, and also visual field defect, diplopia, decreased visual acuity. These are red flags. So these are the basically indications for imaging. That's what I've just told. The principle of management are basically reduction of the headache frequency, severity, duration, reduction of reliance on poorly tolerated, ineffective, and pharmacotherapies, improvement in quality of life, avoidance of use acute headache medication, much more than 2 per week. I will say it just briefly. So basically, the drugs are NSAIDs, acetaminophen, ibuprofen, naproxen. These are the most common drugs used. They have shown efficacy in the trials. And triptans, they have also been used. And try not to give the pain medication, not more than 2 per week, because it can lead to a medication overuse headache. And basically, zolmitriptan is available in nasal spray. Rizatriptan has a melt preparation, and sumatriptan is very well found even with paracetamol combination, naproxen combination, but they are used much more beyond mainly 12 years. Rizatriptan can be used 6 years or more. Now, migrainosis is generally does not present. It's a very severe condition where the headache will not occur. You will have to see other diagnoses like intracranial hemorrhage or subarachnoid hemorrhage. A medication used basically IV paracetamol can be used in case of headache, and triptans can be used, the melt ones. The preventive are basically brought their anti-seizure medication, antidepressant medication, antihypertensive medication, and antihistaminics also, like cyclopentine, and some supplement nutritional drugs like melatonin, though it's a hormonal drug, not nutritional, and riboflavin, magnesium, and CoQ are nutritional drugs. And basically, what are the indications for using migraine prophylaxis? At least 3 to 4 severe migraine per month. And migraine that diminish the daily activities like missing school, extracurricular activities, the grades are falling, in the tuitions they are not paying attention, disrupting sleep, these are the indication. And migraines interfering with neurological signs like visual loss or visual weakness itself, confusion, fatigue. Antecedent, topiramate, valproate, gabapentin, lamotrigine, levetiracetam, zonisamide. But basically, we use topiramate. It's very much used and safe drug in the pediatric, though not much in the adult population. The side effects are lesser in the pediatric. Valproate is generally not used generally, but can be used definitely, and try avoiding use in the girls in the adolescent age group. Gabapentin and lamotrigine are generally not used because the other drugs are quite effective. The antidepressants are amitriptyline, not triptyline. Amitriptyline is quite safe and can be used, and they are also in the Cochrane database, and the trials RCT, amitriptyline is useful. And antihypertensive propranolol is also useful. Flunarizine is useful, but you will not find in majority trials because this has recently been approved in the USA. Previously, flunarizine was not much used. And so what are the things to do? Make a headache plan, the headache treatment plan, to find a headache diary, just like a nephrotic syndrome diary, Caesar diary. And this is a tool to use, PEDMIDAS. It is also available in the local languages. You can translate it to use in case of research or like that. And duration of analgesic should not be 3, even they are finding 2 per week to diminish the chance of medication overuse headache. And preventive therapy should be continued at least 6 weeks to see the efficacy. And if successful, preventive therapy should be discontinued after 6 to 12 months of age. And cyproterine is very much common, though there's randomized trial, they do not find anything, but it is very much useful because there's a molecule with antihistaminic, serotonin, and anticholinergic and calcium channel blocking pathway. All are responsible in migraine, so it's usefulness is there. There is no study for that, that's why you cannot find in RCTs or like recommendation. Single dose of head time, you need not give twice. One time will not produce much sleep. And this is a frequent tension type headache. I will not go much beyond that. And tension type headache is a headache lasting 30 to 70 years. Mind it, this is one of the most common. And this is a bilateral location, pressuring, tightening quality, mild, moderate intensity, and not aggravated by routine. Try not to see tension type as because of any panic attack or tension within the family. This is a primary headache variety itself. So, and the treatment of childhood tension type headache is no randomized trial is there. Basically, physical therapy, counseling, supplements, riboflavin, and occasionally this amitriptyline and topiramate help. CDH is the headache lasting for then 15 days per month. Mind it, headache for 15 days per month, but migraine headaches, that means which classifies as 2 or more than 2 hours, for 8 days per month. For 3 months, you can identify that this is the chronic daily headache or persistent headache. The treatment pattern is different. A child, 16 years, presented with increased frequency of headache. The headache severe affects the family. And so you can that this is the chronic migraine with aura or chronic headache. The ICD criteria are there. To find out, this basically the ICD criteria, more than 15 days per month. But now they have also classified 8 days, which is migraine-like headache for 3 months. This 8 days per month, where the C criteria is there for more than 3 months. This is important. Now, treatment is basically continuation of analgesics, but not using much, changing of analgesics, using of non-pharmacological treatment like relaxation and technique, using of prophylactic medication, lifestyle management, CBT, biofeedback, CGRP inhibitors. Now, there are a lot of things and lot of trials in this CGRP inhibitor. None have been recommended now, but trials are ongoing for 2 types of inhibitors, CGRP, and the CGRP pathway. CGRP is erimumab, and the CGRP type are basically fremajunab and epitimab. These are all trials are ongoing beyond 6 years of age, and the trials may be within 2 to 3 years. And another is lamivudine. This is a 5-HT antagonist, but it is not much useful. This causes much problem. So basically, these will come within 3 to 5 years, this therapy. These are very much effective, and especially in case of chronic daily headache, and this is a headache which is problematic, you will find these are much safer, and they are basically the CGRP inhibitors are single molecule, and CGRP type are basically monoclonal antibodies. This will come within a few years itself. So for prophylaxis, topiramate, propranolol, amitriptyline, flunarizine, pizotifen is not much used, cyproheptadine. And lot of this, I have told you, this is the Cochrane the database. All the RCTs are there in topiramate. They're basically double-blinded in propranolol, and RCTs in amitriptyline. Flunarizine, they are double-blind, not RCTs. And cyproheptadine, only open studies, no data is there. Thank you.
Thank you. Thank you, Dr. Gupta. Nicely presentation. Any question from the audience? No. Okay, thank you.
So our next program is the quiz, most interesting part of the session is quiz on pediatric neurology. And you will be thrilled that per question is cash prize 2,000 rupees. So total 14 questions. So 28,000 rupees will be earned within a span of maybe 40 minutes. So, so be ready, excite your nerves, and yes, you will get. So, volunteer from ICH, please stand up and stay. Two people there, please stand up. And Alicia, please cover this row. So you will be given the cheat. And volunteer from Sevasadhan, please stand up. Please stand up. Two people, two students will cover this row and two will suffice here. So, first of all, you distribute the cheat, papers. You distribute the papers and small cheat, that prescription cheat. You distribute the paper and I will flash this question there and you have to write within 10 seconds. And the cheat will be collected by the volunteers. Volunteers will also participate, no problem. So cheat will be collected and it will be given to me. Where is Dr. Dittangshu Das? So, so Shopanda will help me. Please come. So Shopanda will sit in the chair and he will match the correct answers. So, shuru kore jao, just 2 minutes. So, yes, paper, aro chai? Paper to dilam, okay. Moshomi, please come. Help me in quiz. So I need one senior person. So, Supratim sir will match, and Didi aschen. So you are the Didi and Supratim sir will be the senior controversy solver. If there is any controversy arises out of any question, so our president, our ex-president AOPN as well as ex-president IAP will solve the controversy if arise. So let me start. আপনার এখানে দরকার আপনার অডিও দরকার অডিও দরকার এটা যেটাতে হয়ে যাবে কোনো ইয়ে রাখেনি ওখান থেকে অন করতে So let me decide the describe the rules first. So you will get lots of money here. Those who are those who are really intelligent, they will take lots of money from this quiz. So there are 4 rounds. Round 1, 4 questions, clinical neuroanatomy. Then round 2, 4 questions about clinical neurophysiology. And round 3, core pediatric neurology. And round 4, there are 2 questions on neuroradiology. So rules is no oral prompt. The time per question allowed is 10 seconds. After 10 seconds, our volunteer will collect the cheat and it will be given to the senior person, our sir and madam. Sir is Datta sir, Supratim Datta sir, and madam is Kalpana madam. So you have to write in a piece of paper and submit to the volunteer, and no mobile phone assistance. Mobile phone assistance will be disqualified, and there is a fine of 2,000 rupees. So you have to cough up 2,000 rupees from your pocket. If you take assistance from Professor Google. So decision of quiz master is always final. So if you are ready, if everybody has got the cheat, yes or no? Everybody got the cheat? কাগজ দিয়ে দেওয়া হয়েছে, ওইদিকে সবাই কাগজ, এদিকে সবাই কাগজ পেয়েছে? পায়নি কাগজ? সো ফার্স্ট অফ অল কাগজ পিছনে আছে, তোর পিছনে। সো CSS volunteer Srijata, দে কাগজ দে। CSS volunteer, please give. So write your name first. Otherwise we cannot identify. In spite of a correct answer, you will not get any money. So if correct answer is given by 10 people simultaneously, then 2,000 will be divided by 10. So 200 per person. 200 per person. So if 5 people give correct answer, then 4 into 5, 2,000 rupees. So have everybody got the cheat? Yes or not? Okay, so let me start the round. Are you ready? So round 1, clinical anatomy. So this is question 1. The cross-section of a developing fetus nervous system at around day 25. Which of the following structures is represented by number 1? There are 5 numbers, 1, 2, 3, 4, 5 in the picture. You have to write the structures represented by number 1. Your time starts now. 10 seconds. So, Alisha, collect this side. Collect. Time up, collect this side. Collect. Please write your name, otherwise we cannot identify you. Who are you? Who are you? If 20 people is correct, then it is 100 rupees per people, per candidate. So quickly give it to the madam. Quickly give it to the madam. Quickly give it to the madam. So, no more cheat after I show the answer. No more cheat. Time is up. No more cheat. We will not accept any more cheat. So correct answer is not occurred. So how many people has given correct answer? You have to write. You have to write in a piece of paper. So I will announce the name. So round 1, question 1. So round 1, question 1. ঠিক আছে হবে? Correct answer. Okay. Accept 1. So we have to. Okay. Then if 40 people is correct, then 50 rupees per. আচ্ছা ঠিক আছে, I have got some extra questions also, so no problem. Okay, now how many people? Let me correct. Onek. So now I can run this question as a trial run, no problem. As a trial run. So all right. So let's see. So 2000 can be divided by 100. So it is 20 rupees, no problem. $25, $26. সেটা করা যাবে না। হ্যাঁ। So majority has answered correct. So we can keep this. Keep this. We can. So anyway, if it is 40 also, now it is 30. If it is 40 also, then 20 rupees doesn't make any difference. So it's a trial run. Forget it is a trial run. 20 rupees will not make any difference, so it is a trial run. 34. Okay, we'll keep it. We'll keep it and make this trial run. So are you ready for the next question? All have received the paper, cheat. Diptangshu, please come and help Supratim sir. If you have got time, help Supratim sir. So, Orijitda also has entered. So please, Orijit sir, please be an observer of the whole quiz. So, it is just a trial run. First question is so easy. 34 people has answered. So 2000 divided by 34. So that's why around 10-15 rupees it will not cause any difference. So that's why it is a trial run. So now comes another neuroanatomy question. Everybody has got the cheat. So time starts now, 10 seconds. So volunteer, please collect nerve root responsible for pelvic ptosis. And there is a cue that a beautiful lady is running across a terrace. You have to correlate nerve root responsible for pelvic ptosis. Time up. So please collect. So 10 seconds is up. 10 seconds to dekhte chole jacche. Already. बोलते टाइम शेष हो जाए. Please collect. Quick. After collection, I will show my answer. Pelvic ptosis, please. Apply হয়েছে আর আনতে হবে না, চল তাড়াতাড়ি ফাস্ট বাস উইল নট অ্যাকসেপ্ট এনি মোর. Is S1. This is reference is Victor Adam, page 134, Victor Adam Neurology. So S1 segment, if weak, there will be pelvic ptosis. It can be very subtle. It can be manifested during running. So how many? How many correct answer? Only one. Now দুটো লিখলে হবে না. S1. So, Sangi Pogu Gurumurti. Very good. And there are some more. Let's check all. Let's check. Only one. So congratulations to Gurumurti. Gurumurti from which place? Andhra Pradesh. Which college? Barasat Medical College. A big big clap for Sangipago Gurumurti. 2,000 rupees. 2,000 rupees. Eta jomiye side likhe rakhun. Gurumurti, you have to give your phone number. You will get money through GPay. Because government regulation, we cannot give cash beyond some limit. It is a lesson for us. So, are you ready for the next question? Question number 3. Next question. So, this gentleman is recovering from some neurological disease. And after discharge from hospital, he came to your clinic with full sleeve shirt. But it is half on, as in the picture. Now, question is, there are 2 components. You have to correct 2. Then, price is 2,000 rupees. So, enumerate the name of the condition and site of the lesion. Neurology is all about site of the lesion. Time starts now. Timer আছে এখানে. So 7, 8, 9, 10. Off. Collect. Please collect. Very quick. Yes. Volunteer can also participate. Alicia got a prize yesterday. So, please give it to Sir, Madam. There are 4 persons sitting. Deeptangshu also. Quick. So, no more cheat. So, I will show the answer. This is, first part is hemi-neglect and second part is parietal lobe lesion of non-dominant cortex. Non-dominant cortex is the answer. Because I am right-handed, there may be some people left-handed. So that is why it is non-dominant cortex is the correct answer. So here a pointer, pointer আছে. So here what? না জানি নেই ওইটা পয়েন্টার Kino alo. So see, this is left hemispheric lesion. So I am right-handed. So my left hemisphere is dominant. So if there is non-dominant hemisphere lesion, so right-handed person, right hemisphere lesion, then there will be hemi-neglect. So it's very clear from this picture, and I will show you another slide where it will be more clear. So if you allow him to take a dish of rice and fish, he will consume only rice because he is neglecting the other half of the visual field. Similarly, shaving, if you allow the patient to draw the clock, you will draw the half of the clock. Or draw the image, you will draw the half of the image. Half of the body is hemi-neglect. There are various types, hemi-neglect of vision, hemi-neglect of object, hemi-neglect of body surface. So here, somatic surface, there is hemi-neglect, and he is thinking that he owed the shirt on the other side. There is, inattention, yes, correct. 7 correct answers. 7 correct answers to both the questions. Then very good, learned audience. So please read the names. এই যে মাইক একটা আছে ম্যাডাম উইল রিড দ্য কারেক্ট নেমস
কি নাম পড়তে পারছি
বিশ্বজিৎ সরকার, শ্রেয়া পুরকায়েত, চন্দন ব্যানার্জি, দেন রোশন মহাঞ্জ, ডক্টর রোশন মহাঞ্জ, সৌম্যদীপ ভঞ্জ, and another is some
এটা কি সার্ভারে মনে হয় মানে
Hussein, some Hussein, Sarwar Hussein.
এমন নামটা লিখেছে কিছু বোঝা যাচ্ছে না।
And the last one is the Trishita Bosak.
এই 7টা নামই লিখবে?
Yes. হ্যাঁ, 7 জন।
এটা কত নাম্বার?
Third question হচ্ছে 7 number লিখুন।
Correct answer. So 2000 divided by 7. And
Yes.
all have to, Madam has pronounced the names, all have to put the phone number. So that
আজকে যারা অ্যাওয়ার্ড পেপার বা এরা আছে জাস্ট আমাকে স্ক্রিনশটে আমি টাকা ট্রান্সফার করব মানে যারা এই দেবেন আশা করি সবারই গুগল পে আছে বা এই আছে তুমি ট্রান্সফার করবে
ফোন পে গুগল পে
ক্যাশ পাবে না
হ্যাঁ ক্যাশ দেব।
নো ক্যাশ প্রাইস
So this is another question from neuroanatomy.
রোশনটা এই নামটা ভালো
So
বোঝা
the
যাচ্ছে না।
question
আরও
is,
এসেছেন।
মহান্তি
হ্যাঁ,
রোশন মহান্তি
হ্যাঁ বেঁচেছে। So
এদের নাম্বারগুলো
so
এবার এসে দিয়ে দেবে।
question is face blindness is called prosopagnosia.
Yes.
ফোন দেখছি নাকি
Enumerate the sides of lesion. Sides, two sides. So you have to write two sides. So time starts now.
Face blindness is called proportional inverted
10
sighted.
seconds. 5 is over.
Time.
Time up. 10 seconds.
তাও 10 তো গুনবে। হতে দাও 10 সেকেন্ড হতে দাও। লিখতে তো।
ফোন দেখে নেবে ওর পিছনে
20 seconds is over. So please collect quick.
এ কড়া কুইজ মাস্টার।
এটা কি বিশ্বজিৎ না
বিশ্বজিৎ সরকার।
তাদের সাবজেক্ট একদম সুবিধা একদম। So this is your correct answer. Inferior occipital lobe and inferior temporal lobe. This is main component of prosopagnosia, occiput gyrus, which is below in the brain. There are rules of three. So if you see under surface of temporal lobe, there are 3 gyrus and 2 sulci. So in the middle part there is fusiform gyrus.
Yes.
So this is main and the occipital lobe as a whole.
হ্যাঁ পড়ে লিখে দিন।
So here write both the
তুমি তো আনসার ঠিক দিয়েছো?
আবার
ঠিক দেওয়া তো পাইনি।
নাম লিখতে বলে
অপটিক কি নাম?
inferior temporal lobe
আনসার তো পাচ্ছি না
and occipital lobe.
ওই তো ইনফেক্টেড।
এই তো অক্সিপিটাল লো আর ইনফিয়ার।
You have to write inferior occipital lobe as well as inferior temporal lobe.
So no one has answered correct. So
না এখনো দেখা হয়নি। টেম্পোরাল
না একটা লিখলে হবে না।
একটা লিখলে হবে না, একটা লিখলে।
ইনফিরিয়র নি।
টেম্পোরাল লোব আর অক্সিপিটাল লোব কি করে হবে? না হবে না। টেম্পোরাল লোব এত বড় অক্সিপিটাল লোব কিছু না।
Always brain has a dominant lobe. Bilateral হলে এটা হবে না।
হবে না তো।
এটা ডমিনেন্ট লোবে হলেই হবে। ঠিক আছে?
হবে না।
Speech and visual recognition comes from dominant occipital lobe assisted by other side. So reference is Victoria of Neurology, page number 489. Page number 489. And also page number 270.
Hemitemporal কি?
So I am ready for the next question.
না না টেম্পোরাল ফুড গেস্ট।
It is there.
ভেন্ট্রাল হর্ন ইজ ভেন্ট্রাল স্টিম। না না
Oh,
না।
obvious আমি তো বলেছি ওদের করতে হ্যাঁ। ঠিক
না আমার এখানে কেউ
everyone has the cheat. If everyone has the cheat.
খারাপ না দুটো।
If everyone has the cheat, then I will go to the next round of neurophysiology. Next round of neurophysiology.
No one.
Shall I start? So round 2 neurophysiology question 1. The patient has loss of light reflex but preserved accommodation. The question is enumerate the site of lesion and name the syndrome. So if both are correct, you will get 2000. No half.
Time ball 1 2 3.
So time there is timer. So 5 seconds is gone. Another 5 seconds. Please write very quickly. Very quickly. Very quickly. Volunteer time up. Please collect. Please collect. Please collect. Volunteer please collect.
আসলে অস্কি করিয়ে না এরকম হয়ে গেছে এক্ষুনি বল।
So loss of light reflex, preserved accommodation, quick, quick, quick. Loss of light reflex, preserved accommodation, site of lesion and the syndrome. আর নেওয়া হবে না, তাড়াতাড়ি তাড়াতাড়ি, ফাস্ট 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 ফাস্ট। সবাই ইয়ে শুরু করে দিয়েছে, দেখা শুরু করে দিয়েছে পেপার। বাস আর নেওয়া হবে না, আর নেওয়া হবে না। So it is the posterior midbrain or dorsal midbrain. The syndrome is dorsal midbrain syndrome or Perinote syndrome. So both should be there. Both should be there. Oh, acha. Printing mistake hote pare. So how many need the correct?
সব 8 দিন রবার্টস ম্যাম
সবাই আর্টিকেল রয়েছে একদিনও দেয়নি
এরকম সবসময় তো কোশ্চেন দিয়েছিস কেন
সব
যখন সুজা কোয়েশ্চেন তখন 40 If Sudeep increase the prize money next year, then I go little bit higher. Oh, 4000 save হয়েছে, yes. Society 4000 টাকা save হয়েছে।
No one has answered correct.
So none have given the correct answer. So here is the midbrain. Here is the midbrain. So when this is superior colliculi to superior colliculi and two red nucleus. So this is your aqueduct. Mic বন্ধ হয়ে গেছে?
না 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 না
So this is your aqueduct and this is periaqueductal diameter and two third nerves are there. Actually it is a single complex. So it is schematic diagram. So it is a complex and third nerve is coming across. This is dorsal part, this is ventral part. So if anything compresses here, then there will be your loss of light reflex. Loss of light reflex and accommodation pathway, to trace accommodation pathway, actually starts from the frontal lobe.
Yes.
So frontal lobe directly to third nerve nucleus, your accommodation ciliary nucleus, direct connection. So it bypasses the midbrain. So any midbrain pathology, your light reflex will be lost, but accommodation will be preserved. So think of dorsal midbrain syndrome if you come across, and there may be some associated distant mass. So this is your dorsal midbrain syndrome and compression from the posterior aspect of the midbrain, maybe tumor. We call it Perinote syndrome. So are you ready for the next question? Next question, please write it down. Please write it down.
Write the names, don't forget.
Yes, name, without name we will be in a soup. Whose answer it is? So enumerate the name of the neurotransmitters of descending corticospinal tract. There are many neurotransmitters, but which is the main neurotransmitter responsible for the transmission across the corticospinal tract? Corticospinal tract is always descending. Battery chale geche. So corticospinal tract is always descending. So descending corticospinal tract is the main neurotransmitter. Please collect, please collect, please collect. দেখানোর পরে 10 সেকেন্ড হয়ে গেছে। So yes, please collect, please collect and give it to the madam. So this is the neurophysiology question 2, and I will, if no more, so answer is aspartate and glutamate. Aspartate and glutamate is the main neurotransmitter of descending corticospinal tract. And here I would like to add one thing for all PG. Glycine is a inhibitory neurotransmitter in the spinal cord, specially expressed in Rancho cell. So Rancho cell inhibit by application of glycine, and glycine is very excitatory in the brain. So contra.
They have given.
No, একটা লিখলে হবে না। না হবে না, এটা তো রুল। রুল ইজ অলওয়েজ ডিসাইডেড অ্যান্ড ডিক্লেয়ার্ড এট দ্য অনসেট। না হবে না, দুটো লিখতে হবে তবেই পাবে। হ্যাঁ, রেফারেন্স ইজ এনি এগেইন ব্র্যাডলে, সরি, রেফারেন্স ইজ ভিক্টর অ্যাডাম। Victor Adam, neurology. So, if you are ready, can I proceed to the next?
Yes, no one has given the right
So,
answer.
no
Two parts.
one has given
Actually,
the right
one part
answer.
is answered by all, but not by two.
Okay. So, please be ready with your sheet and paper for the next physiology question. So, here, why there is no diplopia in third nerve palsy? Very easy question. Why there is no diplopia in third nerve palsy? Right. 10 seconds is over already. Why there is no diplopia in third nerve palsy? Now give the Chirkut. Time is up. It is a easy question. Easy question. It is there in Hutchison. Hutchison is third year clinical. In our time it is third year. Now it is second year. Second year clinical companion. Hutchison clinical method. Oh, একটা 10 সেকেন্ডের টাইমার দিয়ে দাও না কোয়েশ্চেনের পরে পরে। So please collect the sheet. Please collect the sheet. Fast. আর হবে না বাবা, গুগল দেখে লিখে দিলে হবে না। গুগল দেখে লিখে দিলে হবে না। 10 সেকেন্ডে সম্ভব না, গুগল খুলে লেখা 10 সেকেন্ডে নট সম্ভব। এটা ভাগ করে দিয়ে দে। হ্যাঁ, যশোদরা কটা দেখুক। হ্যাঁ, আনসার দেখাচ্ছি। আনসার ইজ হিয়ার। This is from Hutchison clinical method, page 319, figure 16.9. Third nerve palsy causes complete ptosis. So there is no diplopia. Answer is complete ptosis. Complete ptosis. ঠিক আছে, পার্শিয়াল টোসিস তো প্রশ্নই নেই এখানে। টোসিসে পাবে পয়সা, টোসিসে পয়সা পাবে। কে কে কারেক্ট করেছে, টোসিস লিখেছে? দিস ইজ, এই জন্য বলেছিলাম দীপ্তাংশুকে আগে আসতে, যে মানে আমি ভেবেছিলাম তুমি থাকবে এখানে, তো ম্যাডাম এসে গেছে। তো ম্যাডাম আর স্যার হচ্ছে সবচেয়ে রিলায়েবল, হ্যাঁ, কন্ট্রোভার্সি সলভার। যদি কোনো কন্ট্রোভার্সি হয় ম্যাডামকে সামনে রেখে। সাতজন টোসিস লিখেছে। সো 2000 ডিভাইডেড বাই 7, সবার নাম লিখে ফেলতে হবে।
শ্রেয়া পুরকায়েত, চন্দন ব্যানার্জি, সৌরভ ভট্টাচার্য, শুভশ্রী দাস,
ভেরি গুড,
সরওয়ার হোসেন, বিশ্বদীপ দাস।
Vishwadip also participated in posters.
সৌম্যদীপ ভঞ্জ।
Soumyadip is participating in everywhere. So, your money is 2000 divided by 7. So, are you ready? Can I proceed with the next question? Shapanda, 10 minute লাগবে আর 10 মিনিট বসো, 10 মিনিট। So, next question is, again neurophysiology question 4. Earliest color blindness to appear in a case of optic neuritis. Baby with the optic neuritis may be demyelinating, may be fall, may be trauma, and there is loss of recognition of color vision. So, timer. So, which is the earliest among the Vibgyor? Bas. Quick. যশোধরা আর স্যারকে দিয়ে দাও কটা। So, answer is red color is the earliest color blindness. Earliest color blindness. না না না, দেখো না কি লিখেছে, লিখেছে red. So in bedside clinics, optic neuritis, yes or no, we give a red pen, and you will tell it is blue or white or whatever. So cannot recognize the red color. Earliest. তারপর সব কালার ব্লাইন্ড হয়ে যাবে, বিকজ কালার ফাইবার at the center of the optic nerve, and pressure effect is more in the center, because vascularity, if you consider, highly vascular structure is the optic nerve, and when there is inflammation, maybe demyelinating with antigen antibody or trauma, whatever, so is get compressed and
প্রচুর পেয়ে গেছি, তো একটা
nerve
করে
fiber
হবে।
is lost. Yes.
Hello, first is Dr.
কতগুলো
Many, I have not counted this much. So,
লিখতে তো হবে, পয়সা তো দিতে হবে।
Riya
জিজ্ঞাসা
Ghosh.
করছে নাম লিখতে হবে কিনা, লিখতে তো হবে।
First is Riya Ghosh, Rajdeep, Mohammad Alamgir, হ্যাঁ দাঁড়া দিচ্ছি, ব্রতসী, সরি এমন লিখেছে, ব্রতসী, দেন ডক্টর ডি পান, রাজু, কে রাজু কে, দেন অলকা সাম পাল কি, আলকা কি, অর্কপাল,
অর্ঘপাল তো বলবি, লিখবি তো ভালো করে, ম্যাডাম পড়তে পারছে না।
সুকন্যা জানা,
15 মিনিট শেষ হয়ে।
অভিষেক সিং, আবার সঞ্জয় পাল, সায়নী পান, দেন কুশল ব্যানার্জি, দেন অস্মিতা দেবনাথ, এটা কি, অরিত্র বক্সি, এটা কার নাম, এটা বুঝতে পারছি না, এই নামগুলোকে একটু বয়স হটে লেখো, তাও লেখো ঠিক, অর্পণ, ডক্টর অর্পণ, ডক্টর শাহিদ, মোহাম্মদ হুসেন, হাবিব, মৌবিকা রয়, মৌলিকা রয় বা মৌবিকা রয়, এনিওয়ান,
মৌমিতা রয়,
বিসি ভুইয়া, and this is King Sainidhi something.
Oh,
Kinsandi
from Silchar, na? SMC.
Two names are very eligible, could not.
Yeah, you spell your name here, please come.
Kinsandi, someone from
yes,
K.
She presented a poster.
Please, no, someone from K.
Spell your name.
Oh,
with
sorry.
Rupa.
And someone from A. Arlok, A diye. Asolvia something. Oh. Orpon. Acha to Orpon pe awa jaye. This one. A. Huh? Ashok. Oh, sir, Dr. Ashok.
না ঠিক আছে,
আমি দিয়েছি অশোক দাও,
40 then 50 rupees.
অনেক আছে এই তো।
Now you cannot change the rule after it is declared. So
BC
2000 is the total amount, divided by, if it is 40, then whatever 50 rupees.
বিসি ভুইয়া,
50 rupees is কতজন হলো
নাম লেখা
টোটাল?
আছে, নামটা লিখে দাও। মালবিকা রয়, হাবিব,
কতজন হলো টোটাল?
প্রচুর জন হয়েছে। ওয়েট মোহাম্মদ মাসুদ হোসেন, মাসুদ হোসেন, মাসুদ হোসেন,
না ওইদিকে কতজন?
শাহিদ, এখানে 7টা আছে। কুশল ব্যানার্জি, হ্যাঁ দাদা, 22
22 জন, ঠিক আছে। 2000 ডিভাইড বাই 22, 100 এর কাছাকাছি। হ্যাঁ ঠিক আছে, So let me proceed to the next question. It is on clinical pediatric neurology. So read very carefully. The boy has difficulty in vision, exercise intolerance, seizure on antiepileptic medication, and there are some skin lesion which is refractory to all types of ointment from skin doctor. He has persistent boring pain of palms and soles. Recently, he was detected with proteinuria and hypertension. Special blood test shows alpha galactosidase activity of WBC is much less than the normal. What is the diagnosis? Timer please. Yes, he is confident, he has given it. So if you know, please give.
আচ্ছা আগে একটা নাম ছিল অরিত্র বক্সি সামওয়ান ইজ देयर অরিত্র বক্সি
তো লিখে রাখতে হবে। অরিত্র বক্সি আছে পিছনে।
আচ্ছা ঠিক অরিত্র বক্সি তাহলে অরিন্দম বক্সি দেখো তো নাম
অরিন্দম বক্সি
নাম
না না এটা অরিন্দম লেখা নেই
এটা এ দিয়ে বক্সি
রাইট ইওর নেম নিটলি। চিট আ গয়া সব।
অ্যাকচুয়ালি এত তাড়াতাড়ি নামটা লিখছে তো ওই জন্য তাড়াতাড়ি হচ্ছে
চিট।
আচ্ছা অরিত ভক্ত
Cheat. So I am showing the answer. This is Fabry's disease. লিখে দিয়েছে সবাই।
হ্যাঁ এটা ফেব্রিসি বলে কি মা এটা হান্টার লিখে দিয়েছে কি রে বাবা
বাবা এখন আমি আর পাচ্ছি অ্যাসিস্ট্যান্ট লাগবে
হান্টার
একটু তো সময় লাগবে ওইটার সময় তো সময় লাগবে।
এটা পারা উচিত অনেকের ওই স্কিন দেখেই পারা উচিত ফাইব্রোকিউটোমা অ্যাঞ্জিওকিউটোমাটা তো পাওয়া উচিত
Correct answer.
ফেব্রিস হ্যাঁ দাঁড়া নামগুলো বলি
নাম পড়ে
সন্দীপ ঘোষ কটা গুণে না 3 4 5 6 7 8 আমি ওই ফলস 9 10 11 11 ভুল 11 12 13 আমার কাছে আছে 14
এখানে 12
14 and 12 26 তোর কাছে
আমি দুটো নাম লিখেছি
26
আর শান্তনু ঘোষ
28
সংখ্যাটা পড়েছে এখানে
আর দুটো এখানে
30 ওগুলো আমি ভুল করে ফেলেছি
30
টোটাল 31
correct answer. So 2000 divided
Manohar Singh, Dr. Manohar Singh. Manmohan.
Manmohan Singh. Oh, so you should be sitting in front. Manmohan Singh never sits in the last bench.
Katrina.
So
Abhishek Singh. হাবিব আচ্ছা হাবিব মালহোত্রা নাকি টাইটেল কি
হাবিব বলে লিখে রেখেছি আগে তারপরে
মাসুদ হোসেন অরিত ভক্ত শাহিদ ব্রতসী সাহা রিয়া ঘোষ হ্যাঁ ব্রতসী সাহা রিয়া ঘোষ আলমগীর আলম সৌরভ বার মুকুলিকা আইতি হ্যাঁ রাজদীপ পৃথ্বীরাজ পি রবি প্রতাপ আবার সুকন্যা পূর্বালী ঘোষ সাহেরি জসমিন প্রশান্ত রাজক বেনজির বেগম অস্মিতা দেবনাথ রোশন মহারাজ নাকি রোশনের টাইটেল কি বোঝা যাচ্ছে না
অস্মিতা কি বললে
অস্মিতা
দেবনাথ
দেবনাথ হ্যাঁ
আর তারপরে
রোশন ডক্টর রোশন অর্ণব ঘোষ মুক্তার রহমদ মুক্তার রহমান হ্যাঁ অর্কপ্রভ পাল সৃজিতা বিশ্বাস সামিনা আহমদ অ্যান্ড অর্ণব ঘোড়াই Samina Ahmad, Arnab Ghorai.
So, moving to my next question.
42.
So, 30
42.
majority has answered this correct.
42.
So, timer please. So, question is two pictures.
Oh, এটা উপরে
At newborn period, at 1 year of age, you have to write the name of the gene, newer edited version, and the chromosome. Name of the gene has changed. Newer edited version. So write your name first. Clear handwriting, name, your name. Time up. Or timer. Pass হয়ে গেছে, দিয়ে দাও. Please give it to me.
আর কটা আছে?
টাইমারটা তো কোয়েশ্চন দেখানোর সঙ্গে দিয়ে। So please give. গুগল দেখে লিখলে হবে না, প্লিজ ফাস্ট।
এই কাগজগুলো কালেক্ট করো, তবে তো আনসারটা দেখানো হবে।
না, আর হবে না, অলরেডি হয়ে গেছে।
আগে থেকে নামগুলো লিখে রাখো তোমরা।
হ্যাঁ, কাগজের নামগুলো লিখে রাখো ভালো করে। আগে থেকে নামগুলো লিখে রাখো। If you want to participate in the next question, please write it down. Please write it down. Yes, answer.
না, সব কালেকশন হয়ে গেছে?
কালেকশন হয়ে গেছে, আর সময় দেওয়া যাবে না। This is IKBG.
হ্যাঁ।
New name is IKBKG. Sorry,
অভিষেক সিং, অভিষেক কি জগন্নাথের?
না, this is incontinence pigmentae. Earlier it was Nemogene, now is IKBKG. It has got 4 stages.
They made it jumbled up.
From Oxford Pediatric Clinical Method.
They did IJKBP.
IKBKG. So correct answer will be IKBKG and X chromosome. IKBKG and X chromosome.
You asked the new name, na?
Yes, new name. Nemo হবে না. Nemo will be a wrong answer. Nemogene will be a wrong answer. We cannot accept it. এটা পুরনো বেলাদি পুরনো, ফেলে দিন। So how many did the correct?
Is there anyone?
IKBKG and X chromosome.
IKBKG, not IJKBP.
না, হবে না, সিকোয়েন্স চেঞ্জ হলে হবে না।
No. Two only correctly written, that IKBKG, Dr. Shahid and Ravi Pratap.
IKBKG and X chromosome লিখেছে তো?
No, সেটা half answer, only IJK. I think this is a very difficult question, they should get the answer.
Already declared in the beginning that you have to answer 2 components, then you will get 2,000 rupees.
Okay, so there is no answer for the two components only.
Half answer
is not allowed.
Will not get the mark.
Okay.
না, আর ওই যে সহজে যে 35-40 হচ্ছে, 42 হচ্ছে। So IKBKG plus X chromosome you will get the correct answer. IKBKG X chromosome দুটো লিখেছো? কোথায় তোমার চিট? ত্রিশিতা বসাক IKBKG X chromosome দুটো লিখেছে কিনা? ত্রিশিতা বসাক
the only one who has written the both incandescent. No, she has written incandescent pigmentae IKBKG X-linked.
বাস, তো Ishita Bosak will get 2,000 rupees.
Oh.
Ishita Bosak will get 2,000 rupees.
I think she should.
Which college Ishita Bosak? Bah, very good.
Oh, good. Very good. We are proud of you.
Very good. So she has written one thing extra: incontinent pigmentae, X-linked, and IKBKG. So are you ready? So please write your name. Please write your name clearly. So next. Timer. Boss, আর তিন চারটে কোশ্চেন বাকি আছে। 8-year-old girl with recurrent nosebleed, careful physical examination showed bruit in the liver. Recently, she was admitted for pallor in a local hospital where they found blood loss by stool is a cause. So, the identified a pathology, blood loss. USG Doppler study upper abdomen showed AV malformation in the liver. Her mother and younger brother is also suffering from the recurrent nosebleed. The attending physician did a genetic test which showed mutation in endocrine gene. What is the diagnosis? Many family member affected with nosebleed and something inside the liver. So, endocrine gene, what is the disease? So,
Time up.
Yes, please. পিছনে দিচ্ছে, পিছনে। ওই ছেলেটা।
ইসিতে বসা। নিচে।
বাস, কুইক, ফাস্ট।
খুলি রাখো।
বাস, আর দেখে, গুগল দেখে লিখলে হবে না।
আর না, আর কালেকশন
টাইম আপ।
কালেকশন।
টাইম আপ। গুগল দেখে লিখলে 2000 টাকা ফাইন হবে, পকেট থেকে 2000 দিতে হবে আমাদেরকে।
Yes, that's right.
গুগল লিখলে। So this is hereditary hemorrhagic telangiectasia, also called Osler-Weber-Rendu disease. Mutation of endocrine gene. Correct?
Yes, there are many.
How many questions?
5. 6.
Can write hereditary hemorrhagic telangiectasia accepted answer or this Osler-Rendu-Weber disease. So both we should accept as a correct answer. So how many?
Correct. আর আমার কাছে 5 14 তোমার কাছে?
Count.
14. এটা
দীপ্তাং, স্নিগ্ধান্দুদা একটু সাহায্য করো না। স্নিগ্ধান্দুদা একটু শর্টিং এ সাহায্য করো না এদেরকে, তাড়াতাড়ি হবে।
6 12
তুমি চেয়ারটা নিয়ে এসে যাও না আগে।
ওরে বাবারে, হেরিডিটারি কত তারিখ আছে? ওকে,
কতজন?
20. So 100 rupees.
You have to read the names.
Yeah, ব্রতসী সাহা, সৌম্যদীপ ভঞ্জ, শ্রেয়া পুরকাইত, Arnav Ghorai. The person who has written only hemorrhagic telangiectasia will be not considered correct because you have to write hereditary hemorrhagic telangiectasia then only. Muhammad Muqtadir Rahman, Srijita Vishwas, Arnav Ghosh, Shantanu Samina Ahmad, Riya Ghosh, Dr. Sahid, I am correct, Sahid I think. Dr. Arko Pal, Dr. Masood Hussain, acha. Dr. Saurabh Bar, Dr. Rajdeep, Dr. Diya Tattanj. Anyone please correct your name? Diya, someone? Diya? Spelling the difficult. Divya Tatachari. Yes, Divya Tatachari. Dr. Arit Bhatto, Dr. Gautam Shantanu Ghosh, or Shantanu to Kushal Banerjee. This one is Sanjay Pal and Abhishek Singh.
হয়ে গেছে? So are you ready for the next question?
No.
So this is 4-month-old boy presented with early hand preference. He refuses to hold object by left hand. Anxious mother went to her baby doctor who did MRI brain and confirmed no history of HIE. Mother gives history of migraine on regular prophylaxis. MRI shows bilateral subcortical diffuse white matter hyperintensity, but also finds evidence of microbleed in white matter. So MRI is a doubtful, questionable. So few old infarct is also there. So hemorrhage, infarct are different locations. Radiologist asks for a skin biopsy of the mother. He suspected something. He asked for skin biopsy of the mother for the diagnosis, but refused. Mother refused. Attending physician sent genetic test which showed mutated NOS3 gene on chromosome 19. What is the diagnosis? So timer. Masood is very confident. Please, please come and give it to sir. বাস হয়ে গেছে গুগল দেখে লিখলে হবে না ফাস্ট 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 হয়ে গেছে এদিকে চলে 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 আর লিখতে হবে না বাস হয়ে গেছে টাইম আপ টাইম আপ টাইম আপ কুইক 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 ফাস্ট বাস বাস আর নিবি না কাম 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 ও গুগল দেখে লিখছে ওরা বাস বাস চলে চলে চলে
অতটা লিখতে গুগলে সময় লাগবে
হ্যাঁ গুগল দেখে লিখছে তাড়াতাড়ি ওই জিনটা দিলেই তো বেরিয়ে যাবে তাড়াতাড়ি 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 জিনা ক্রোমোসোম 19 দিলে এসে যাবে ডায়াগনোসিস সো নো মোর চিট সো দিস ইজ
Cadacil.
Cadacil. Cerebral autosomal dominant arteriopathy, subcortical infarct and leukoencephalopathy. So it can be a cause of stroke in the newborn. I repeat, stroke in the newborn, a Cadacil can be one of the cause.
Correct.
And earlier days,
15টা কাটি,
they
15টা কাটো।
did skin biopsy of the mother or a family member and
No, 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 no,
হবে না
no.
হবে না CADASIL ক্যাডাসিল লিখতে হবে
12 তারপরে 15 ছিল আমি গুলিনি
CADASIL
19 কত কারেক্ট
কি এত নাম লেখা সম্ভব আমি কত টাকা পাবো
এত নাম লিখছে
অর্গানাইজিং সেক্রেটারি জিজ্ঞাসা করো যা বাঁচবে তোমার বাজেট থেকে তাহলে রূপাকে দিয়ে দিতে হবে
ফাস্ট 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 ফাস্ট
পেয়েছে কারেক্ট হয়েছে
অনেক হয়েছে দাও এখানে কত ছিল
কয়জনের কারেক্ট হয়েছে দীপ্তাংশু হ্যাঁ স্নিগ্ধেন্দুদাকে কিছু দাও না চিপ কয়টা কারেক্ট হয়েছে
22
সুদীপ একটু ওইদিকে গিয়ে দাঁড়া ওরা যদি মোবাইল দেখে তাহলে তো
29
কেডাসিল লিখেছে
কারেক্ট ইয়েস ইয়েস
এরা মোবাইল দেখে লিখছে
পূর্বালি ঘোষ ধরো ধরো
মোবাইল দেখে লিখছে আর রূপা লিখতে লিখতে
শাহিন জসমিন দিয়া অরিত্র ভক্ত
ডিভাইডেড বাই 30 না নামটা লিখতে হবে তো
সন্দীপ ঘোষ সৌম্য দত্ত সুকন্যা দত্ত অভিষেক সিং কুশল ব্যানার্জি সঞ্জয় পাল সামিনা আহমদ শ্রিয়া বিশ্বাস অর্ণব ঘোষ মুক্তার রহমান শুভশ্রী দাস চন্দন ব্যানার্জি সৌম্যদীপ ভঞ্জ শ্রেয়া পুরকায়েত ডক্টর দীপ পান ডক্টর শাহিদ মোহাম্মদ হুসেন এটাকে রবি প্রতাপ ডক্টর সৌরভ রয় বেনজির বেগম ডক্টর সৌরভ বর পৃথ্বীরাজ মুক্তার মাইতি or Haiti. I'm sorry if I'm pronouncing wrong anyone's name. Rajdeep, Trishita Boshak, and Poonam.
Poonam Pradhan. So, are you ready for the next question? Please write your name very clearly. Last question. So, 13-year-old female presented with recurrent headache for 1 year. Local physician treated her as migraine, but no improvement. She developed recent onset cold, cough, running nose, which aggravates the headache, and admitted to your hospital. MRI brain shows something. What is the diagnosis? And what will be anticipated finding in sensory examination of upper limb? Very quick. জিন দিলে তাড়াতাড়ি আনসার চলে আসছে কিন্তু ক্লিনিক্যাল দিলে আর আনসার বেরোচ্ছে না তার মানে ওইটা গুগল প্রফেসর গুগল ইজ হেল্পিং সাম ওয়ে
টাইম আপ যে কার পরে দিচ্ছে তারা
টাইম আপ প্লিজ কালেক্ট দ্য চিট প্লিজ গিভ বলে দেবে চিট আর লিখলে হবে না, যে দিয়ে দাও তাড়াতাড়ি দিয়ে দাও, টাইম আপ।
দেখেন দুটো টু পার্ট
তাড়াতাড়ি
আনসার
তাড়াতাড়ি তাড়াতাড়ি তাড়াতাড়ি
which what will be the anticipated finding the sensory
তাড়াতাড়ি তাড়াতাড়ি তাড়াতাড়ি।
এত কম আনসার এলো কপি স্লিপ এলো তাতে সিম্পল
তাড়াতাড়ি তাড়াতাড়ি।
সব কালেকশন হয়ে গেছে,
বাস, হয়ে
নো
গেছে,
মোর
আর না।
কালেকশন, নো মোর কালেকশন,
নো মোর কালেকশন, বাস আর কালেকশন হবে না, আর কালেকশন হবে না।
তোমরা এত দেরি করছো।
ওইটার হ্যাঁ আনসার, ওইটার আর দিস না, ওইটা কালেকশন হবে না।
ঠিক আছে দেখা হবে, আর দেবে না, আর নেবে না,
টাইমের অনেক পরে দিয়েছে।
আনসার দেখাও।
আর্নল্ড চেয়ারি অ্যান্ড সিরিঙ্গোমাইলিয়া
দুই লাগবে,
লিখেছে কেউ? Very easy. Unexplained headache in an adolescent is, you have to rule out Arnold Chiari. Bas.
What was the second questions of the second part?
So here ends the quiz. Arnold Chiari and Syringomyelia.
What? আচ্ছা ঠিক। হ্যাঁ
Syringe লিখলে হবে।
Yes, মাইলিয়া মানে ওটাই তো। হ্যাঁ
Syringe।
yes, দুটো
লিখলেই হ্যাঁ দুটো লিখলেই প্রাইজ পাবে,
না হলে পাবে না,
না হলে পাবে না। তাহলে কটা হলো কারেক্ট?
3 I think. Any question? Anyone? No, only single question.
ওই তো আমার কাছে আছে, আমি
Only 3. Only 3 correct answers. Only 3 correct answers.
Only 3 correct answers. So 2000 divided by 3. So 2000 divided by 3.
Masood
only
Hussain,
3 correct answer.
Masood Hussain, Dr. Shahid and Ravi Pratap.
Okay. So only 3 correct answer. Here ends the quiz. So I need feedback. How is the question? Is too easy, too tough, good, bad, ugly? And I am sure that particular part of the house I used Professor Google. So Professor Google was helping them. So clinical question, long time to get the answer. And single answer, gene, very quick. So yes, awarded kagos. আমি ডিক্লেয়ার করব, ডিক্লেয়ার করব। ও ওই প্রদেশ তাহলে একটু দিয়ে দিন পোস্টারের প্রাইস, কি পোস্টার দিয়ে দিন লাগবে।
Hello. Yeah. Thank you all students, because you are the pillars till now for this successful program. Without you all, I think so none would have given any credit to us. So thank you all students for participating till the last and interacting with all our faculties. So a great round of applause for our students, without whom I think so no program is successful. Because we know all those who are practicing pediatricians or neurologists, they have their work. Even our organizing team is not fully present. I am really very sorry for that. But thank you all. Thank you all our trade partners. I will be calling one by one. But before I should start with the AOPN award, I would request Jashodhara to announce the names, which was held on Saturday at declare prize money. So I will call upon the AOPN awards. Jashodhara call. So we will be transferring here the money. আমার কাছে নামগুলো আছে।
So yes, I call upon the dais, Supratim sir and Kalpana madam to hand over the prizes. No,
prizes to prize money. We don't require, because I will just transfer the money on the stage for them. Certificates, ma'am, everyone has, I think so everyone has taken your participation certificate, because it has been written obliquely, so we have not divided, but only the prize money is there. So first, yesterday was Mukulika Maiti, who is going to get a prize money of 7,000.
On the dais, Mukulika Maiti.
আপনাদের ক্যামেরা আনা যাবে সামনে? হ্যাঁ? তুমি ওই সবাই তোমাদের না, যাদের আমি নাম বলছি, প্লিজ তোমরা ওই ট্রান্সফারে স্ক্যান অ্যান্ড পেটা আমি করে নিয়েছো ফোনটা, আমি আই উইল ট্রান্সফার দ্য মানি। আমি তোকে এটা শেয়ার করে দিয়েছি, তুই এটা নামগুলো বলতো।
মুকুলিকা সামনে এসে দাঁড়াও না, এখানে এসে দাঁড়াও।
যশোধরা
হ্যাঁ ওইখানে এসে দাঁড়া তিনজন, মুকুলিকা, আলিশা কুজুর।
কেন আমি না এটা
আলিশা, আলিশা সেকেন্ড প্রাইজ, শান্তশ্রী ঘোষ। So Alisha Kujur please come and Shantosri Ghosh please come.
তুমি চলে এসো।
He is transferring money. Rupees 7,000 as a prize money for the first European award.
First prize goes to Mukulika Maiti.
She is from Bardhaman Medical College.
Bardhaman Medical College, na Mukulika?
Rupali Diktan.
Rupa Show. And maximum prize.
The next we call. First prize is rupees 7,000 for AOPN award paper.
7,000 rupees.
The second AOPN award paper will be awarded to Dr. Alisha Kujur from Institute of Child Health. The second prize award is rupees 5,000 for Institute of Child Health, Dr. Alisha Kujur.
Yes, Alisha please come. আলিশা ওই যে আলিশাকে টাকা দেওয়া হচ্ছে, ট্রান্সফার করা হচ্ছে।
Start on dice.
আলিশা আইসিএইচ
তোমরা না খুলে এসো, আর আমি জাস্ট অ্যাওয়ার্ড পেপারে তোমাদের অ্যানাউন্স করা ছিল।
And the third prize goes to Dr. Shantoshri from AIMS Guwahati.
Yes, AIMS Guwahati. Shantosri Ghosh.
The prize money for the AOPN award paper third prize is rupees 3,000.
So 3,000 rupees.
আপনার কাছে ইজোন অ্যাওয়ার্ড পেপার লিস্ট আছে? এরা তো জানে না, এটা তো জানে না। তারা কিউআর কোড কি করে করবে?
ওরা আসবে। বিশ্বদীপ দাস সিএনএমসি, দিব্যা তাতাচারী আর তৃষা রায়চৌধুরী সিএনএমসি, দুটো সিএনএমসি।
কি হচ্ছে না নেট নেই? We can announce the names of the East Zone. So there was another East Zone award paper session which happened today morning. So we announced the winners for that. First prize goes to Dr. Bishwadip Dash from Calcutta National Medical College.
So CNMC is flying. 2 prize today goes to CNMC.
So the amount for East Zone award paper, first prize is 2,500.
2,500. So Vishwadip is richer by, Vishwadip is richer by 2,500.
Then the second prize goes to Dr. Divya Tatachari from Command Hospital,
Command
Kolkata.
Hospital, please come.
That is for an amount of rupees 2,000.
Yes.
And the third prize goes to Dr. Trisha Rai Chaudhary from Calcutta National Medical College.
National. So
And
National got 2 prize.
The prize money is rupees 1,500.
1,500. ওইটা ফ্রি পেপার ছিল, কোনো অ্যাওয়ার্ড ছিল না।
পাঁচজন প্রাইজ পাবে
পাঁচজন ডিক্লেয়ার যা করা হয়েছে এখন
5 4 3 2 1 ওকে
ডিক্লেয়ার করে দাও স্যারকে দিয়ে দাও
স্যার
So, sir announce করবেন. So, today's e-poster, the participants are more than 30 and we have selected 5 out of 30. So, sir will declare the names.
First prize goes to Dr. Shukarna Datta from IPGMR and SSKM Hospital. Second prize goes to Dr. Shikha Sharu from Tata Main Hospital. And third prize, Srijita Vishwas from Chittaranjan Shishu Sadar. CSS. Fourth prize, Riya Ghosh from Medical College, Kolkata. And the fifth prize, Dr. Saurabh Rai from IPGMR and SSKM Hospital.
হ্যাঁ এদের সবার সাথে অর্গানাইজিং টিমের সামনে চলে
Again, CSS. Tata Hospital, Tata Main Hospital. Swarup
এটা লগ ইন করতে দিচ্ছে না আচ্ছা
Prize money for e-poster. Yashodhara, prize money for e-poster.
That will be announced by
প্রাইজ মানি অ্যানাউন্স করে দিচ্ছি
হ্যাঁ first prize for e-poster was 5,000, second was 4,000, third was 3,000, fourth was 2,000 and fifth was 1,000. So there were, because multiple candidates we gave. তোমরা বসো আমি প্রাইজ মানি ট্রান্সফার করছি
So, Sukarna Datta got 5,000. Your Shikha Swarup from Tata Main Hospital, 4,000. Srijita Vishwas from Chittaranjan Seva Sadan, Shishu Sadan, 3,000. Riya Ghosh, Medical College, 2,000. And Saurabh Rai, 1,000, SSKM.
আচ্ছা আমি ট্রেডেডটা দেখে নিই I have to transfer the quiz money also price না ওটা আমাকে টোটাল করতে হবে আচ্ছা
So,
now
electronic transfer takes some time. So, in between.
so now we will start our valedictory second round, that's our trade partners. So I will call upon one by one. Can we have Sun Pharma team, Sun Pharma Neuro on that stage,
Sun
please?
Pharma Neuro.
Sun Pharma Neuro. ওখান থেকে নিয়ে নে Sun Pharma Neuro. আর কেউ নেই আপনাদের So Sun Pharma Neuro, great round of applause for Sun Pharma Neuro. Next is Cipla Neuro. Anyone from Cipla? Thank you. Next we have Linux. Linux, anyone from Linux? Apex Laboratories. Apex Laboratories. Next, VEPA. Unipath. সুশান্ত তো চলে গেছে আছে তো সুশান্ত কেপলার Kepler, then MSN. After Kepler, MSN. Then we have Dassault. Dassault. Nutrigold after Dassault. Nutrigold. Torrent Pharma, Neuro Division. এটা কি প্রাইজ মানিটা কুইজের Altius. Anyone from Altius? LaLpath Labs. LaLpath Labs. Pavier. না এটা আগে ওদের দিদি হ্যাঁ ওই ওদেরটা দিদি LaLpath Labs হ্যাঁ Pavier হ্যাঁ হ্যাঁ দিদি গেলে হবে Reddy's Laboratories Neuro Division Lupin Neuro Division MedGenome after Lupin MedGenome MacLeod's after MedGenome MacLeod's কোনটা হ্যাঁ হ্যাঁ লাগে দুটোই ঠিক আছে না না আনাবো Celegenex Intas, AstraZeneca, Icon Life Sciences, Newburgh, টরেন্ট এখানেই আছে, কিছু সার্টিফিকেট এখানে পড়ে আছে। নিউবার্গ এসছে, নিউবার্গ, শিল্ড, শিল্ড, anyone from Micro, Juventus, Gene Life Sciences? কেউ আছে? Micro, Gene Life Sciences, Juventus. Micro Life Sciences, Gene Life Sciences, Juventus. আচ্ছা। Acha, now I would request our two anchors, Charlene and Shukanna. না না আরো আছে, ওগুলো লাগবে না, এগুলো দেবো না না না, ওদের শুধু এমনি এই দুটো ঠিক আছে। ওটা দাঁড়া, এটাকে শেষ করি, ওটা নিয়ে মাথা ঘামাস না, থাক থাক ওগুলো থাক। Charlene, আচ্ছা, both are coming here. Sir, আপনি আর যশোধরা। Shukanna, thank you both for staying for 2 days with us. Now I would request Beladi. Her job is being now reduced day after day. She's cash collection is coming down for Didi. Didi কদিন পরে অঙ্ক ভুলে যাবে। Thank you Didi. সুশান্ত দা আছে? এই তো সুশান্ত দা আছে। রোহিত কোথায় গেল? রোহিত, সোমনাথ দাটা রোহিত নেবে। আচ্ছা, এদিকে এসো। সুশান্ত দাও, থ্যাংক ইউ সুশান্ত দা। Rohit, you will collect your papas also. Very good. First for your papa. Thank you. So সোমনাথ দার জন্য রোহিত কালেক্ট করবে, সোমনাথ দা বলে গেছে। And also he will collect for his whole team. Please call your whole team. So all three of you come. তোমাদের নাম কি ওই এই দিয়ে চলছে, আর কোনো নাম আছে না? কিছু নাম আছে? রোশনি। So a full audiovisual stall. Thank you for a wonderful job. Audiovisual was very good. I would call someone from LaLit Great Eastern. Please, LaLit Great Eastern. আর কেউ নেই? ওই তো, Thank you, Lalit. Very good service. We were really satisfied. I think so. Orijit sir wants to say a really great service. So now I would like to call upon our two photographers. একজন একজন করে আসুন, আমি নাম জানি না কারোরই। সৌগত দা, প্লিজ। ম্যাম গ্রুপ ফটো কি নাম? অরূপ সিনহা, মিস্টার অরূপ সিনহা। তিমিরারি বাবু, উনি আমাদের, থ্যাংক ইউ। মিক্সড জব বাই হিম, সব কিছুতে উনি ছিলেন। এই যাদের প্রাইজ নেওয়া ছিল তারা কোথায় গেল? সবাই চলে গেল প্রাইজ না নিয়ে? অ্যাওয়ার্ড পেপারের প্রাইজ এগুলো আমি তো ট্রান্সফার করিনি, সব চলে গেছে? হ্যাঁ, আচ্ছা। এই আলি কে কে আছে তোরা প্রাइज पाबी আমাকে बोले जा। इसको प्राइस क्या है तुम्हारा? कोई प्राइस है? क्विज में लास्ट में दे रहा हूँ, क्विज तो मैं कैश ही दे दूंगा, कोशिश कर रहा हूँ, देख रहा हूँ। कत बोलो ना ना नंबरे হবে না, नंबरे পারবো না। হ্যাঁ পিআরএস কেন বলেছি কিনা স্যার একবার ছবি উপরে চলে আসুন। সুদীপ একবার ছবি একটা তুলে দিন, জনগণমানকে শেষ করতে হবে। তুই তোল তোল, আমি ওই টাকাগুলো ট্রান্সফার চলে বাড়ি যেতে পারবো না, আমার হোটেলের পেমেন্ট আছে। তুমি রাখো রাখো না, 2 মিনিট দাঁড়াও, এদিকে তুমি দাও না, করো না তোমরা। এই চলে চলে 2 মিনিট দাঁড়িয়ে যাও, এদিকে চলে তোলো না আমি আছি। আরে এসো না, তোমাকে ছাড়া হবে না। সুদীপটা একবার কি তাকাও, সুদীপটা একবার কি তাকাও, ছবিটা তোলা হয়ে যায় তো 2000 তো কি নাম? সুদীপটা একবার কি পোস্টার সেকেন্ড পোস্টার কি নাম রে? দিব্যা তাতাচারি।
এই পোস্টারের কাগজটা আছে, প্রাইজের কাগজটা ঠিক আছে, সেকেন্ড প্রাইজটা তাহলে
চলে গেছে, দেখে নে। আর কার প্রাইজ মানি বাকি আছে? ও এরা আছে, চলে এসো। পেয়ে গেছিস? হেই ডিড ইউ গেট দ্য মানি? এই সবাই প্রাইজ নিয়ে যাস না, আমি ভুলে যাবো।
सिंधु गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय 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 जय